this is the 33rd conference of API Bihar chapter and second East Zone conference of East Zone Apicon, Ezapicon. And to inaugurate the scientific session, may I request Dr. Paul, our respected Dean, ICP Indian College of Physicians, and also the President-elect, and to inaugurate this scientific session.
Thank you. It is really our privilege to be here in Bhagalpur, the Silk City, and I congratulate Professor D.P. Singh with blessing of Professor B.B. Thakur. He has successfully conducted 33rd Bapicon and second Ezapicon. And this is a session. I hope all the postgraduate faculties members will gather here and will learn a lot in the next 2 days and will be updated with the modern medicine. Thank you. With this small word, I congratulate and wish best successes. Thank you.
परम आदरणीय प्रातस्मरणीय डॉक्टर बीबी ठाकुर साहब, डीन आईसीपी डॉक्टर ज्योतिर्मय पॉल, प्रेसिडेंट एपीआई बिहार डॉक्टर बीके सिंह, डॉक्टर डीपी सिंह, past Dean Dr. Alka Deshpande, my dear friends. It's my immense pleasure to be here at the inaugural ceremony of scientific session of 33rd Annual Conference of Bihar Chapter and second Conference of East Zonal Conference. It's a wonderful feeling to be here at this ancient city of Bhagalpur. I'm highly grateful for all my friends, to my most respected Dr. Thakur sir, to invite me on this prestigious event. I'm sure this conference will set a milestone in the history of Bihar API and to promote the academic excellence. Thank you so much.
On behalf of the Bapicon 33rd and the EZ Epicon, under the patronage of our Bishop Pitama, Professor B.B. Thakur sir, under the guidance of our national leaders, the dynamic, young, I will say, the two duos of the API, Professor Girish Madhur sir and Dr. Paul, they have changed the concepts of the API, I think, this year. Many things have been introduced under the guidance of the seniors and the committee which was formed earlier, and we are yet to see many, many more things. I am thankful especially to Madam Professor Alka Deshpande, who despite her age and problems, and she fell down and had injured herself, but still she came. So thankful to you, so kind of you. And everyone else, Kulkarni said कि यार जो सलमान खान टाइप आए हैं कल, कि मैंने कह दिया आएंगे तो आएंगे, चाहे जैसे भी होगा, जिधर से होगा, डूब जाए एयरपोर्ट, डूब जाए, मैं पहुंचूंगा जरूर. और पहुंच गए यहाँ पे. संग्राम इज हियर. संग्राम इज ऑलवेज फाइटिंग विद संग्राम्स, but he is our brother. So both the name signifies always fighting and for the spirits. Welcome Dr. H.K. Singh sir, the father figure of diabetes in Bihar, and Madam Nandini Chatterjee. आपने जो नहीं तो कुछ बोला ही नहीं, आपने प्रेजेंस ही होने कुछ. So I welcome all my friends. My chairman is here. So friends, thank you all. Thank you. Enjoy this feast.
I would like to have few words of blessings from Madam Alka Deshpande. कल इन्होंने कहा कि डीपी मैं जानता कि तुम ऑनलाइन भी हमें जोड़ सकते तो मैं ही नहीं आता. इतना आर्डुअस टास्क था. पटना से यहाँ आना 7 घंटे लगे उन्हें. एक बार जोरदार तालियों से इनका जरा प्रोत्साहन दे दीजिए. इन्होंने कोई गलती नहीं की हम लोग के पास आकर के. आते Yeah, madam. Madam is so smart, so youthful, so energetic. Age.
I think this Silk City attracted me, and more so by brother Dr. D.P. Singh's invitation and persistence, and Dr. Sharma's persistence that I had to come here. But when I came here, I was little disappointed that instead of Silk City, now it has been changed to Smart City. So it's a good change, but still I would like, as a woman, I would like prefer a Silk City. So thank thank you very much for all your love and affection. Thank you, sir.
Sir, without the blessings of Dr. B.B. Thakur, sir, just bless few words, sir.
Oh, friends, I am actually delighted, honored, without any words. I have no words to express my feelings for my honorable president, whom I have been treating like my son, if not, if he doesn't mind. Similarly, Dr. Paul Kulkarni has been very dear to me. Brother, madam, say, so it is it's a peculiar meeting where the whole nation has come. Not with all difficulties, from Calcutta to by train, by president, by dean. Madam, 7 hours of journey from Patna. Similarly, Kulkarni from Mumbai, Brother from Gulbarga. So friends, this only speaks of very high esteem of my friends, very high desire to promote medicine, and I will talk regarding their quality in the evening, if I am permitted to, in inauguration, what quality our president and dean has got and where API is expected to go. Thank you very much. And regarding Ezapicon, the first Ezapicon was held in Muzaffarpur in 1993, which I could not do because I was directed towards API, but then with the help of this young, dynamic, futuristic Dr. Paul and Dr. Mathur, I thought, why not to revive it again? And they have been very kind to agree to it. We are going to have a general body meeting of those who are from Eastern Zone, and if I correctly remember, note, many of the Eastern states representatives have come. Northeastern states have come, and we welcome them all, and thank you all for asking me to speak something
Thank you so
which
much.
was not needed of me.
Wonderful. Thank you so much. Let's have a big round of applause for sir, for sure. And with the permissions of our organizing chair.
Thank you very much, sir. Sir.
Yes,
Before
we
we
can.
leave the dais, there's an announcement. We must congratulate him. He had a marriage anniversary last night. No, we will be celebrating that on the dais itself. During the inaugural function.
After the
During
inauguration,
function.
there is a.
Yes, sir. Sir, we have already.
अरे
लाया है सर, लाया है. तो सब लोगों को तालियां बजानी चाहिए इसमें जोर से. And from all of our side, we wish you a wonderful anniversary. And taking so much of trouble. Sir, he is here.
he's planned it accordingly. How many years of? All right. With that, we've got a few surprises lined up in the evening as well, but we would like to get started with the scientific session. Can I request our chairpersons to please join us? We have Dr. Alka Deshpande, Dr. Professor A.K. Sinha, Professor Dr. K.D. Mandal, Dr. Ajay Sinha, Dr. Satish Chandra, and Dr. D.K. Thakur. At the same time, to save a few seconds, can I request our speaker, Dr. Nandini Chatterjee ma'am, to also please join us on the dais. The time allotted is 20 minutes. The timer is going to be set for 17. The buzzer is going to be ringing in 15 minutes and 3 minutes for discussion. Thank you so much. I hope that's okay, ma'am. 17 minutes timer, which is going to be on the screen as well. Buzzer will be
Good morning, everybody. And we are starting a session with a very beautiful, charming professor of medicine from Calcutta. As she is so charming, she is also very active in academics. She is editor of quite a few journals and books. And today she will be talking to us about the changing spectrum of vivax malaria. There are many factors which are changing the clinical profile of infectious diseases, and therefore it will be great to listen to her about vivax malaria. Dr. Nandini, all yours.
Yes, thank you, madam, and good morning to all. It is a privilege to be standing here and delivering a lecture in front of the likes of Professor B.B. Thakur and all the leaders of our Association of Physicians of India. The topic today allotted to me is the changing spectrum of vivax malaria. Now, vivax malaria or malaria as an entity has been known to us for centuries, since 2700 BC. It was reported in Chinese literature then, and after that, after path-breaking discoveries by Charles Lavarenne and Ronald Ross in the 19th century, the Anopheline mosquito and the Plasmodium parasite have been designated as the causative factors. However, malaria has come a long way from those days, and there has been several ups and downs in the epidemiology of malaria. But what is very notable is that within the time period of 2000 to 2019, due to the remarkable activity of the malaria control programs, there has been almost 72% drop of the cases of malaria, and the death has also been reduced by 74% in India. As per the World Malaria Report, 247 malaria cases are reported at 2021. But the thing I will be dwelling on today is that the ratio of the falciparum malaria to the vivax malaria is sharply dropping from 2.9:1 in 2010 to only 0.6:1 in 2021, which means that vivax malaria is gradually becoming more and more predominant. There have been 3.6 million cases of vivax globally, and India bears the largest burden. And most of these cases have been concentrated in the states of Orissa, Chhattisgarh, Jharkhand, Madhya Pradesh, and Maharashtra. Having said this, I come from West Bengal, and it is also burdened with cases of malaria, and that too, the predominant one being Plasmodium vivax. Now, the epidemiology of malaria depends on several factors: the biology of the parasite, the behavior of the vectors, susceptibility of the host, and the influence of climatic situations. I will be touching upon these one by one, but first let me talk about the clinical scenario which is presented by vivax malaria, because that is the thing that we physicians face first. Now, the clinical presentation is becoming more and more atypical these days. As we know that for vivax malaria, relapses are the main problem, and 1/3 of the cases have a history of previous malaria. But the problem is that many of it may be asymptomatic or subclinical. What is very worrying for us physicians is that there is an increase in the prevalence of severe malaria with Plasmodium vivax, which used to be the forte of falciparum in the past years. Chills and rigor, high-grade fever, these are not often seen. Fever lacks periodicity, so your patient will come with a continuous fever and will resemble all other etiologies of acute febrile illnesses and may confuse the physician. So the changing clinical profile has been studied by various people, and it has been found that atypical features like lack of taste, sore throat, cough, vomiting, these may be the presenting complaints of a Vivax malaria patient. So to emphasize what I have been saying is that global incidence of Vivax is increasing, and Vivax is becoming the predominant cause of severe malaria. Several studies have been done across the country, and the percentages, however, are ranging from 8.8 to 78.9, which means there's a diversity in the burden of Vivax across the country. One study I am quoting, which has been done in and around Kolkata, where 900 cases of Vivax were included, and there it was found that 22% of the cases presented with severe disease. So this is a very important and worrisome figure, because it also has a overall high mortality. Now, the features of severe malaria are well characterized and designated, but who is the culprit in the present day? Is it falciparum or Vivax? The question has come up that how benign is benign tertian malaria, and the answer, as I have already shown, means that it is not at all benign, and there are a host of complications found with Vivax malaria. This list shows that Vivax malaria is known to affect almost each and every organ system of the body. And the risk factors for this seems to be the presence of comorbidities, co-infection with falciparum, pregnancy, delayed diagnosis, and delayed admission in a hospital. So what are the complications that are mainly coming to us? Severe anemia after relapses, thrombocytopenia, pancytopenia, and even cases of HLH. Respiratory complications like ARDS are commonly encountered. Renal complications like acute kidney injury, even little uncommon complications like HUS-TTP are being seen. And lastly, but not the least, cerebral malaria. Cerebral malaria has always been known to be occurring in falciparum, but now Vivax is coming up with cerebral malaria, and it resembles any other case of acute encephalitic syndrome. So we have to have a high amount of suspicion in our minds and send the investigation stat whenever a patient comes with fever with altered sensorium. It is to be noted that apart from the drowsiness and seizures, patient may have certain atypical presentations like cerebral venous thrombosis, edema, and even malarial retinopathy. Patient can develop blindness, hemorrhages, papilledema. Now, various studies across the world have implicated Vivax to cause different types of complications. Studies around Delhi have said that thrombocytopenia and hepatic dysfunction were the commonest, whereas other studies from Africa, Indonesia are saying that ARDS is the most common. So whatever it may be, what we clinicians need to remember is that Vivax is no longer benign, and we have to be very cautious in dealing with it. Now, the exact causes of the changes in the clinical profile of Vivax is uncertain, and there are many studies going on to ascertain that, but the genetic alteration in the parasite has been implicated as one of the very important causes. The changes in the vector biting habits and drug resistance are also being put forward as causes. So why is Plasmodium vivax becoming so predominant? One important factor is that the efficient transmission of Plasmodium vivax via the mosquitoes because of frequent relapses. Because of a relapse in the blood, there is transmissible gametocytomia, and therefore, even before clinical presentation, that person is a carrier of infection and can transmit the disease. The early evening biting habits and outdoor resting of vectors is another important cause, because the impact of bed net distribution and indoor residual spraying is becoming useless, because the mosquitoes are biting in the daytime or afternoon. It is also difficult to detect Plasmodium vivax by the rapid diagnostic test. Why? Because the level of parasitemia is less in vivax, and a minimum threshold is required for detection in the RDTs. Moreover, there is a high proportion of asymptomatic carriers, people who are not having fever, but they are having the hypnozoids hidden inside their livers. So they are potential transmitting agents. The third, but maybe the most important factor for Plasmodium vivax becoming important, is the lack of radical treatment. As we know that in order to control the hypnozoids, we need to give a 14-day course of the primaquine, and this is often missed. Healthcare providers are prioritizing the treatment of the fever and may not prescribe the primaquine. People may not adhere to the 14-day course. Sometimes, because of fear of hemolytic reactions, people may be prescribed suboptimal doses. There may also be polymorphisms in genes in people where active primaquine metabolites are not being formed. So all these factors ultimately is halting the radical treatment of vivax and the persistence of the hypnozoids in the liver, which can lead to transmission. This slide is actually a repetition of what I have said, that both asexual and sexual parasite stages in the peripheral circulation remain in vivax due to relapse, and that has an impact on increased transmission of the disease. Now coming to other factors that has led to these changes and the predominance of vivax, one of them is the vectorial dynamics. So migration of different malarial vectors and colonization in new habitats is occurring. It is so rampant that Anopheles minimus, which was a mosquito usually found in the hilly northeastern states, are now being found in the South Indian states. Moreover, the vectors are also resistant to the insecticides like DDT and malathion. Urban settings, there is much of constructional and developmental activities going on, and that leads to increased vector densities. So in a way, more mosquitoes, more transmission of malaria, and more vivax. Now, it is very difficult to control these vivax vectors because it has a high diversity and different response to different insecticides. That is also an important thing. Vivax can complete its development in the mosquito at lower temperatures. So what is happening is that in the hilly areas, temperate areas, falciparum cannot become prominent. The vivax is having a good time. Effect of climate again is very important. We are all aware that there is global warming. Therefore, districts in the Himalayan foothills, which used to be much colder before, are having 1 to 3 months more of transmission because their temperature range is very amenable for the development of the parasite inside the mosquitoes. Lastly, but it is also very important, is the resistance pattern. Now, when the parasitemia persists in the blood after 3 days, we have to suspect whether the infection is resistant to the drug. Now, it is important to note that resistance in Vivax is much lesser than falciparum, and it is not as rampant in India as in other parts, but we should be aware. Vivax has developed chloroquine resistance much slower than falciparum, but is being reported from countries like Indonesia, Thailand, Cambodia, Ethiopia, and Americas, even in Malaysia. However, reports from the Indian subcontinent is much more reassuring. Here it has been found that though therapeutic failure has not been reported, there have been reports of reduced clinical efficacy because of mutation in the molecular targets. So I have come nearly to the end of my talk. So we have seen that we have to deal with Plasmodium vivax very effectively now, and the challenges in dealing are due to the fact that vivax has a reduced biomass, means a low range of parasitemia in the blood. It affects the reticulocytes. It produces transmissible gametocyte and can relapse with the hypnozoites. There is also difficulty in differentiating between a treatment failure and a relapse. So surveillance of vivax is also challenging because of lack of resources. So these are all the hurdles that we have to face. To sum up, the clinical profile of vivax malaria, hotspot of incidence, and transmission dynamics are all altering. Enormous diversity are seen in the species, in the genetic structure, in the expanding parasite populations, resistance to insecticides, and drug resistance. All these are hallmarks of malarial outcome. Awareness and effective surveillance are of prime importance, because if we need to fulfill the ambitious global targets of the WHO by 2030, we need to be aware and cautious. Thank you.
Thank you. Dr. Alka, your comments?
Any questions? Questions from the audience?
I believe the presentation was so well thought and presented. No questions then.
It
So
was an excellent presentation. Up till now, we were only thinking about falciparum as a severe malaria with all the complications, but the same complications are now being seen with vivax malaria. Not only that, the clinical profile is changing, and many a times there are patients without fever and without any recurrence or relapsing type of a fever, then it is difficult to suspect these cases. So I congratulate Dr. Nandini for an excellent presentation. And if there are no questions, I think we would move on.
Thank
Yes.
you.
so
Thank
much.
you very much, madam.
we have Dr. Sangram Biradar next, and requesting him to please join us on the dais.
I welcome Dr. Sangram Biradar, who is the professor and head Department of Medicine, very active in academics, organizing many webinars and seminars and conferences. A very active member, not only at a state level, but also at a national level. He is a member of Governing Council of API, and today he is going to talk to us on a very, very important topic of thrombocytopenia and its clinical implications. Nowadays we do routinely CBC in each and every patient, and we get profile of thrombocytopenia, but its clinical implications in a true sense will be enlightened by Dr. Biradar. May I invite him to start his oration?
Thank you, madam, for your kind words of introduction. At the outset, let me thank the organizing committee headed by Dr. D.P. Singh and M. Shankar Sharma for giving me an opportunity to be part of this prestigious Bapicon 23 conference held in beautiful city of Bhagalpur. With the blessings of patron Dr. B.B. Thakur, our leaders, Dr. Mathur, API President Paul, Dr. Jyotirmay Paul, Dean. The topic allotted to me is a simple, basic clinical medicine topic, clinical implications of thrombocytopenia in febrile illnesses. As as told by Dr. Shankar Sharma, there will be a lot of postgraduates which will be helping for them. So I see hardly any postgraduates, but anyway, yeah, no problem. Because all are allied speakers. So the theme being the blending science with art of medicines and basics in clinical medicine and helping the others. So, yes, sir. Yes, sir. Sure, sir, sure. Thank you. Yes, sir, yes, no problem. Definitely, sir, definitely. So the topic being thrombocytopenia and febrile illnesses. A little basics of thrombocytopenia, as everybody is aware, what is thrombocytopenia? A subnormal number of platelets in the circulating blood. Fever with thrombocytopenia is a common problem in India. It has an infectious etiology. Many undifferentiated febrile illnesses mimic infections such as dengue, enteric fever, malaria, leptospirosis, and influenza as well. Certain non-infectious causes like primary hematological disorders may present with febrile thrombocytopenia as well. The hematological aspect, as everybody is aware, a normal platelet count ranges from 1,50,000 to 4,50,000 cubic millimeter of the blood. Often patients with thrombocytopenia are asymptomatic and diagnosis made on routine complete blood, simple basic blood count, CBC. Occasionally present with bruising, purpura, petechiae, nose bleeding and gum bleeding as well. So rarely platelet count may be as low as 5,000, predisposing the patients to life-threatening bleeding in the central nervous system or from the gastrointestinal and the genitourinary tracts. So what are the common causes of thrombocytopenia? As everybody is aware, one being the decreased platelet production itself, common being the vitamin B12 and the folate deficiency, certain leukemias, bacterial or viral infections and hereditary diseases are quite common. The other important common causes being the increased destruction of platelet itself by mainly the idiopathic thrombocytopenic purpura causes or a thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation, paroxysmal nocturnal hemoglobinuria, systemic lupus erythematosus, antiphospholipid syndrome, post-transfusion purpura, and hypersplenism. So these are some of the important causes of thrombocytopenia. The other being the drugs which we come across and everybody uses in everyday, day-to-day practice. There are certain common drugs like quinine, valproic acid, methotrexate, carboplatin, interferon, isoterideron, and heparin. These are some of the important drugs which are being used. And the important diseases which we come across being the malaria, leptospirosis, rickettsia, septicemia, typhoid, borreliosis, and arboviruses such as dengue or yellow fever, and rodent-borne viruses such as Hanta and Lassa fever, human immunodeficiency viruses, and hemolytic uremic syndrome. So these are some of the important causes of thrombocytopenia. So that's why a thrombocytopenia in fever acts as a prognostic factor, can predict the cause, thus helps in early diagnosis and treatment, help in preventing further fatal outcome associated with intracerebral bleed, hemorrhage into vital organs, and shock. So with this background, we conducted a study of thrombocytopenia in our institute, where a case material of 160 cases presented with less than 1 week fever we took, where platelet count was less than 1,50,000 and the age was more or less equal to 18 years. The exclusion criteria of those on long-term medications causing thrombocytopenia, heparin, rifamycin, carbamazepine, acetaminophen, or with other chronic illnesses like SLE, ITP, chronic liver diseases, malignancies, autoimmune diseases, previously diagnosed with leukemia, myelodysplastic syndrome are excluded in our study. So what were the results we noticed? Out of 160 patients with febrile thrombocytopenia, 91 were male, 69 were female. The maximum number of cases were in the age group of 21 to 30. Infection was the established diagnosis in 88.125%. The common symptoms which we came across were the myalgia, the headache, the signs of pallor was prominent, platelet count was ranging from 50 to 1,00,000. The other being observations which we made were 12 patients were in the range of 10,000 to 20,000 platelet count, 8 cases were below 10,000, 53 patients with bleeding manifestations were seen, 43 patients had spontaneous bleeding. So bleeding tendency is correlated with the lowest platelet count during admission, and maximum tendency was noted with platelet count less than 20,000 per cubic millimeter. The other observations were, of the 85 cases of dengue, 28 had bleeding manifestations. Of the 25 cases of malaria, 4 had bleeding manifestations. Of the 14 cases of septicemia, 9 had bleeding manifestations. And of 9 cases of enteric fever, no patient had any bleeding manifestations. Whereas 1 case out of 4 mixed infection had bleeding manifestations. So these were the laboratory values which we correlated. Anemia was seen in 72 cases, leukopenia in 50 cases, leukocytosis more than 11,000 in 18, and abnormal renal functions in 21 cases. No cases of polycythemia due to hemoconcentration were seen in dengue fever patients. So this was the diagrammatic representation which we studied, where the distribution of platelet bleeding tendencies used based on the platelet count. This was the total number of cases and the bleeding manifestations. Up to 8 cases, platelet count was 10. Total number of cases were 12, where platelet was 20,000. 49 patients, 20 to 50, and total number of cases 91, where platelet count was more than 50,000. So this clearly demonstrated the ratio of platelet with the other results. There were maximum increment in the mean platelet count was on day 5 of the admission persistently, and the decreased platelet count was seen in 13 patients. The platelet transfusion was given in 42 patients. 108 patients did not show any major complications, and 52 patients had notable complications. So these were some of the important distribution of the viral various clinical symptoms which we came across. Fever was seen in 160 patients, myalgia, arthralgia, rash, headache, bleeding manifestations, pain abdomen, nausea and vomiting, jaundice, loose stools, cough and dyspnea, oliguria, altered sensorium. So these were some of the important distribution of the various clinical symptoms in the febrile thrombocytopenia which we came across. And this was the distribution of the lowest platelet count during course of hospitalization which we came across, where platelet count was less than 10,000 in 8 cases, 10 to 20,000 in 12 cases, 20 to 50,000 in 49 cases, 50 to 1 lakh in 63 cases, and 1 to 1.5 lakhs in 28 patients. And we also saw acalculous cholecystitis was also seen in as a common complication in dengue fever. Of 160 patients, 148 patients had a good recovery, 8 patients expired, and 4 were referred to higher centers due to some other causes. In the case of septicemia, there was 5 mortalities out of 14 cases. In dengue cases, we had mortality of 2 out of 85 cases. 1 patient out of 9 of falciparum malaria was also expired. The range of platelet count in the mortality case was less than 10,000 in 2 cases, followed by 21 to 50,000 in 4 cases, and more than 50,000 in 1 case, and 10 to 20,000 in 1 case. So all the expired patients had hypotension, abnormal renal functions, and acute respiratory distress syndrome as well. So this was the correlation of petechiae, purpura, and the spontaneous bleeding with thrombocytopenia we came across, where the platelet count of number of cases up to 10,000 were 8, which 7 seen were the petechiae and purpura, 8 spontaneous bacterial peritonitis was seen in 5, whereas in platelet of 10 to 20, total cases were 12, petechiae had 10, other spontaneous bleeding in 5, platelet of 20 to 50, 49 patients, and petechiae bleeding tendencies were more than 50. These were the observations which we came across. The other observation what we did was the distribution of platelet count and the etiology. So etiology was mainly the dengue, number of patients were 85, where platelet was less than 10,000 in 5, 10 to 27, 20 to 50, 27, more than 50, 46. So likewise we saw in dengue, malaria, septicemia, leptospirosis, hematological conditions, other associated diseases like AML, megaloblastic anemia, viral hepatitis, DIC, and unexplained causes were also seen, where the distribution of platelet count with the etiology was made out. The other observation we made was the laboratory and the etiological profile of febrile thrombocytopenia cases. Like lab parameters, anemia was seen in 21 patients of dengue, 15 malaria, AML4, septicemia, DIC, megaloblastic anemia. So likewise, anemia, leukopenia, leukocytosis, renal function test, abnormal SGPT, and abnormal bilirubin observations were studied. And this was the complications in febrile thrombocytopenia which we came across. 108 patients had 108 patients had nil complications, 21 had acute kidney injury, hepatitis was seen in 29, acalculous cholecystitis was seen in 16 patients, ARDS in 5 patients, dengue hemorrhagic fever in 6, dengue shock syndrome was seen in 2 patients, polycirrhosis in 9, CNS complications were observed in 4, and myocarditis was seen in 2 patients. So this was a graphical representation which we clearly showed according to the main platelet count on follow-up days, overall comparison of the platelet count as per the Friedman's test, where on admission platelet on they went on day 1, day 2, day 4 and day 5, which clearly trends of platelets count in our study showing continuously rising in 55, initial fall and then rise, persistently low was seen in 8%. So mortality depends on the severity of the disease, diagnosis made, available treatment and care, the time of initiation of the treatment, and associated other medical illnesses as well. So mortality can be reduced by early and right diagnosis and timely and effective treatment of care. In future, various pathological and microbiological imaging modalities should be needed for research and diagnosis of many viral hemorrhagic fevers. So to conclude, thrombocytopenia, a basic, simple, bedside CBC examination in this era of high-end investigations or the digitalization of the all investigations, a simple CBC count will tell us thrombocytopenia, a common observation in hemogram, needs a systematic evaluation to find out the underlying cause, which can be of infective or not. Thrombocytopenia may not have a bleeding manifestation and may be asymptomatic at initial presentation. However, in few cases, it may lead to severe bleeding, which may be life-threatening for the patient as well. So platelet transfusion should be considered in all patients with platelet count below 20,000. Hence, the prompt diagnosis and immediate specific treatment of underlying etiology of febrile thrombocytopenia with maintenance of platelet count and hemostatic function give a good recovery. So infections such as dengue fever, malaria, enteric fever, septicemia, leptospirosis, and non-infectious causes such as megaloblastic anemia are usually associated with febrile thrombocytopenia. Thank you for patience hearing. I will be happy to take any of the questions. Thank you. Thank you. Yeah.
Can you predict, because the thrombocytopenia, leukopenia, it is a feature of various viral diseases. So can you predict alone from CBC alone that it could be a case of dengue?
That's what we showed now. Whole study what we did was we studied basically platelets in all diseases. That's why platelet count is a prognostic marker as well.
Platelet count is diminished in many viral diseases.
Yeah, that's what.
But is there any red cell indices other than platelet, which combinedly you can say this could be a case of platelet,
Dengue. No, we cannot say like that. The platelet count is decreased in so many causes of febrile thrombocytopenia. It may be a marker. Follow-up studies will tell us definitely that we are heading towards dengue or towards malaria or towards this.
You have to go to various details.
Yeah,
Just I wanted to know some RBC indices other than platelet. Along with that, we can predict how you dengue है. ऐसा नहीं.
No. We should have a serological diagnosis to confirm.
Yes. Okay, sir. Thank you.
Thank you.
With that, we conclude the session. Can I request the speakers and the chairpersons to please join us outside the hall for the felicitation ceremony? Dr. Nandini, Dr. Sangram, if you could please join us. We would like to present a memento, a bouquet, a shawl, just at the... Dr. Sharma sir is waiting for you. Yes. Sab aa rahe hain. In the meanwhile, we would like to move to our next session. I would like to thank the speakers because they have concluded it 1 minute before time as well. And to move to the next one, can I request the chairpersons to please join us? We have Professor B.B. Thakur, Dr. Jyotirmay Pal, Professor A.K. Pandey, and Dr. P.B. Mishra as the chairpersons. To save time, can I also request our first speaker, Dr. U.C. Jha, to please join us on the dais. And again, just a gentle reminder, total time is 20 minutes. Timer will be set for 17. A buzzer will ring on 15 and 3 minutes for discussions. Yes, sir.
Slide आगे बढ़े.
Without wasting any time, sir, Dr. U.C. Jha, mic behind you, sir. Dr. U.C. Jha is a great clinician, great academician, professor and head of the department of. Hello. Yeah, a great clinician, a great academician, and professor and head of Department of Medicine, one of the premier colleges of Bihar, which was established long back as a school, and then it became college, Darbhanga Medical College, and he is going to talk on such an important topic. In spite of a lot of development in the type of insulin, quality of insulin, quality of delivery system, our type 1 diabetic are only 20 to 30% controlled. So adjunctive therapies are the need of the hour. And on such an important topic, he is going to deliberate. Let us welcome him with a holding hands and clapping.
Thank you, Dr. B.B. Thakur sir. Thank you very much for introducing me as a speaker in this August gathering. One thing I want to express the organizers that they have given opportunity to speak me on this platform. I have an emotional attachment with this city because I got entry in the medical from this city only. The center of entrance examination was this medical college, and I got entry in this profession with this. And from the first year student up to this, up to this post, I have reached. Okay, thank you very much. Now, the topic, the type 1 diabetes. Everyone knows it is a beta cell dysfunction, absolute or relative destruction of beta cell. And gold standard of treatment is insulin. And in that, the multiple basal bolus insulin. Everyone knows what is the issue, why we are in search of adjunct therapy. We have to understand this, what is the issue? The issue is that simply on the patient level and also on the pathophysiology of type 1 diabetes. Everyone knows type 1 diabetes due to beta cell dysfunction, but not the beta cell alone. The alpha cell dysfunction is also important for the pathogenesis of type 1 diabetes, along with amylin and somatostatin. So the whole pancreas, the islet cells containing alpha, beta, delta cells and PP cells is responsible for the pathogenesis of type 1 diabetes. And this is the issue. We are in the search of adjunct therapy which can control these other hormones who are counter-regulatory hormones. All they cause is hyperglycemia. This is the issue on the pathogenesis basis. On the patient basis, the issue is insulin is always unacceptable. Multiple injections. Every patient don't want to take insulin. They always request us, sir, something else you can prescribe, that will be better. Number one issue. Number two issue, no, you have to take insulin. Insulin is the gold standard. So what are the complications of insulin therapy? Multiple injections. Then insulin is lipogenic. And so the type 1 patients having insulin injections, they weight gain. And gain in weight is unacceptable in young persons and also causes insulin resistance. Number one bar. Number two, that in aim to achieve the target, we give over treatment and there are frequent attacks of hypoglycemia. Or to prevent the overweight, patient takes under insulin. So there are more chances of hyperglycemia and life-threatening fatal complication, diabetic ketoacidosis. These are the issues. So we are in search of the adjunct therapy. What are these therapy? We will take one by one. What the options left? The drugs which are used for the treatment of type 2 diabetes. And different drugs have been tried in type 1 diabetes along with insulin, and their efficacy and safety has been studied a lot. But till date, no drug has been approved or has been labeled effective till date. Only the hope is immunotherapy. So, for adjunct therapy, we have to see this benefit and risk balance. Adjunct therapy should be effective, should be better glycemic improvement, should improve weight control, should lower insulin dose. What are the risks? Increased hypoglycemia, increased GI side effects. So we have to outweigh the benefit and risk of different drugs so that we can prescribe in type 1 diabetes along with insulin. Why might non-insulin adjuncts be of benefit to people with type 1 diabetes? In everyday clinical practice, it is clear that some people with type 1 diabetes have more troublesome hypoglycemia than others. Interestingly, recent evidence suggests insulin deficiency in type 1 diabetes is not absolute, implying residual beta cell function in some subjects. Histological sections of pancreas tissue from patients treated for type 1 diabetes for a long duration of 63 years also revealed the presence of surviving beta cells. In a study of patients being treated for type 1 diabetes for more than 50 years, more than 67% were found to have a random C-peptide level more than 30 picomicrograms. So the message is that there is not complete absence of beta cells. There are residual beta cells present in type 1 diabetes. And this is the basis that we can use some therapy which can increase the beta cell mass or increase the beta cell sensitivity. So therapeutic strategy that aim to preserve or even enhance beta cell function are likely to be of benefit. Therefore, in the management of type 1 diabetes, it is also becoming increasingly evident that insulin resistance plays an important role in progression of type 1 diabetes. Weight gain, increased resistance, improvement in insulin sensitivity at around 3 months after starting insulin in newly diagnosed type 1 patients is likely contribute to the transient remission seen during the honeymoon period. Treatment aimed at improving insulin sensitivity may therefore also be beneficial, especially in recent onset type 1 diabetes before resistance becomes established. Finally, the role of glucagon in type 1 diabetes has been the focus of renewed attention, with elevation in both fasting and postprandial glucagon value. What normally happens when there is hyperglycemia, glucagon value becomes less. And in hypoglycemia, when the blood sugar level is falling, the body tries to increase it by increasing glucagon level. But in type 1 diabetes, it remains persistently raised irrespective of level of the blood sugar. So this is the alpha cell dysfunction. Plasma glucagon level have been found to be raised and to correlate with hyperglycemia in patients presenting with diabetic ketoacidosis. Suppression of glucagon with somatostatin has been reported to prevent the development of ketoacidosis in patients following withdrawal of insulin treatment. As mentioned before, in people with type 1 diabetes, glucagon level fails to rise during hypoglycemia, thereby impairing recovery. The abnormal glucagon response appears to be mainly because of the effect of systemic hyperinsulinemia on glucagon secretion working through central and peripheral mechanisms. So pharmacological agents capable of regulating glucagon secretion in a glucose-dependent manner may help address inappropriately high glucagon after meal and inappropriately low during hypoglycemia. Immunotherapy for type 1 diabetes is another area where there have been rapid advances. So now the different drugs which are available for adjunct therapy will come one by one. Metformin. Metformin is a gold standard treatment for type 2 diabetes. It has been tried in type 1 diabetes, and the Vela et al. Published a meta-analysis on metformin use in type 1 diabetes, summarizing data from 5 out of 9 trials which satisfied their criteria of randomized trials with either a crossover design or where metformin was compared with placebo or comparator drug. There have been no reports of lactic acidosis in the metformin meta-analysis of subjects with type 1 diabetes, and no reports of increased rate of GIT adverse effect. Then second group, thiazolidinediones, the glitazones, both pioglitazone and rosiglitazone, they have basic action on the nuclear receptors in white and brown adipose tissue. There are conflicting data regarding a potential effect of these glitazones on autoimmunity and the progression of diabetes and animal models of diabetes. Alpha glucosidase inhibitor, however, in certain studies, there is direct evidence of enhanced endogenous incretin hormone level, which are yet to be confirmed. Then amylin analogs. Amylin is a co-secretion of beta cell along with insulin, and it is deposited in beta cell in type 2 diabetes and causes further destruction of the beta cells. So the amylin analog, formaldehyde, is a synthetic peptide that share most of the pharmacokinetic and pharmacodynamic properties of amylin without the tendency to accumulate. This is the beauty of this molecule. It does not accumulate in the beta cell. Amylin has been found to restore glycogen content in liver, inhibit glucagon in rats, and had binding sites on rodent beta cells with possible effect on insulin secretion. So pramlintide infusion has been shown to reduce post-meal glycemia in patients with type 1 diabetes. But unfortunately, you have to give multiple injections along with each meal. That's why this is not much advocated, although it has been approved by FDA for use in type 1 diabetes along with insulin. Then incretin-based treatment, incretin hormones including GLP-1 and glucose-dependent insulinotropic polypeptide GIP are secreted from intracells in response to nutrients and influence glucose-mediated insulin, glucagon, and somatostatin secretions. Endogenous incretin hormones has a half-life of 2 to 3 minutes, being cleaved by ubiquitous protease enzyme DPP4. So GLP-1 agonists and DP4 inhibitors are routinely used in patients with type 2 diabetes, and evidence from preclinical and some preliminary clinical trials in a small number of patients suggests that augmenting GLP signaling with some have similar effect on insulin and glucagon secretion in patients with type 1 diabetes as well. In a 4-week placebo-controlled crossover trial, sitagliptin was not found to have any advantage over placebo in changing insulin requirement or HbA1c, and there was also no change in glucose variability with continuous glucose monitoring. Then SGLT inhibitors, there are 2 trials involving the use of SGLT in type 1 diabetes. The pitfall of the trial that SGLT2 in type 1 diabetes causes euglycemic ketoacidosis and more hypoglycemia. That is the pitfalls, along with genital infections are more common with this drug. Bapicon trial involving dapagliflozin and tandem 3 trials evaluated the safety and efficacy of these drugs in type 1 diabetes. Then leptin is an adipokine and has a central and peripheral role in energy homeostasis. Currently, phase 1 trial is underway to test the effect of meterleptin, a synthetic analog of leptin, in type 1 diabetes. Then immunotherapy, that is the cornerstone of adjunct therapy. In type 1 diabetes, beta cell death is a result of autoreactive T cells and other mononuclear cells. Infiltrating islets, autoantibodies, especially insulin-specific, appear several years before clinical diagnosis, making prevalence strategy possible. So vaccination with GAD alum to induce immune tolerance to GAD6-5 is being tested in clinical trials. Conclusion: insulin therapy in type 1 diabetes is essential for the majority of our patients. While some achieve adequate glycemic control, many do not. Although an increasing number of people with suboptimally controlled type 1 diabetes are referred for insulin pump therapy and even beta cell replacement therapy in form of islet or whole organ pancreas transplantation, there are still large numbers struggling on basal bolus therapy. The recent observation on persistence of insulin microsecretion long after diagnosis and the appreciation that diabetes is a bihormonal disorder of not just abnormal insulin but also glucagon secretion has generated renewed interest in the role of non-insulin adjunct therapy. While none seems likely to replace insulin, some of these therapy may have potential benefit when used alongside insulin, including improved glycemic control, less hypoglycemia, a beneficial effect on weight management, and hopefully a reduction in the long-term complication. And these are the future references. Management of patients with type 1 diabetes is likely to become increasingly reliant on non-insulin adjunctive therapy in addition to usual insulin, glucagon, and GLP-1 based treatment. A strategy to increase insulin sensitivity and exciting advances are also being made with immunotherapy in prolonging remission in newly diagnosed type 1 diabetes. Autoantigen-specific therapy have far fewer side effects and are likely to become available for routine use. Thank you.
Thank you, Dr. Jha, for this nice but elaborate talk. And again, thanks for finishing in time. There will be no question. Thank you, audience, for your patience hearing.
Ajit, Dr. B.K. Singh. Our next speaker is Dr. B.K. Singh. Yes.
If you want any question to be asked from Dr. Jha, you can do it in lunch hour, etc. Now I request my co-chair, Dr. Pal, our very respected introduce Dr. B.K. Singh. They are good friends. Our chairman, Bihar chapter of
The topic, what is the topic? Diabetes. So now invite Dr. B.K. Singh. He needs no introduction. He is the chairman of API Bihar chapter, and he was also past chairman of RSSDI Bihar chapter, organizing secretary of Bapicon 2016, and he is a respected governing body member of the National API. He has a number of publications in national and international journal. With these few words, I request Dr. B.K. Singh to please deliver yours on the topic of mitochondrial diabetes. Thank you. Please.
Thank you, sir, for your kind words. Honorable Chairperson, our Guru, Dr. B.B. Thakur, sir, Dr. Jyotirmay Paul, sir, and my teacher during my undergraduate classes, Dr. A.K. Pandey, sir. At the outset, I thanks the organizer, especially Dr. D.P. Singh, Dr. Hemshankar Sharma, Dr. Manish, and Dr. Aved Ali for inviting to my second home, because I graduated from this medical college of Bhagalpur Medical College. Sir, Dr. Girish Mathur, sir, my special thanks for coming to here, and Dr. Alka Deshpande. My topic is small, mitochondrial diabetes. Nothing to disclose. As you know that mitochondria is a very important organelles found in the cytoplasm of all cells. And you know that in type 2 diabetes mellitus, or even in some cases type 1 diabetes mellitus, mitochondrial function is deranged. But today, I am not talking on the secondary causes of mitochondrial dysfunction, but the mitochondrial diabetes, where the mitochondria is diseased first, then cause diabetes in second. So mitochondrial diabetes is caused by poor
functioning of insulin producing cells in the pancreas and or the emergence of insulin resistance as a part of mitochondrial disorder. That is my topic, and that is the definition of mitochondrial diabetes. A very rare disease, less than 1% is present in the society. Mitochondrial disease is one of the most common among the genetic disorder with the prevalence of 1 in 5,000 adults. It is rare in comparison to the other disease, but according to, as per the genetic disorder, it is one of the most common disease. And the diabetes mellitus is the most common endocrinopathy reported in the mitochondrial disease. Exact prevalence is not known, but in India, it is supposed to be the less than 1% of the total diabetic patient may have mitochondrial diabetes. So it is one of the rarest presentation. You all know that the mitochondria is a very important organelles which is present in all cells. And it is a double membrane bond organelles present in the cytoplasm of the cells. You can see the diagram that it is a double membrane, that is inner membrane and the outer membrane. And the main functions of oxidative phosphorylation to produce ATPI, cell signaling, calcium score, and cell fat, that is the release of cytochrome C, which activated capase, so that the cell death is also possible due to the mitochondrial dysfunctions. It is the unique structure which contains the mitochondrial DNA. And you all know that the mitochondrial DNA always comes from the mothers only. The father cannot transmit the mitochondrial DNA. During the fertilizations, only the mother mitochondrial DNA is inheritable. So mitochondrial disorder are caused by the either mutation of mitochondrial DNA or the nuclear DNA. You have two DNA, mitochondrial DNA has present in the mitochondrial DNA and the nuclear in the nuclear DNA. And the mitochondrial DNA contains nearly 17,000 base pairs and 37 genes only. And the syndrome caused by mutation or deletion of mitochondrial DNA are often inherited from the mother. But the nuclear DNA mutation may be inherited autosomal dominantly or the recessively. Sometimes it may caused by the spontaneous gene mutation, that is the de novo mutation, and environmental toxin can also trigger this mitochondrial disease. The mitochondrial DNA mutations are more common in comparison to the nuclear DNA mutation and occurring in 20 per 1 lakh adult and are transmitted through maternal inheritance. The nuclear DNA mutations are less common, 2.9 in 1 lakhs, and are inherited in an autosomal dominant or recessive pattern. The clinical syndromes correlate poorly with the mutation load in the blood, and the more than 100 mutations are linked with this mitochondrial disorder. Classification of mitochondrial disease are depend on the mutation and organ involved. High energy requiring structure like muscle, kidney, retina, pancreas, brain, and nerves affected the most. So diabetes mellitus is the most common endocrinopathy reported in the mitochondrial disease. Highest prevalence detected in those with the mutation 3243A to G mutation, replacement of adenosines to the guanosine is the highest prevalence detected in this mitochondrial diabetes. If the pancreas is affected, insulin production is hampered, and the insulin resistance may be there if the liver, muscles, and other high energy tissues are involved. When to suspect this mitochondrial diabetes? When there is a multi-organ involvement, mostly high energy requiring organs, the raised serum lactate level, because the mitochondrial function is deraised, so lactate level may be high. The more rapid progression of the insulin therapy, and the earlier onset of diabetes-related complication in comparison to the individual with other type 2 diabetes mellitus. So you have to suspect when these three or four criteria is met, then you have to suspect that this is the case of maybe the case of mitochondrial diabetes. There are mainly two types of mitochondrial diabetes, is Mellitus syndrome and the MID. The Mellitus syndrome is the mitochondrial encephalopathy, lactic acidosis, and the stroke-like episodes. And the MIDD is the maternally inherited diabetes with deafness. In Mellitus, the stroke-like episode, especially below the age of 40 years, encephalopathy defined by seizure and or dementia, the myopathy with or without red rat fiber, recurrent headache, and the vomiting may be present, and lactic acidosis due to impaired glucose oxidation. In MIDD, which is more common than diabetes with sensory neural deafness in individual and with the maternal relatives. The myopathy may be present, which is usually in proximal myopathy. The macular dystrophy, particularly pigmentary retinal dystrophy, may be present. And there may be renal focal segmental glomerulosclerosis. So these two are the main mitochondrial syndrome present in our society. So when to diagnose the patient, the history is very important, particularly the maternal heritability, which suggests that your patient may have the mitochondrial diabetes. The characteristic clinical feature which I have already enumerated in MIDD and the Mellitus is the features. The mitochondrial DNA mutation usually detected in the white blood cells, and due to heteroplasmy, other tissue samples are important, particularly the urine epithelial cell segment. So you can diagnose in white cells this mtDNA mutation in white cells or the urinary epithelial cell sediments. And where diagnosis is not confirmed by the DNA testing, tissue biopsy of the vastus lateralis muscles is gold standard. To differentiate, differential diagnoses are very few, and the Kearns-Sayre syndrome, that is the chronic progressive external ophthalmoplegia, atypical retinitis pigmentosa, and the cardiac manifestation may help to distinguish this syndrome from the Mellitus. And the myoclonus epiclesia associated with the ragged red fibers, that is in this condition there is a characteristic myoclonus may be present, and the Leigh syndrome. So management is not only supportive, no curative management is there. Low level of nitric oxide were detected in the patient of mitochondrial diabetes. So nitric oxide precursor like arginine and sertraline have been observed to reduce the lactate levels in the Mellitus syndrome. IV arginine decreases severity and frequency of stroke in the episodes. Folinic acid can correct cerebral folate deficiency and improve hypomyelinemia. Coenzyme Q and L-carnitine are beneficial in some patients. Ivadenone in an experimental man-made drug similar to coenzyme Q10 is in different phase of trials. One possible prevention of this mitochondrial diabetes is the female with mitochondrial disease may utilize 3-parent IVP in which father sperm combined with the mitochondria and cytoplasm from the donated healthy ovum and the nuclear DNA from the mother. This is one of the important factors to prevent this mitochondrial diabetes. So to conclude, dear friends, that the mitochondrial diabetes is in one of the rare affecting organ and only an organ dependent on this high aerobic metabolism multi-organ involvement and maternal inheritance should prompt considerations. MELAS and MIDD are the most common mitochondrial diabetes caused by mutation in the M3243 arginine to guanine in 80% of the cases. Metformin should be avoided in mitochondrial diagnosis where there is a chance of lactic acidosis. This is one of the disease where the metformin is contraindicated and there is a rapid progression of insulin requirement and higher prevalence of complication. Diagnosis lead to family screening, education, and surveillance for future complications. Thank you very much.
Yeah, wonderful BK, especially because you have finished in time. Any question from audience? We have still some time.
Actually, when you are diagnosing any patient of hyperglycemia, you only think the type 2 diabetes or type 1 diabetes. But if you can see that nearly level 10% of the patients are having the monogenic diabetic form. In one of the, if you see in the GDM cases, the monogenic diabetes are quite common. In Western world, it is around nearly 10% of the patient having the monogenic form of diabetes other than the type 1 and type 2 diabetes. In India, there is no data is available. We are only thinking of this, but we are not thinking about the rare diseases which is present in our. We have already enumerated that when there is a maternal transmission linked or there is a multi-organ disease are there, and the diabetes hyperglycemia is there with the other organ affected, then you can suspect that this may be a case of mitochondrial diabetes.
Thank you, Dr. B.K. Singh. And this session is concluded. I am very much thankful to Dr. Jha and Dr. Singh for excellent deliberation. I am sure the delegates are much benefited from both of your speech. Thank you.
Thank you so much, sir. With that, we would like to request the chairpersons and the speakers to please join us for the felicitation ceremony right outside on the special stage. And we would now like to move for the oration, Dr. Shambhu Sharan oration. And for that, can I request the chairpersons to please join us on the stage? Dr. Rajesh Upadhyay, sir, Professor B.B. Thakur, Dr. A.K. Gupta, and Dr. Darbar. Can I request the chairpersons to please join us for the oration? I request the chairpersons to please introduce the oration. This is the Dr. Shambhu Sharan oration. We have Dr. Girish Mathur, the president, who's going to be the orator. Sir, over to you.
Good morning, everyone.
Ajit, projection change karna. We need that slides.
It is a pleasure for me to be introducing the Professor Shivnarayan Singh oration because he was my teacher. Shambhu Sharan. So,
Dr. Shambhu Sharan, I am privileged to be born in the district where Dr. Shambhu Sharan had worked for 6-7 decades. He was a great clinician, committed to poor persons, and very dear, and always attending the Epicons, always taking interest into the API activities. And I welcome Dr. Muruganathan sir and madam also. So I invite Dr. Girish Mathur to please give your oration on a very important topic I won't disclose.
अजित रुक जा अभी.
No, this is presentation. There is no presentation. I emailed him. I emailed Manish.
ईमेल किया है मनीष को. मनीष के फोल्डर में है.
Yeah, it is this one. Good morning, friends. At the outset, I express my very sincere thanks to API Bihar chapter, my friends Dr. B.K. Singh, Dr. D.P. Singh, Dr. Hem Shankar, Organizing Secretary Dr. Obed Ali, most respected Dr. B.B. Thakur, for inviting me here and giving me the opportunity to interact with my friends of Bihar and Bhagalpur. I'm also thankful, I'm honored and humbled to receive the most prestigious Dr. Shambhu Sharan oration. My talk is a tribute to Dr. Shambhu Sharan, a great physician who, despite high academic excellence, chose to serve the downtrodden people of Bihar. He was MRCP and FRCP of that time, but he worked for all his life in the area of Champaran and Motihari. He was a great physician, and he was known as Nagar Pita of Champaran. He was past chairman of API Bihar chapter. So I am honored to deliver Dr. Shambhu Sharan oration, and my talk is also in sync with the theme of this conference, blending science with the art. You are listening since yesterday afternoon, science of medicine. What I am going to talk is the art of medicine. Communication, a basic skill of medical practice. Medicine is an art whose magic and creative ability have long been recognized as residing in interpersonal aspects of patients and physician relationship. To develop a bond between patient and a physician is the most important thing in medical practice. Doctor and patient communication is the heart and art of medicine, because communication is the key that unlocks a number of benefits. It leads to increased patient satisfaction, better understanding of the treatment, improved compliance, and above overall better health of the patients. Communication is the differentiator. Because if there is a clear the communication, better understanding, and better is the outcome of the patient and the attendant satisfaction. Why doctors should learn patient communication? Because they have never been taught about that. And the relative situation is the heavy science requirements of medicine leave many physicians without any education in humanities. And why it is needed at all? Because it helps patients feel at ease, It reduces their anxiety and builds their confidence. It makes patients and clients feel valued. It reduces chances of medical errors. But unfortunately, there are no rules to abide by, leaving doctors unsure about the how of communication. And resultantly, our patients feel the pitch. About 60% of patients complained about a lack of involvement in decisions about their care. 46% of patients said they were given inaccurate information about how they would feel after treatment. About 33 patients felt that they have been given no explanation of test results. 31% felt that they had no opportunity to talk to their doctor. And what are the barriers between a patient and physician? There may be personal barriers. There can be negative attitude by doctors toward communication and giving it a low priority due to their concern primarily to treat illness rather than focus on patients' other needs, which may be psychological or related to social well-being. There are factors like tiredness and stress, a lack of inclination to communicate with patients. This can be due to lack of time, uncomfortable topics, lack of confidence, and concerns related to confidentiality. Lack of time is one of the biggest factors. We see patients from morning till evening, a lot of patients in OPD, and we hardly find time to communicate with the patient, but it's very important. We must give some time to the patients to understand their feeling, to listen to their complaints, and to make them understand about their disease and the treatment. Another factor can be inconsistency in providing information and giving conflicting information by different healthcare providers. Many times our nursing staff gives different information. Our residents can give different information, and a consultant can give different information. It is very important to give the patient a common information about their disease. There can be some organization barriers, although they are usually outside a doctor's direct control. This is lack of time again, pressure of work, being subjected to interruptions by many things. And many patients complain, and doctors just don't listen and focused on investigations. Whenever they talk to doctor about some complaint, he writes some more investigations. Empathy is what the patients need and demand for. We must practice empathy, not sympathy. Sympathy is just saying sorry to the patients, whereas empathy is a doctor's ability to understand the patient's experiences and feelings accurately, and also to demonstrate that understanding to the patient. Empathy is an active process. It comprises of love, nurturing, caring, understanding, and relating. Let us look at some of the key steps towards effective communication. Number one is to start with displaying respect towards your patient. Very important but often overlooked skill. You must introduce yourself to the patient, explain your role, shake hands with the patient, but don't force physical contact if patient is uncomfortable. Address the adult patient as Mr., Mrs. or Miss. Do not use the first name. Maintain privacy. Keep doors and curtains closed while talking with the patients and attendants. Acknowledge and greet others in the room. Your professional appearance boosts patient confidence. Maintain a clean, neat, professional dress code, because it does not only exude confidence, It ensures patients to feel more grounded in your presence. First impression matters a lot. On the first visit, when patients comes to you for treatment, they make an impression about you in their mind. Do remember, this is one of the most crucial interaction with the patient. It sticks and doesn't quite shifts in the future. Be polite, sympathetic, and talk kindly so that they can understand that you are their well-wisher and you are concerned about their illness. First visit impression will make a lot of difference in the future to improve doctor and patient relationship. Number 4, ask open-ended questions. Just don't talk about their illness. Talk about other things other than illness. And a bath technique can help. Letter B of bath represents background. Ask the patient, what is going on in your life? Second letter A, affect. We can ask how this disease is affecting you. Third letter T, trouble. We can ask what troubles you most about the situation. Fourth, H, and how have you been handling this disease so far? And lastly, empathy is most important. Show patient that you are listening. Reflect back what you hear them talking about their feelings. We can say them, it sounds very frustrating, very confusing, difficult, satisfying. It goes a long way in building the confidence about physician. Number 5, convey the diagnosis in a convincing manner should be an important step in communication. Physician should realize that patient may be anxious about his or her diagnosis. Patient may view the pros and cons of the physician's disclosure of illness differently than do physicians themselves. So conveying the diagnosis in a convincing manner is the most important thing in developing patient-physician trust. Number 6, disclosure of prognosis. Provide information in simple language and avoid using medical terms. Some patients welcome visual information in the form of diagrams or written information and instructions. And in some non-communicable diseases, the art of communication should be extended to educate the patient so that they can take care of themselves and the society. Number 7, choose quality over quantity. Convey your important information to patient in unhurried approach. If clock is your enemy, invite your patient for another visit. Patients often measure quality by how well the physicians listen, validate his or her complaints, and acknowledge concern. Quality is also measured by how thoroughly the physician explains the diagnosis and treatment options, and how well the physician involves the patient in decision concerning their treatment. Patients forget what to tell them and forget their complaints often. So ask them to write down their complaints before revisiting the doctor. Gently ask the patient whether he has understood the information. Many times, a patient attendant can be more helpful in giving important information. Number 8, art of healing touch. Modern medicine has undermined the power of touch, compassion, and care. Touch has the power to provide reassurance and confidence to the patients and has a larger healing power than any of modern tools in the medicine. So just holding hand or giving a pat on the shoulder of the patient can sometimes do wonders while treating patients. Number 9, preserve the trust. Doctor-patient trust is at its lowest, and doctor shopping is very commonly practiced nowadays. Caring attitude from the doctors coupled with communication boosts the doctor-patient trust like no other. The patient will never care how much you know until they know how much you care. You may be a very learned doctor, but if you do not take your patient into confidence, it doesn't matter for them. Problem arises when there is a breach of confidence that hurts the relationship a doctor and patient share. Number 10, bringing back the role of a family physician. Days of paternalistic family doctors are clearly over, but that need not to be a bad thing. All trend of family physicians should again be brought back in our profession. Patients treat family doctor as their family member, and the physician knows all the background of the patients and their family. While referring the patient to a specialist, they may consult you again for whatever problems that may arise during the treatment. Be the professional sounding board your patient can rely on. Number 11, provide the patients options. Merit of each available treatment option should be discussed openly with the patients and their relatives. They should then be asked if they wish to be involved in choice or would they prefer to leave it to a physician. If the choice is not possible, you should explain the reasoning behind it. Be responsive to the information given and where appropriate, involve the patient in decision-making process. It will make them feel satisfied and supported. Number 12, encourage patient to give feedback. Every complaint is a gift. It's a guide and chance to learn and improve. Encourage patient to provide feedback of both the compliments and the complaints. Complaints give us we are doing a good job, and compliments remind us that we can do better. There are certain specific situations where effective communication is very vital, like dealing with critically ill patients, breaking bad news like death, terminal illness, and bad prognosis, or in cases of highly demanding patients. When breaking bad news, we must handle with care. Imparting bad news is an emotional experience for the doctor as well as the patient, and it requires additional targeted strategies. Bad news must be transmitted in person and not over the phone. When you speak to the patient, they get the chance to clarify their doubts. Patient should likely be accompanied by spouse or some close relative. Make yourself fully conversant with the facts and details of their disease, exact diagnosis, and any additional issues. Make sure they have understood your communication and nature of risk and its consequences. Avoid pitfalls. Don't rush through negative information when describing complication. Give a few moments for questions also. If you are a specialist, you may often come across patients who have been referred from their family physicians or family doctors who don't fully understand the implications of disease or diagnosis. Never criticize the family physician. Work through them. Never allow the junior doctor or nursing staff to break the news, as they may not be able to clear the doubts of the patients and their relatives. While trying to be positive, never lose track of the fact that this is a serious and potentially fatal disease. Be optimistic, but do not promise success or anything else that may not be delivered. Sudden death is another situation where communication is very vital. While confirming a death, do whatever best possible you can do and then declare the death. If you wish, get an ECG done, take the history, and note it down the paper for future record. If you think that the cause of death is little suspicious, immediately inform the police. Take full address, telephone number of the relatives of the patients. While communicating with the family, we must listen to the complaints of the patients and respectfully in a mature fashion, because hearing can do make a world of difference. Try to explore the nature of their complaints. If the complaints are justified, it is important that you apologize and you ask the relatives what they would like to be done about it. Any problem that the family feel or experience should be actively identified and appropriate action should be taken to resolve them. If their demanding behavior continues, set a limit and you can tell them that you cannot do better than what is being done. If the relatives insist on continuing to disagree about the patient's management, it may be necessary to call some senior doctor to try to explain and convince them. Today, there are diabetologists, neurologists, gastroenterologists, but we need patientologists in this era to treat patients. Empathy and understanding what the patient's fears are, what the patient's worries are, so they can help manage it, it makes us patientologists. How does a doctor become a patientologist? Unfortunately, there is no set technique. Some doctors have a high emotional quotient, and others learn how to improve their patient skills by emulating their teachers who are good clinicians. How can we ensure improved communication among future doctors? What are the remedies? In medical schools and colleges must be encouraged to provide the best possible communication skill training as part of the core undergraduate curriculum. This training should have set objectives and clear methods of assessment. There should be more communication skill training programs during postgraduate levels. Doctors should use the appraisal process as a vehicle for discussing the success of communication skills training. As we wrap up, there are some key points. Good communication skill is essential for better patient-doctor relationship. Legal suits against the doctors are due to poor communication, lack of empathy, respect, and rough behavior that results in patients taking legal action. Being caring is not just nice, but it's also logical. Have a positive attitude without compromising on the reality of the situation, exact nature, and progress of the disease. For effective medical practice, care and concern about the patient is most essential. Never comment against other doctors' treatment and reputation. Patient has a basic right to avail adequate medical care. And medical profession, along with the society, must continue to work for those who can't afford medical health care. Lastly, be optimistic without setting unrealistic expectations. Remember, a good physician treats the disease, but a great physician treats the patient who has the disease. Thank you so much for patient hearing.
Thank you very, very much.
Sir, thank you.
Thank you very much, Dr. Girish, for this excellent lecture on a very important topic, which is going to determine our future way we treat our patients and how we change their outcomes by this art of medicine. And now there is enough evidence to suggest that the art of medicine improves patients' clinical outcome. That has been scientifically proven. So thanks a lot, and that was a great lecture.
Thank you so much.
Please don't go after number. Go after quality. Please add spirituality, yoga, meditation, pranayam, etc. in your day-to-day practice. Please forget.
Thank you, sir. Now, can I request the chairpersons to
we will be doing the oration ceremony over here. Right?
We would like to present no questions during the oration. Yes. Can I request the chairpersons and our scientific chairperson to to please come forward, as we would like to present the memento to our orator, President Dr. Girish Mathur, sir. We would like to present you with a small bouquet and lots of love from Bhagalpur. Ajit, screen off kar de, please. Yeah, thank you. Also, I would like to thank our president, Dr. Girish Mathur, sir, for finishing it 2 minutes before time as well. Thank you so much for maintaining time and helping us keep this conference just as an international conference on time. Thank you so much. We would like to now proceed to our next oration, Professor B.B. Thakur oration. And for that, can I request the chairpersons to please join us? We have Professor A.N. Rai, Professor D.P. Singh. We have Dr. Muruganathan, Dr. Sangram Biradar. Can I have Dr. Sangram Biradar, Dr. Professor D.P. Singh, Dr. Professor A.N. Rai as well. Ajit, slides डाल दे पहले. Slides डाल दे screen पर. Yeah, thank you. Requesting sir to please introduce the oration and call our orator. Our orator, Dr. Jyotirmay Paul, has also accepted that he is also going to keep it on time. Let's see what happens.
Yeah. Good morning, all of you. I'm very, very happy to be here in Bhagalpur. It's a long pending invitation from our affectionate Bihar people. So this time, in spite of heavy cyclone and rain, we could make it. And I'm also being given, surprisingly, to chair one of the stalwarts of API and stalwarts of medical profession, Dr. B.P. Thakur oration. All of you know, I don't need to talk about B.P. Thakur in Bihar because every one of you are his students. It's okay? He's a past president of API. The president of API 2002, 2000. Yeah, I think now it's good. And he finished MD
Mic not working.
Hello, hello.
To deliver this prestigious oration, my good brother, the Dean, Dr. Jyotirmay Paul, is going to talk about a very important and interesting subject, but often neglected subject. Does India need adult immunization guideline? Yeah. See, when I was the president, I had at least about 50, 60 meetings on this adult immunization, and we brought out a book on API recommendations for adult immunization. Subsequently also, we reviewed and then brought another book. So API is doing their part to promote the adult immunization. And this topic, I think Jyotirmay Paul is, it's his pet topic. We had organized exclusive vaccination webinars and seminars at Calcutta, where I was one of the patron and Jyotirmay Paul was the speaker. So I request, without wasting much time, I request Jyotirmay Paul to deliver the oration, the prestigious oration, Does India Need Adult Immunization Guideline and Our API Role? Over to you, my brother Jyoti.
Thank you. It is my blessing to me as I am speaking in an oration named by Professor B.B. Thakur, the legendary figure, godfather, mentor of API. I am very much thankful to Dr. Girish Mathur, Honorable President of API, who set up an expert committee to formulate the adult immunization guideline. Previously, Dr. Muruganathan, during his presidency, he has taken the first initiative to have an adult immunization guideline by API and published a very beautiful book on adult immunization. When the government of India has not published with its clear guideline, why API has taken guideline? Does it really need it, or it is driven by some other interest that often the people think? Let us see from the historical perspective. In the last 2000 years, history of mankind is governed by the history of infectious disease. Fall of Roman Emperor was due to the plague epidemic. Beginning of the Dark Age of Europe and beginning of the Renaissance of Europe was again due to the Black Death, that is the epidemic due to the plague. The Spanish people was successful in establishing colony in Latin America because of the smallpox. The Latin American people have lacks the immunity against the smallpox, and 1/3 of their army died due to the smallpox. The Spanish very easily encroached the Latin America. So in last 2000 years, mankind has fighted against the infectious disease more successfully in last 200 years with the advent of germ therapy, with the advent of concept of cleanliness, sanitation, with the discovery of antibiotics, and lastly by vaccines. So what is vaccine? Simply it is a biological byproduct that can be used to safely induce an immune response that can protect against the infections or disease on subsequent exposure to that particular organisms. The journey of vaccine started with the discovery of smallpox vaccine by Sir Edward Jenner in 1796. It get further armament with the discovery of rabies vaccine by Louis Pasteur in 1885. Subsequently, many more vaccine has been discovered, such as against the plague, typhoid, BCG, and so on. If you see the health situation in the pre-independent India, this data is taken from the JIMA, from an editorial in 1947. That time surveillance system was very poor. Only the piecemeal was reported. Still from the piecemeal, the data was written in the JIMA that from 1932 to 41, death from cholera was almost 1.5 lakhs. Death from smallpox was around 70,000. Death from plague was around 30,000. And active TB case was 2.5 million. The health situation and the prevalence of the diseases, this is very important to note that all was the preventable diseases. The editor JIMA in 1947 April in his editorial, he has written that no country in the world is medically so badly served as India. Because the British government, their motive was to save their own people and to take some measures so that infectious disease cannot spread from India to Europe, particularly the UK. They have done very little for the health, to improve the health condition of the Indians. And from the statistically it is seen only the 10% population was under medical cure or medical care under the British area. Anyhow, they have taken some act, that is the Epidemic Act, again that was adopted during the COVID period and 1896. That Epidemic Act basically was brought basically to prevent during the one plague epidemic, so that plague epidemic cannot spread from India to UK. And in the name of quarantine, even the freedom fighter were put in the quarantine house. That is basically in one term is a modified jail. They established the School of Tropical Medicine in 1914. This is definitely was a bold step for prevention and research of infectious diseases. But again I say, that time all the measures was taken only to prevent their own people, nothing for the Indian health. First structured committee on Indian health was established by Sir Joseph Vore in 1943. And you know, the one Indian was member of the committee, that is Dr. Bidhan Chandra Rai. That was the first structured committee. That report was accepted by the British Raj, later on by the independent government of India. And that committee has given stresses for the preventive aspect, the preventive health of India, at the same time establishment of the primary healthcare system, so that the rural India, the most of the population who are stay, they can get both preventive and curative care. Fortunately, when the India got freedom 1947, government of India readily accept the Vore committee report and tried to implement the report. So that time in 1947, the Vore committee, they earmarked 6 diseases that are as the major killer disease. The disease are diphtheria, tetanus, polio, whooping cough, measles, tuberculosis. So finally India got freedom in 1947, and in his first speech, Pandit Jawaharlal Nehru, he told that now it is the era for ending of poverty and ignorance and disease and inequality of opportunity. So he established the 4 priority, and one of them was the prevention and cure from the diseases. So independent government next 50 years taken many measures, starting from expanded program on immunization, particularly BCG, DPT, OPV, typhoid. Then it was measles was included. But all these measures was basically for the child immunization, because 48% death in 1947 was among the children aged below 40, below 10. So that means the childhood death was almost 50% of the total death. So prevent this childhood death, so all the immunization program, what was taken as a policy by government India was against the 6 killer disease earmarked by the Vore committee. That is the tuberculosis, whooping cough, polio, and this 6 killer disease. So that is why in next 50 to 70 years, India government and along with all state government, along with all authorities, we physicians, we concentrate on the childhood or infant immunization. So in this century, Government of India has taken some other measures like National Rural Health Mission that was finally converted to National Health Mission. In this step, in the next 20 years, again there is no stress of adult immunization, except few example. Hepatitis B was included in some of the high risk population, and JE vaccine in certain zones of the India where there is a high prevalence. But still, up to today, focus of government was in part of the infant children and pregnant women. Anyhow, the two steps was taken very successfully in last 70 years. One is the clean water mission, and another is the vaccine. That is why probably during the independence, our death, among the total death, 2/3 death was due to the communicable disease and 1/3 death was due to the non-communicable disease. But in this century, it is reversed. 1/3 death was due to the communicable disease and 2/3 death was due to the non-communicable disease. This reversal probably happened due to successful implementation of the childhood vaccination and clean water missions. In next 50 to 70 years, definitely there is a improvement of the economic situation in India, healthcare services, along with education, healthcare, economic upliftment. All this causes the demographic reversal. If you see the demographic reversal, age in 2011, age among 50 years was 193 million, but that is to be expected will be almost 1/3 of the total population in 2036. Whereas the age below 15 years, when the 2011 was 31%, it is to be decreased in 2036 in 20%, because the aging population, age above 50 years percentage is increasing. So we are seeing the demographic reversal. Demographic reversal, at the time of independence, our life expectancy was only 34. Now it has reached almost near 70. So we are now harboring the more aged population. This aged population are more vulnerable to suffer from different non-communicable disease such as diabetes, kidney disease, hypertension, lipid, obesity, heart disease. Very interestingly, if one person suffers from non-communicable disease, not only his mortality will increase or morbidity also, but if that person suffer from some of the communicable disease, mortality and morbidity will be further increased. So communicable and non-communicable disease have a relation. So not only the prevention, cure of the non-communicable disease, prevention and cure of the communicable disease also equally important. Otherwise, presence of either or both, the mortality, morbidity, and so the economic burden, healthcare burden will be exponentially increased on the society, on individual, on the government. So if you see the data, you see the, for one example, diabetes in 1990, 26 million prevalence, but it is to be, will be 65 million in 2016. So also CVD, death due to CVD, obesity, all are increasing exponentially in last 20 to 30 years due to due to changes in the lifestyle, economic upliftment, so and so, our lack of exercise, our motivation, so and so. So burden of this non-communicable disease in the present century increases the risk of infectious disease and its complication. So our duty is to prevent the infectious disease so that the complication out of the non-communicable disease should not increases. So this is a report from the Global Burden of Disease 2004. The 30% of disease burden in India basically due to the infectious disease. And among the infectious disease, they increase the complication of non-communicable diseases. This data from the WHO in 2017, they mentioned that India harbors the significant vaccine preventable disease in the world. The 60% of diphtheria cases are in India, 40% of tetanus cases are in India, 17% pertussis cases are in India, 17% rubella cases in India. So the vaccine preventable disease prevalence is 2 to 4 times more than any other part of the world. But remember, India's surveillance system, reporting system is very poor. So actual burden may be more than what is reported by the WHO in 2017. And in last 50 years, there is a several outbreak, epidemic, endemicity of the different vaccine preventable diseases. Just take one example of influenza. Between the 2010 to 2030, influenza-related respiratory illness almost 58%, and influenza-related circulatory death is 52.9%. So influenza, one communicable diseases, causes significant harm to the elderly population, particularly if that population different diabetes, hypertension, CKD, and different non-communicable disease. So that is why till now Government of India failed to declare that it is a must vaccination. Immune system, so at the one side there is a high burden of non-communicable disease, there is a high burden of infectious disease in India, and combination of both can increase the mortality and morbidity. Other hand, the aging population, this is the normal physiology, that immune system start declining after 50 years of age. So there is a immuno-aging, immunosenescence, immunodysregulation. So that is why mortality due to the infectious disease further increased as there is a immune dysregulation or immune dysfunction after the age of 50 or 60. That is why there is a need of adult vaccination. So the prevention from the communicable diseases is a duty of the physician and the state, so that the mortality, morbidity can be prevented and longevity can be increased. But sorry to say, in India, there is no proper adult immunization guideline. Even in the USA, there is awareness and coverage is very poor. In USA, coverage of adult vaccination is only 2%. India only, in case of adult, the pre-exposure adult vaccination are available in some of the diseases, such as tetanus during pregnancy and Japanese encephalitis vaccination in some of the areas of this country. So that is why different professional bodies, IMA, API, RSSDI, Geriatric Society of India, Indian Nephrology Society, previously they recommended adult vaccination as a piecemeal, not as a mass vaccination, but as a vaccination in some of the high risk population, and mostly recommendation came for the pneumococcal and influenza vaccination in the elderly. This is the different guideline. API also previously came out with guideline, particularly the influenza guideline, probably in 2016 or 17, under leadership of Dr. Muruganathan. Also we get different guideline on influenza or pneumococcal vaccination, particularly in elderly and those who suffers from different COPD, asthma, chest complication or CKD, but not as a whole adult vaccination guideline is available in India. This is a study done by the Jodhpur AIMS. So this is a vaccine coverage guideline. The hepatitis B, the coverage only 8% in the population near surrounding the Jodhpur. Pneumococcal coverage 7%, typhoid coverage 3%, influenza coverage 1%. But the post-exposure coverage for tetanus and rabies is quite high, that is 42% versus 20%. That means our awareness and practice in adult immunization is very, very poor. But this is not in India, across the globe. I told previously, USA also adult vaccination coverage and awareness poor, only 2% people under coverage. So where is the barrier? Why in the last 100 years we cannot cover the adult population, though we scientifically we know the high prevalence of infectious diseases and non-communicable diseases that increase the mortality and morbidity in the adult population. This is because one is the universal access, one is the resources, because to cover the entire so much population need a lot of money, most of the government lacking that money, and also the system of surveillance. So because our policymakers always ask, what is the incidence, what is the prevalence? So we have a poor surveillance system and also vaccine confidence, because when the COVID vaccine was introduced, there is a lot of resistance from the many population to take the vaccination. So these are the barriers. This is the barrier to adopt the adult vaccination as a mass vaccination. So that is why our national policymaker till now has focused only on childhood immunization, not in the adult. Our expert always asks for the data. So when you will go to talk, the expert on behalf of the policymaker will see, give me the data, what is the prevalence of the different infectious disease in different part of the country, and how if we apply the vaccine, how it can prevent. So we physicians should gather the data, we should collect the data and do the proper publication, and we move to the policymaker, so that not only the API can adopt the guideline, government can adopt the proper adult immunization guideline. I am again thankful to our president because he established the expert committee for API guideline on adult immunization. Hopefully very soon it will be published, I think before or during the Epicon 2024 in Delhi. So in conclusion, historically our primary focus was the vaccination among the childhood and pregnancy. In this century, the proportion of the adult population is increasing, and these adult populations are equally economically productive like the young population. There is a high disease burden in the adult population that can pose a threat not only to the family, economic threat also to the society. So this population should be prevented from occurrence of the different infectious disease and out of his complication. So adult immunization policy should be the new healthcare policy. So slogan in the 21st century should be prevent death from the communicable disease, prevent complications of non-communicable disease, and healthy aging. Thank you for giving me the opportunity.
Thank you, Jyotirmay Paul, for an excellent oration and talk, and highlighting about the need for adult immunization. I think we must give standing ovation for two things. One, for the prestigious oration, the living legend BP Thakur, to salute him. We stand the first standing ovation. The second standing ovation is to Jyotirmay Paul. Sir, you bite, sir. You sit down. It's a tribute and salute to you, sir. And
we take this opportunity to give you our love and a token of appreciation. Thank you so much. And also I would like to personally thank Sir for finishing it 30 seconds before time as well. That is Dr. Jyotirmay Paul for us. Thank you so much again. With that, we would like to move to our next oration, Professor Shiv Narayan Singh oration. And for that, can I request our chairpersons to please join us? We have Dr. Girish Mathur, Dr. Preetam Gupta, Dr. H.K. Singh, Dr. Sham Narayan Prasad. Can I request the chairpersons to please join us? As you can see, our orator has already made her way onto the dais. She is right next to the screen on the right-hand side. We have Dr. Alka Deshpande with us as well. She's ensured that the presentation is on time, and she's asked me 25 minutes mein, haan, theek hai, kar lungi. And she's been kind enough, traveled all the way. Loads of love. The chairpersons, Ajit, first slide dal de, screen par please.
Presentation.
अरे अजित ये डालना ये सब बंद कर पहले प्रेजेंटेशन मोड पे इधर लाइव कर दे हाँ वो क्या हो गया आ गया सामने आ गया
प्रोफेसर शिव नारायण सिंह
वही सर सामने है
was a great person. He's a very good clinician. I joined him as an assistant professor, and I was his assistant professor. With him, few years. He the timely तो कभी नहीं आए लेकिन लेकिन वो आते थे तो थ्रू आउट क्लिनिकल टीचिंग बेसिकली पेशेंट इन कर रहा है हॉल में पेशेंट इज इनिंग इन द हॉल in his room, any suppose the case of lethargiasis coming like a spasticity, दूर से बोलते थे, all signs you can see, and this is the case of lethargiasis, must be from the eastern part of Bihar. So this was his beauty, and another thing I took him his nature that if you will invite for any function your doctor, तो 4-5 इन्विटेशन है तो एड्रेस नोट करते थे। अब 1 बजे 2 बजे रात तक तो उनका चैम्बर चलता था। 2 बजे रात को आपका नॉक करेंगे, सब कुछ खत्म हो गया है, दरवाज़ा नॉक करके उठा के आपको विश करके गिफ्ट देके और उसके बाद कुछ जो भी एक पीस खा के चले। That was his character. Yes. Sir wants to say.
You see, my dear students, I have the privilege of being his student. There are certain qualities. Go to the next slide. Please go to the next slide. Yeah, he is Dr. Srinarayan Singh. He charged only 10 rupees from starting to his death. He was a great violinist. And this is the photo on the day, it was 16th of December 1989, when Dr. Srinarayan Singh went to Muzaffarpur, and he is getting out of the hall, and that day he was nominated as the first chairman of Bihar chapter of API, and the rebirth of Bihar chapter of API was done on that day. He used to smell medicine, and whatever clinical medicine our generation knows is because of Dr. Srinarayan Singh. So my hats off to him, and I salute him with folded hands.
In his service life period, he worked more than 40 years in government service, but 9 years some months he was in leave in that period, out of 30 years.
So we now invite Padma Shri Dr. Alka Deshpande, past Dean Indian College of Physicians, to deliver the prestigious oration in the name of Professor Dr. Shiv Narayan Singh. Dr. Alka Deshpande.
Thank you, sir. Honorable chairpersons and esteemed delegates, I pay my tributes to Dr. Shiv Narayan Singh, in whose memory this oration is instituted by this Bapicon. The topic is art of clinical medicine, dying art. That means the organizers accept that it is an art and it is dying. In my experience, whatever I feel about this art and also the science, I'll be putting before you and you decide. This art of medicine is actually an art of healing. It is as ancient as mankind. There was a caveman who used to encounter with the animals. He also sustained injuries. As you know, even in those eras, the population flourished. There were pregnancies, there were deliveries, there were natural traumatic injuries. But there were also instinctive methods of self-healing. Probably these people were also watching the animals around them. And the animals had that instinctive feeling. They used to lick their wounds, they used to go and wash their wounds, they used to use some plants to heal these wounds. And the caveman and the primitive man learned from this. So every country had its own system of medicine. Every country had gods worshipped as healers. Hippocrates, 460 BC, separated medicine from religion. History-taking, careful observation, use of eyes, ears, and hands. That was very important, emphasized by him. And then he said, by this, you develop a power of judgment. He also said medicine has been defined as coming to conclusion on insufficient evidence. We had our own system, Ayurveda, which is described in Atharva Veda. Charak and Sushrut are contemporaries of Hippocrates, Vagbhatta, Sarangbhatta. We don't know what exactly were the methods, but the same methods were used by these people. They have described biosafety. There is a Nadi Pariksha. Now, in those eras, 500 BC, that means about 2,500 years ago, they have given 1,120 illnesses, 700 medicinal plants, 64 mineral preparations, and 57 preparations of animal origin. So, along with the art of medicine, the science of medicine was also developing in that era. They have described the surgical procedures, as you know, various procedures, and one of the important procedure was rhinoplasty, which was taken from here to England, and this is documented in the Madras Gazette. If you don't believe me, I can produce that evidence. They have described Madhumeha, that is diabetes mellitus, and all of you know the famous story that Charaka observed that a urine residue was attracting the ants, and he was wondering, and he saw 2 or 3 such examples. So he literally tasted by his tongue the urine. Urine was sweet, and therefore he called it as Madhumeha. He didn't stop there. They have described Udakameha, that is diabetes insipidus, Ikshumeha, renal glycosuria. They have described type 1 and type 2 diabetes, and also said there is a genetic basis for this, and therefore it is incurable. This is the rhinoplasty I was talking. 1814, Carpew, a surgeon from London came, learned the rhinoplasty of Sushruta from a barber in Pune, and introduced this as a Hindu surgical technique with Indian nose. Okay? So this is what was happening over all these years. The art of healing was developing, and along with that, there was also science of healing which was developing. What were their study tools? The same tools that we are using today, but sparingly. It was keen observation, documentation. Even today, we are absolutely lazy in documenting our cases and experiences. Data collection, rational analysis of the data, hypothesis or hypothesization, and validation of their hypothesis. The same methods we are using today. So, art of tending to the sick is as old as humanity. They had human qualities required to encourage the patient's own healing power. If you are reading even tuberculosis of the present era, you know that before the advent of streptomycin, there was a sanatoria treatment, and tuberculosis used to heal naturally. So the God is great. It has given us a tremendous power of natural healing. So that was an art of healing, how to motivate and progress to that art of healing. So they had human qualities required to encourage the patient's own healing power by positive thinking. Physicians to understand patient as a person, not as a dead body. He was a living human being. 3 fundamental principles were observed: patient's welfare, patient's autonomy, and social justice. The basic essence of all this practice of medicine in those era was humanism. That is nothing else but art of medicine. Some years ago, the survey was done in Thailand, which showed that all kinds of doctors, ranging from quacks to the base-trained modern practitioners, have been equally effective in the society. What was the basis? Only humanism, not the knowledge. The science of medicine, the modern science of medicine, developed much later over last 3.5 centuries. Is it a pure science? Is medicine a pure science? Always we debate whether it is art or science. The art was developing over thousands of years. The science is only 3.5 centuries old. And it is an applied science. It is not a basic pure science. There are spin-offs from other sciences which are benefiting the human, human kind. And therefore it is called as applied medicine. As you can see, Jenner was the first physician who developed the pox vaccine. Darwin was a geologist and naturalist. Pasteur was a chemist. Röntgen was a physicist and mechanical engineer who discovered X-rays. Madame Curie was a physicist, radioactivity. Then there were, of course, Fleming, who came out with penicillin and revolutionized the whole medicine. Banting and Best with insulin. I mean, I can't go on because of the constraint of time. But this means that science of medicine is an applied science, and all other sciences are having spin-offs for the betterment of human beings. So medicine is an art or science. Practice of clinical medicine is an art based on science of medicine. Okay? And this is the definition of medicine which we should follow. Attributes of a good physician have been described by all these people. He has to be competent. He must have a knowledge of science. He must have art of medicine. So they go hand in hand. He must understand the philosophy of medicine. There must be empathy. He must put himself in the shoes of the patient and understand his problem. Intellectual honesty, integrity, and humanity. The great physician, from collecting all his experience, must also develop a power of judgment. What are the clinical medicine tools today? Again, the symptomatology, observation, critical evaluation of our data, hypothesis, objective evaluation. We do not know how they objectively evaluated their findings in Ayurveda or Hippocratic era, but they must be having certain methods. Today we are using experimental method. In addition, we have a statistical analysis. We have made therapeutic progress. We are giving prognosis and dialogue. So the dialogue is very, very important, which Dr. Girish Mathur has very well elaborated. So these are the clinical medicine tools which are using today and developing our science. The doctor-patient relationship. This is a relationship between the two human beings. There was a strong bond between doctor and the patient. There was an institution called as a family physician. The family physician knew every member of the family, right from a newborn to the great-grandfather. He knew the intricacies of that family. He knew the allergies in the family. He knew the different inherited disorders in that family. The family physician was like a part of a family member, that he was even consulted for the family matters, like family feuds or even matrimony in the family. So there was a very strong bond between the family and this doctor. Over the years, this institution is crumbling down. Now, family physician, when he had some problems, he would refer or take the opinion of a consultant physician. Even the consultant physician was an unfragmented specialist. He was concerned, he was caring, and he was compassionate to this patient's problem. He devoted time for the patient. That was very, very important. Maybe there was no cutthroat competition, but more than a cutthroat competition, he was compassionate, and therefore he spent time with the patient. And therefore there was a very strong bond between these two people. There was a loyalty and there was a trust between the patient and the doctor. But over last 3 or 4 decades, there have been technological innovations. These technological innovations are for the betterment of the human life. They are for sophisticated gadgets, advanced diagnostics. They have all come to help the patient. But with that, what happened? We fragmented the broad specialty of medicine. This word super specialty is used only in India. All other countries call it a subspecialty. Because of these technological innovations, some physicians, they develop, this is fascinating, but the physicians, they developed interest. They had a training in that. They mastered the techniques and they themselves started calling as cardiologists, nephrologists and whatever so on. But these are all subspecialties of medicine or subspecialties of a broad specialty like surgery. And therefore, in all other countries, these are called as subspecialists. Let me also tell you, in USA, all these subspecialists have to spend 100 hours per year in their basic specialty. That means the umbilical cord with a basic specialty is maintained, so that the doctor is prevented from developing a very tubular or myopic vision. I'll just give, for the benefit of some postgraduates, yes, 2 or 3 examples. There are innumerable I can quote from my experience. A young man presents with acute onset inability to move both the lower limb. He can't call it as paraplegia, so he says, I can't move the lower limb. Where the patient should be weighed in? For CT scan, for MRI of which part? Brain, spinal cord, which one? Cervical, thoracolumbar, we don't know. So are we going to subject him for this? And all the imaging techniques are negative, then what else? I mean, when this patient is presented, I expect even my undergraduate broadly to say that this could be a transverse myelitis in a state of shock, or it could be a Guillain-Barré syndrome. What you have to do is clinically examine the patient. If there is a transverse sensory level below which there is a paralysis, it is transverse myelitis. Then the patient MRI is done only to rule out if there is any treatable cause. Otherwise, it is Guillain-Barré. Both the conditions, the approach is different, the investigations is different, and the management is 180 degrees apart. And this is only possible with your bedside investigation, a clinical acumen. Thyroid. Nowadays, I get large number of the patients, they just come and put down their investigation papers on my table. I ask them, आपको तकलीफ क्या है? तकलीफ? तकलीफ कुछ नहीं है. Then why this investigation? लिखा है ना तकलीफ. अरे but आपको तकलीफ क्या है? They don't come out with तकलीफ, and then I tell them, I treat a human being. I treat a patient and not a piece of paper. If you have any problem, you tell me. If you don't have a problem, whosoever had asked you to do this investigation, you go back to him. And then I'm told, no, because I am getting fullness here. So there is a fullness. The lady is 85 kg weighing. It is all obesity. But her padosan says, कि thyroid देख लो, thyroid check करा लो. Or some family physician, which is now the family practice has gone into the hands of Ayush people, and they advise thyroid checkup for each and every month. When I there was nothing related to thyroid. Okay, I don't mind doing a serum TSH after doing her examination, but definitely that obesity was not because of hypothyroidism. Hypothyroidism doesn't cause obesity. In very severe stages, it causes a generalized anasarca, non-pitting edema. That is not obesity. When I investigated, she had moderately severe diabetes. One of my very brilliant postgraduate student after MD, through competitive exam, was selected for gastroenterology. She went for a gastroenterology in another hospital. The case paper is issued by the clerk sitting there in the registration. So this patient went with edema, feet, ascites, and therefore he issued the paper of gastroenterology. Patient lands up in gastroenterology. There the junior houseman examined the patient, and the practice was that every patient was to be shown to the lecturer before admission. The lecturer immediately said, admit him and put him for a GI scopy tomorrow morning. In the evening, when my PG, who had passed her MD, she went to take the history and examine the patient. It was a case of full-blown, severe mitral stenosis with pulmonary hypertension with CCA, hepatomegaly ascites, and she got frustrated. She spent 10 days in that department and came back to me and she said, Madam, I don't want to do any specialty. My medicine is most interesting and exciting. I will be back here. If there is any post of lecturer, please offer me. Otherwise, I'll start my practice. Today, she is one of a renowned physician in Mumbai. There was an old woman, about 65 years. She was from the old age home. She was admitted for some genital complaints. The students and my residents took the history. When I went for a round, I just asked them, is there any history of sexual exposure? What, madam? Madam, she is menopausal. Madam, she is 65 years old. Madam was asking something out of the blue. I said, "Theek hai, but that doesn't make her immune for this." When I talked to her and said that there may be some infectious disease, you might have contracted from somebody, so we'll have to also examine that person. Did you have any sexual exposure? She blushed and she said, yeah, that person from room number so and so comes and visits me. So we said, whenever possible, you please call him. And then she also said, in addition, there is one more person. So please don't take anything for granted in medicine. Be true, be honest to the history, because nothing is immune. So this was the case. Now subspecialties, as they are developing, they are busy doing the technological procedures. So medicine has become depersonalized. It is a medicine with machines. They are developing myopic vision. That has negated the holistic approach to a patient. Lot of commercialization has come. Arrogance. I'll just give you one example of arrogance. A famous cardiac surgeon, a patient was referred to him for CABG. The patient and patient's family goes to him. He doesn't even see the angio. He says, okay, CABG is to be done. He puts the card before them. In this hospital, I charge so much. In this hospital, I charge so much. Patient will have to stay in the hospital for 10 days. That's all. Now, patient's family is in a state of shock. Mentally, they are yet to be prepared for a CABG of their family member, plus the financial constraint. So they asked, doctor, how much time do we have? And he said, time? For. So they said, for your financial adjustment. So he said, you can take as much time you want. But after that, put his photo frame on the wall and garland it. This is sheer arrogance. If I would have been there, either I would have slapped him, insulted him badly, and walked out. Just because the patient is needy, he has come to you. You are not expected to behave like this, and these are the assassins of art of medicine. So this is affecting a doctor-patient relationship. Today I can tell you that there are many subspecialists in Mumbai. They don't have time for the patient. They don't even look at the patient. A patient, they have, some assistant sitting outside. He writes everything. Patient goes for 1 minute. 1 minute, the doctor says, sees the TSH level, either increases or decreases dose of thyroxine, go. I know the oncologists, they don't even talk to the patient, how are you feeling? They see the report, either add something or it's okay, go. I have many patients who told me that we are paying 5,000 as consultation fee, and what do we get? They don't even have 2 minutes for us. And these are the assassins of art of medicine. A lot of mechanization, commercialization, escalating costs, increasing litigation because there is no dialogue, because there is no communication between the doctor and the patient. And therefore, medicine has become commodity. When it has become a commodity and consumer, if I am throwing 5,000 rupees, I must get return of the same. If I don't get, I can sue the doctor. And this is what is happening with violence against the doctors. So we are partly responsible. And as a result, what is happening? Most elite class of IAS officers, I can tell you from my experience, they come to me, they get a diagnosis from me, and they say, no, your medicines have a lot of side effects. We'll go for homeopathy. So they are going for alternative medicine. And first 3-4 patients, after that I started telling them, this is my diagnosis from modern medicine, which doesn't hold true for a homeopath. He makes his own diagnosis. But this in bargain, we are defeating the modern medicine. So these are the assassins of art of medicine. Now, when we had this art of medicine, there were great physicians. Many of them are sitting here. They had developed that clinical acumen, and they used to say, my clinical acumen tells me this. I feel it is like this. So some people got irritated with this. What is I, me? And they said, we must have some objective evidence. So came the evidence-based medicine. They collected a large data, they analyzed it, and put it with the confidence interval limit of 95%. What about the rest 5%? Okay? They developed the protocols and started calling themselves as experts. Okay, they are experts because they have a large data, but that is not sacrosanct. These are guidelines. We should use the guidelines, but that is not the law. Then my next question is, are we really trained in using evidence-based medicine? You read the first few chapters of Harrison, and Harrison says there was a performance statistical model versus expert clinician, and the accuracy was equivalent. So clinician must use his discretion in given life situation. Now there are lacunae in medical education. Why this art of medicine is dying as, as has been the subject? There are lacunae with the students. When we were students, we were told that the patient is an open book. Go and read that book. And that is what we used to do. We used to be with the patient. Today, the students are sitting in the side room, mugging some books, not even textbooks, because they have to appear for competitive exams. Many teachers are lacking the clinical skills. There are no facilities, and therefore we have to renew our interest and develop this. Medical curriculum, which lack in medical ethics, which lack in communication skill, these are the things we have to teach our students. Clinical skills, informatics, evidence-based medicine, professionalism, costing. We don't even know how to set up your clinic and how to start charging the patient. Therefore, there has to be a scientific method for costing, and we must teach them philosophy of medicine. There is a changing face of clinical practice. Earlier, it used to be individual practice, then it became group practice. After that, now it has become a consumer product. So that the moment it is consumer product, lot of legalities, lot of management issues came in the corporate houses. And now it has become a healthcare industry. And the doctor has become just a minuscule part of a healthcare industry. What a shame. Interaction and interrelation is two ways and reciprocal. So doctor is also a part of the society. What is happening in the society? The moral and ethical values are changing. Greed for money and material gains at any cost is increasing. How can doctor be isolated? So just because the doctor makes money, everybody criticizes him. He is minting money. He can't get this money from the patients. And therefore, there is lot of malpractice. Though you are not doing it, it is blamed upon you. So medicine has become a consumer product. It is absurd to term it as a consumer product. What is the medicine in future? With all this, people are still interested in taking up medicine as a career. It is very exciting. Future is very bright and promising. At the same time, ugly and frightening. What are the new frontiers? Basic sciences, immunology, genetics, nanomedicine, hospital management, and there are many others. Now the digital technology has come in. And with this digital technology, we'll have to keep up pace with the digital technology. We'll have to learn this and start using in our practice. And next is a big challenge from artificial intelligence. I know very little about the artificial intelligence. It is challenging all the fields of life. So also it is challenging medicine. Is it a threat or it is complement? After all, who has developed this artificial intelligence? Maybe 100, maybe 1,000 human brains put together, put to use, and which has analyzed a large data and developed an artificial intelligence. So ultimately it is a human brain. And if it is a human brain which has developed it, it should be appreciated by another human brain. We'll have to take a training in the artificial intelligence to use the artificial intelligence. But is it a threat? I don't think so. I think this artificial intelligence will be a very, very important tool for drug discovery, simulations, diagnostics, personalized treatment plans. And this is what is going to come in next few years. Acceleration of the medical research. But at the same time, there will be a lot of ethical issues, lot of legal issues. And I do not feel, I may be wrong, the time will prove, that it will replace the clinicians. Because the basic fact of a clinician is humanism. Consciousness and intelligence are different. Conscience, mind, and emotions are different. A doctor must have the ability when the patient is talking to him, he listens to what he is talking, and he also listens to what he has not told. There are many things which he can't express, many things which can't be uttered, and that is what the doctor understands. And that is what is called as a sixth sense. That is what is called as an intuition. I don't think the machine can have that. Robots will give depersonalized mechanical precision, but it is not substitute for tender, compassionate, caring, reassuring touch of the doctor, which can change the course of the disease. And this is what we all have experienced during the recent pandemic of COVID. All with that PPE, my doctors were going near the patient. They were reassuring. They were taking care of the patient at the risk of their life. And large number of the people have been saved. That is the trust. So time future is contained in the time past. Time past was the art of medicine. So revive the art of medicine, high ethical standards. We all must have our courage of conviction, and humanity is the basis. Clinical medicine is a dying art. Science of medicine will progress because the science is progressing in all the fields. New innovations for betterment of human life. Clinicians will have to keep pace with the science. Mediocrity will have no place. So we have to be up to date. Mediocrity has no place, but no art of medicine or art form ever died. This reminds me of a small, beautiful story of Rabindranath Tagore, and he says, art never dies. Art is an essence of human life, may change its form, expression, but will not die. Human system is a mysterious integrated whole. No organ functions in isolation. So holistic human care is the art of medicine. The science may develop, but art of medicine, sir, I don't think will die. I am very optimistic. And as such, Professor D.P. Singh and Professor Sharma, they are with me when they have chosen the theme of the conference as blending science with art of medicine. Anything under the sun can be blended. And this is what Hippocrates had said. Anything can be used or put to use by a great physician in developing the art of medicine. So, my friends, I am very optimistic, and Gandhiji has said, science without humanity is one of the social sins. And we are not going to commit that social sin. So let us work together for the development of science and art of medicine. Thank you very much. Once again, I thank the organizers.
Thank you very much, Professor Deshpande, for deliberating an excellent talk regarding the clinical medicine. I think I agree with Professor Deshpande. Please have a seat here.
We would like to now
Yes.
felicitate Madam by giving her a token of
I
appreciation.
fully agree with her that clinical medicine is being forgotten in the current era, in the present day, because the evidence medicine is taking up, but we should not forget it. This still holds true, and we should not forget clinical medicine. Thank you very much, Professor Deshpande.
Thank you so much. With that, we come to the end again. I would like to thank ma'am for concluding the oration also on time. If you look at it, we still have 1 more minute remaining. And at the same time, we've got Dr. Yashpal Munjal sir joining us online. And I would request all of you to please look at the big screen. As you can see, sir, can I request the chairperson to please join us for the session? Can I request Dr. A. Muruganathan, sir, Professor H.S. Sharma, and Dr. Devi Ram to please be the chairpersons? Dr. Yashpal Munjal, sir, can you hear us?
You can hear them. सुनाई दे रहा है आपको?
No.
तो बोलिए ना. Hello बोलो.
Yes, please.
Yes, sir. From the permissions of the chairperson, Sharma
Can
ji,
you hear me?
can he start? Yes, sir is there. As you can see, we've got the CV slide already onto the screen.
Honorable chairpersons.
Sir, Munjal sir, 1 minute, sir. Dr. Muruganathan, sir, 1 minute. Let me introduce, sir. Let me have the pleasure of introducing, sir. Can you hear me, sir? Munjal sir. Dr.
Yes,
Muruganathan.
we can hear you. Please.
Yes. Okay. Dr. Y.P. Munjal needs no introduction, but still he's one of the pillar of API. He's the ex-director, Physician Research Foundation, ex-director, Banarasi Das Sandiwala Institute and Research Center, ex-senior consultant, Department of Endocrinology.
Honorable chairpersons.
Daddy, he's introducing you. He's saying wait. एक second wait करिए.
Akash.
Dr. Muruganathan, can you start?
Okay, please, start, Akash.
Just a general reminder, total time allotted is 17 minutes for the talk time and 3 minutes for the introduction.
Please, go
Thank
ahead,
you.
Go ahead, yes. I think I request Dr. Yashpal Munjal to give the keynote address. We are all eagerly waiting to listen to you, sir. Over to you, sir.
Daddy बोलिए. Daddy बोलिए, वो बोल रहे हैं. आप बोलो ना.
Good afternoon, my dear chairpersons. I am grateful to you for having introduced me to this audience, which is part of my work as various capacities. The Honorable President, Dr. Mathur, Dean, Dr. Jyotirmay Paul, Dean-elect in absentia, Dr. Kamlesh Tiwari, and our past Dean, Dr. Alka Deshpande, a academician par excellence. I think the topic which we are going to discuss is both a admixture of clinical medicine and investigative matters. In this talk, we have Dr. Binda Bihari Thakur. Why I am taking his full name? He is one of the pillars of API, and his name, Binda Bihari, is commensurate with Lord Krishna, who was known to be a thief of fat and eating butter all the time, making us prone to non-alcoholic fatty liver disease.
Dr. Yash, आप mute हो चुके हैं. If you could unmute yourself, please, and change the slide if possible.
There is some issue with changing the slide. I'm just trying to get it fixed,
Oh,
please.
okay, no problem. Can you right click and maybe try the next slide? Maybe right click. That sometimes helps. No, doesn't help. No, it's not happening. एक बार end करके वापस ही कर देना, नहीं तो हाँ. Yeah, there is somebody, but
The topic we are going to discuss is the prevalence and epidemiology of non-alcoholic fatty liver disease, how it comes about, and very importantly, we must understand what is happening in our country. The diagnosis consists of doing non-invasive tests and a gold standard invasive test of liver biopsy in selected patients. Then the difficult part is the management of non-alcoholic steatohepatitis with diabetes and the conclusions. Here you can see the global prevalence of non-alcoholic fatty liver disease. For brevity, we will use the word NAFLD. It was around 25% globally, and it is practically 30% globally nowadays. If you can see the red colored India marked in the picture, where the prevalence is beyond 30%. The gray areas show where the data is unavailable or sketchy. The most important thing which we must understand, that the genetic markers of PNP, PLA3, and what is the distribution of this genotype. There are these two tests which get mutated to PNPLA3 and TM6SF2, which variants of the genetic markers results in making one prone to NAFLD. Here is the NAFLD presence in India. It has been shown in two graphs. One where the risk factors are not as well present. You can see there has been a marked change in the presence of this, and some of our workers have shown a prevalence of more than 40%. Comparing this, we have the patients with increased risk like obesity, diabetes, dyslipidemia, multiple sclerosis, and you can see that here most of the conditions are very highly prevalent, above 30%. A picture showing the difference between the rural and the urban classification and distinction between men and women starting from age 30 and 3 decades have been taken and beyond. You can see that the prevalence is pretty high both in urban as well as rural population. These are the areas. Down south is 40%, while in north it is 30%, and east and west, which show a little lesser prevalence. And considering all these together, it is found and estimated that the burden in India is 0.45 billion. Is it real? That is it more or it is less than this figure? Let's look at another important issue, that whether the NASH and cirrhosis are the same in the population. So what was done was, a study was conducted where the hepatic transplant was done and the number of cases was 372. You find that the distribution because of viral hepatitis, alcohol, primary biliary disease constitute a larger number, while NAFLD and NCPF and cryptogenic are on the lesser side. And after the post-transplant, the figures were not very different. The only point I like to highlight here is that out of 62 people, there were 40 people where the risk factors were not present. This is the bar diagram which shows again the difference between risk factors, and you can see very well that fat, HDL cholesterol, diabetes, presence of increased BMI results in a higher prevalence of cirrhosis. The other studies from our country have shown that the prevalence of diabetes, obesity, metabolic syndrome in cryptogenic cirrhosis. Now we have been talking about NAFLD, NAFL, NASH, and hepatic HCC. Now what is NAFLD? There is an increase in the fat accumulation in the liver leading to insulin resistance. If you do a biopsy, then steatosis is seen in more than 5% of the hepatocytes. Exclusion of secondary causes of alcoholic fatty liver disease is present in very less number of patients. NAFL, that is pure steatosis, steatosis with mild lobular inflammation. That is, not only there is fat deposition, but as a result of that fat infiltration, there is a inflammatory response in the liver. And if you do a fibra scan, then the fibrosis is seen to the extent of F0 to F1, while the non-alcoholic steatohepatitis, where the inflammatory situation increases much more, and you can find the fibrosis and the degree of the ultrasound FFA results between F2 to F3, while in cirrhotic livers it is F4 or above. This is the natural history. If you take the straight line, then you can see that we have steatohepatitis, then NASH, and advanced fibrosis going on to cirrhosis. But during the time when the patient is suffering from the inflammatory markers, then at times there may be direct worsening of liver function resulting in death, while the other course is that cirrhosis takes place and hepatocellular damage and carcinoma are known to happen, and these patients suffer quite badly. Here there is a diagrammatic representation of the various risk factors. You can see obesity, diabetes, change in fats, and the metabolic syndrome all contribute to NAFLD. The most important point we have to understand is that there is a triangular pathogenesis of non-alcoholic fatty liver disease by lipids, liver, and the other risk factors.
Dr. Yash, we are facing some issues. We can't hear you, and your screen is also frozen.
Munjal sir, your screen, you are muted. Sir,
No,
you
sir.
are muted.
सर वो थोड़ा सा इंटरनेट कनेक्शन का शायद से दिक्कत आ रही है.
इंटरनेट कनेक्शन होता तो सब चीज़ बंद हो जाता. उनका कुछ म्यूट हो गया होगा टच करने में. Sir, you are muted at your laptop.
As we had said in the beginning,
सर बीच-बीच में आवाज आ रही है और फिर वापस से जा रही है.
is in the intestine in turn results in the change in the insulin resistance of the patient. And one of the important things we measure is the abdominal girth. So increase in abdominal girth leads on to intestinal.
Sir, you are getting our voice? We are not getting you, sir. Ours is okay. There is some problem in his laptop.
Dr. Yash, can you hear us?
You
We are
can see
Yes, sir.
the non-invasive testing also show easy reproducibility. They are easy to learn. The results are rapid, and the only disadvantages are that you have to have an equipment for elastography and intermediate cost, limited recognition of intermediate stages of fibrosis. The blind selection of the measurement area also makes a difference in the pathogenesis of NAFLD or the involvement of the liver. Then the genetic markers again have high accuracy. You need to also have ultrasound equipment. The cost is in between, and the narrow range of values tends to make the measurement.
Check. Can I request the chairpersons to please take over because sir का वापस से mute भी हो गया है and we are facing a little connectivity issues. Our scientific chairperson, can I request you to please take over?
Conclude.
Yes, please.
नहीं सर बात करेंगे. Close करें. Should we conclude? ये तो रिवर्सल में जा रहे हैं. So I think we are sorry for this. The problem is not from our side. Our system is working normally, and his instruments is showing internet failure, sir. Signal problem on the way. So I would like to Dr. Deviram to say a few words.
The inconvenience is regretted, but we have been just fortunate to hear none other than the great pillar of API, which needs no introduction. And he talked on NAFLD and its associated problem. I suppose as the speaker is not connected, unless somebody wants to give some comments, we'll close this session and move on to the next one.
Okay. So thank you very much. The thing is this, that we cannot even honor him from here. So we can just clap for him, for Dr. Yaspal Munjal sir. And in the honor of him, just we can stand over here. So we go to the next session, I suppose. Okay, thank you so much.
For the chairpersons are the same for this one. Yeah, yeah. We have Professor B.B. Thakur sir, requesting sir to please join us.
Friends, now we will move on to the next keynote lecture by another stalwart and pillar of the API, Professor B.P. Thakur. He is going to talk to us on lifestyle medicine. And you know, Dr. Thakur, even at this age, he prepares his slides, he prepares, the topic very well. Some days ago, he called me, he asked me, is there any precision medicine for lifestyle modification? Because he's up to date. And, he's meticulously preparing and, on and on and on. So it will be a great feast.
At least.
Yeah. So it's a great feast and it will be good experience he'll share with us. So now I request Dr. B.P. Thakur sir to deliver his
So
keynote
before
lecture.
I talk, there was a procession in US. And what was there on the earthy? It was the clinical medicine. Many of you might be knowing that it's a demise of clinical medicine. Madam Pathak has very nicely dealt. She also, my talk will be finished in time. Madam Pathak said about Ayurveda. Let me tell you one of my experiences. My mother-in-law went to one of the Ayurveda charge at Varanasi. He did not ask any question. He just caught hold of the nabj, pulse. And he told a sloka. And the meaning of that sloka was her complaints. So that is Ayurveda. Regarding some talk of my friend Mathur, you see, I personally went to a doctor in Delhi recently. He knew who am I. I had paid a hefty money. He gave me only 2 minutes. Only saw X-ray. Finished. So dear friends, are we there to earn money? Now let us come to the third. Clinical medicine is a great medicine. Believe it or not, I know only clinical medicine. And many of you might be knowing Dr. Amarnath Misra, who was a tutor in PMCH when I was a student. Once he told me, you are Kalidas of clinical medicine. So to postgraduate student, I tell you, read only clinical medicine. I can assure you, if you prepare it well, you will be mostly diagnosing the case. And to the clinicians also. So now let's come to the topic proper. Please inform me after 15 minutes, my talk. Then I will summarize. You see, Dr. Vivekananda said, body is mine, body is mine. I am not of the body. Today, we have become slaves of body. LSM, that is lifestyle medicine, is a curriculum in US, taught in US. I have come to know that now in this country, in our curriculum is being also changed to teach LSM. It's a therapeutic, mind every line, it's a therapeutic use of evidence-based lifestyle modification that focuses on the change of your lifestyle, your habits, to prevent, treat, and even reverse lifestyle diseases in clinical setting. It empowers you, me, the country, and the community to maintain a good health. These risk factors for non-communicable diseases, you know, we have epidemic of non-communicable diseases, genetic, environmental factors. I am tired of the sound and air pollution. Nobody talks of sound and air pollution. Factors of self-management. Mahatma Gandhi said, be the change you wish to see in the world. Don't ask others to. Therefore, I have made a change, and I never have food of the conference or the clinical meetings held in the town. So be the change. You know, inter-heart study, 9 modifiable risk factors are responsible for 90% of the heart diseases. Next. In behavioral determinants, all of the top leading causes of death in US, adults are moderately to strongly influenced by lifestyle patterns and behavioral factors. Next. Predominant lifestyle diseases, you already know, I will not go into the details. Obesity, metabolic syndrome, hypertension, and they are known, 4 of them are put together as whole. Next. Sir, listen to, see this topic, see the slide. Among 1,000 people, only 1 dies a natural death. The rest succumbs to irrational modes of living. Let me tell you honestly, scientifically, we are born to live for 122 years. Maximum, minimum 85 years. We are dying at 70 years. Next. Genetics are not the cause, boss. We have been blaming genetics. No, it's our lifestyle. Next. You are looking to the downstream. Look to the upstream. Look to the cause. Look to your childhood. What behavior? What achar, vichar, vyavhar, ahar you have started to take from the beginning? What is your teaching in the beginning? What you are eating? Only junk food mostly. Next. Why LSM? 80% of the premature death come from tobacco and physical inactivity and alcohol. Only 3% population follow a healthy recommended lifestyle behavior. It decreases reliance on medicine. It treats and prevents. In pre-diabetic, in diabetes, lifestyle medicine is very important. Non-adherence to medicine is large, and you call that there is no compliance. Next. What are lifestyle medicine factors? Diet, nutrition, time finished here. Physical inactivity, smoking, alcohol, stress. Stress is a great factor. Our new generation wants to be Dr. B.B. Thakur, Dr. Devi Ram in the smallest possible time. Have you seen our young age? Have you seen our struggles? No. So, chronic stress, anxiety, emotional wellness, poor and inadequate sleep, which was elaborated by Dr. Mathur, lack of connection. Sir, mind this one, lack of connection to family, friends, community, and social isolation. And that was amply proved during the period of COVID. Next. Sudden death, even in Hippocrates' time, sudden death is more common in those who are naturally fat than lean. Next. We already know that 8 to 10% of weight loss can do wonder in lipid, in diabetes, in blood pressure, in HbA1c, and sodium restriction is known to reduce blood pressure also. Next, please. How can we implement lifestyle changes in our lives and the world around us? By using our feet properly, by using our fingers properly, by spoons, sleep, stress, and love. Love is very important. Next, please. The role of exercise. Next, please. Next, please. In view of the prevalence, global reach, and health effect of physical inactivity, the issue should be appropriately described as pandemic with far-reaching health, economic, environmental, and social consequences. Next, please. This is how we are living. Indoor play. We used to play outdoor, now indoor. Next, please. This is how we are now working. It's a desk working for a overtime also. Next, please. I won't go into the details how many minutes you should walk, exercise, but only 2 lines I will read. Exercise is medicine. Exercise good effects last for only 24 hours. If you exercise one day, the good effect will last for only 24 hours, so you have to continue it. Next, please. Exercise is a medicine, regularly keeps you active, out of chair and off the couch. You can also do that. Next, please. Obesity, coronary heart disease, diabetes, hypertension, cancer. Do you have any answer to these diseases? Do you really think that you can control it without exercise? Next, please. No. Sir, next, please. Sir, a time will come when the patient will be in between and the doctor will be behind, and he will have to push the patient for exercise. So why not to advise? A vigorous 5-mile walk will do more good than all the medicines in the world. Paul Dudley. Next, please. Role of diet in lifestyle medicine. And there where you use a spoon. Next, please. This is what is our diet, junk foods. What are the healthy foods? You see on the left side. Next, please. It is evidence-based now that whole food plant-based diet, healthy Mediterranean diet, DASH diet, low-fat vegan especially, and various vegetarian diets are much, much better than any diet as per different recommendations. Next, please. This is what is a junk food. What American eats is there, and what they should eat is on the other side. It decreases the risk of obesity, type 2 diabetes, heart disease, cancer, chronic diseases, etc., etc. Next, please. Plant-based diets have many, many benefits. I only like to concentrate on, it has got 25% lower risk of ISD. Vegetarian versus non-vegetarian, plant-based diet versus animal food is more associated with other diseases. Appropriate, and mind it, it is appropriate for all the ages and all diseases. If you use plant-based, the doctor will not say, don't take in this disease. Next, please. Possible mechanism, higher fibers, unnaturated plant fats, potassium, antioxidants, etc. It has been seen that there is increased plant-based and animal protein is inversely associated with CV and all-cause mortality. Next, please. This is where PA, physical exercise, and diet is better than each alone. So you have to combine both. Next, please. If we give every individual the right amount and types of nourishment and exercise, not too little, not too much, we have found the safest way to health. Hippocrates. Next, please. Pollution. Sir, we as a doctor should jointly go. We strike for this, we strike for that, but we 4 to 5 kg harmful chemicals each year, each person is taking through different modes. Next, please. The role of smoking. Next, please. I will not go into the details. Smoking is the greatest hazard for all the diseases, cancer, diabetes, etc., and coronary pulmonary diseases. How this sleep helps. Next, please. Adult needs 7 to 8 hours of sleep. Our previous speakers have very well dealt on this. Insufficient sleep is associated with CVD, diabetes, hypertension, obesity, and depression. And drowsy driving contributed to 100,000 motor vehicle accidents. That too in 2008. Now it will be too high. Next, please. Role of stress in lifestyle medicine. Next, please. You see, stress through the hypothalamic, pulmonary, pituitary adrenal system and sympathetic nervous system activation causes CHD, hypertension, mitral stenosis, arrhythmia, and heart failure. Next, please. Stress can be controlled by smiling. So let us smile. Let's keep smiling. Let's be tolerant. Let's tolerate. Let's relax. Don't be tensed. Take it easy. Whatever comes in your life, take it easy. Serve. Service to man is service to God. Maintain silence on every day. Please maintain for 30 minutes silence in your life. Next, please. Your mind will answer most questions if you learn to relax and wait for the answer by looking to the nature and keeping silent. Next, please. Yoga, it's a wonder, relieves the stress and anxiety, positive energy, blood pressure, sluggish digestion, muscle flexibility, strength, endurance, increases feeling of calmness and well-being. It improves immunity, improves longevity, and it improves even sexual ability, concentration, memory, and intelligence. So you must advise your children to go for yoga and pranayama. Possible mechanism of yoga in cardiovascular diseases, again through two pathways. By reducing this stress, sympathetic system, activation of HPA axis, and vagal stimulation is helpful in CVD, cardiovascular disease, diabetes mellitus, HPA, and hypothalamic pituitary adrenal axis. And this has been proved by experiment by Dr. S.K. Manchanda that even ST segment depression improves. Next, please. Meditation. We have 2 minutes. 2 minutes. Meditation and breathing techniques are rare, so you must meditate and do breathing techniques. Next. Role of love and spirituality. Next. The best and most beautiful thing in the world cannot be seen or even touched. They are felt with the heart. Next, please. No, previous. The time spent, this is very important, the time spent with family and friends may be the greatest predictor of our longevity. Our support group, because today the first class of drugs prescribed over the last 20 years are antidepressants. We spend our time with friends and family as a luxury, mind it, as a luxury. After the important, so-called important stuff, it is important stuff. No, sir. Important stuff is to spend time, friends, family, and like-minded people, and spirituality. Next, please. Positive thinking is constructive thinking. It involves considering real solutions, problem solving, objectivity, logic, and honesty. Control of anger, prayer, chanting, worship, laughing, they all are important. Next, please. It is not a rocket science to pray. Next, please. Finally, I realized that this cell phone, why it is called a cell phone? Because you are in the cell. If you could have wires looking to the cell phone, you can do wonder to your health, especially before food and before half an hour before sleep. Next, please. What is the difference between conventional medicine and lifestyle medicine? Patient is an active partner in treatment. Patient is required to make substantial transitions. Treatment is always long. Therefore, he should be advised. Responsibility falls mostly on the patient. Emphasis is on motivation and adherence. Medication may be needed, but if you advise your patients to go for conventional medicine, lifestyle medicine, this will do wonder. Next, please. Lifestyle is the medicine and culture is the spoon. Next. Key to long, healthy life. Get moving. Eat food, not too much, mostly plant-based. Drink red wine if you like. Develop a personal mission statement. Take time to de-stress. Just go, belong. Be a part of a spiritual community. Family first, not the patient. Family first. Surround yourself with like-minded, healthy, spiritual people. Next, please. And this, Dr. Mathur has very amply talked on listening, questioning, building rapport, empathizing, and others. So develop this habit to deal with the patient. Next, please. Again, this somebody told, Yuktaharasya Viharasya Yuktachesasya Karmasu, a person having balanced qualities, taking balanced diet, working regularly, and having regular and balanced sleep-wakeful hours drives away the worldly miseries and suffering. Next, please. So take-home message is prevent diabetes and obesity, stop tobacco, increase physical activity, reduce indoor air pollution, eat a healthy and balanced diet, regulate salt intake, reduce alcohol, normalize blood pressure. So thank you, friends, for your patient hearing. Maybe I have taken a little 1 or 2 minutes more. Thank you.
So we would like to felicitate you.
Thank you very much, sir. You have enlightened us for doing something which we have forgotten to do. And we seldom emphasize in our clinic about these things.
Sir wanted to sit for a few seconds. Can we have a big round of applause for the man who's still running a marathon, I would say, right over here. And as you can see, your applause did make him get back on his feet as well. And that's the kind of motivation and love that we would like to share for him. In the meanwhile, we would also like to give another award for the Lifetime Achievement Award. And for that, I would like to request Dr. D.P. Singh, sir, to do the honors. I hand over the mic to sir.
So after oration of Dr. Y.P. Munjal sir and Dr. B.B. Thakur, keynote address we have heard. We have one professor from this Patna Medical College, Prince of Wales Medical College, Patna, Dr. Professor H.K. Singh, and his father of endocrinology, and he has been awarded by API Bihar chapter Lifetime Achievement Award. Please give him big hands. And because he has got, he has to return back, and we shall honor him with Lifetime Achievement Award. And yes, उनका ये नहीं आया है. अच्छा अच्छा अच्छा. सर मुरुगनाथन सर अभी सर रही बात सर आई ना सर डॉक्टर पाल सर आई सर राजेश उपाध्याय our past president, past dean and doyen of API sir.
With that, we would like to give a big round of applause to sir. We would like to thank sir, and as we take pictures, ये photos Facebook, Instagram पे upload हो जाएंगे, Twitter पे भी, WhatsApp पे तो होनी ही है. At the same time, thank you so much. With that, we would like to now move to our next session, keeping it on time. हमें lunch भी समय पे करने का इरादा है. At the same time, can I request our chairpersons for the next session, Dr. B.K. Singh, Dr. N.K. Singh, Dr. Amit Das, and Dr. Manish Kumar to please join us as a chairperson. We have our speaker, Dr. A. Muruganathan sir, and I request sir to please join us on the stage as well. Can we have the slides on the screen? The chairman, IMA, Hypertension Standing Committee. With the permissions of the chairpersons, can Dr. Muruganathan start his talk?
Hello. It's a proud privilege on the behalf of the API Bihar chapter to have a personality like Dr. Muruganathan sir on the stage of API Bihar. Dr. Muruganathan is a famous personality across the globe, and he has been the past president of API, past dean, and a number of governing agencies take his advice. We are absolutely thrilled to have him on the dais. Please, sir.
Lunchtime, and my talk is going to be home blood pressure monitoring, what is new. I'm really privileged to have the past, present and future leaders of API, right from BP Thakur, and then the present Alka Deshpande, the president Grees Mathur, Dean Jyotirmay Paul, and all the governing council members, past president Dr. Rajesh Upadhyaya and Preetam Gupta, governing council members like DP Singh, Dr. Sangram Pradar, Kulkarni, Jha, and Deviram, so many people. So, the whole API governing body is here. That is the strength of Bihar, and that is the strength and affection by the DP Singh and BP Thakur. So, by talking to all of you, it's like talking to millions of people. Each one can carry message to 10,000 people. So, there are more than 20 VIPs are there. So I think I'm very privileged to give my talk, especially the talk which is my passion topic, which is my heart. Everybody knows home blood pressure monitoring. But unfortunately, nobody really imposes or, does in their practice. Like what BP Thakur said, everybody knows lifestyle modification is important, but how many of us do? Even BP Thakur was saying in the conferences, he doesn't eat. Why? Because in the conferences, we don't give healthy food. We give 3 sweets, 4 oily things and things like that. So what we teach, we should follow. Like that, we must also take up this particular issue of promoting home blood pressure monitoring. Okay, why we should promote home blood pressure monitoring? Home blood pressure monitoring is a reliable, convenient, and less costly and more widely available. When performed according to current guidelines and using a validated device, home blood pressure monitoring provides similar data like ABBM. And it has got also additional features such as nocturnal home BP, monitoring of temperature and environmental factors, which I think other monitors do not have. Also facilitate a more comprehensive approach to the diagnosis and treatment of hypertension and evaluation of cardiovascular risk. Having said that, we got challenges why home blood pressure monitoring is not practiced. That is because of lack of awareness of the clinical value of home blood pressure monitoring. Number 2, inadequate knowledge of home blood pressure monitoring best practices and limited resources and access to home blood pressure monitors. And you would have seen this picture 1,000 times, how to measure the accurate blood pressure measurement, the posture, the conditions. I don't want to repeat it again because everybody knows. Now, what is the reason ESC guidelines? The reason ESC guidelines says home blood pressure monitor is recommended in addition to office blood pressure monitor to improve cardiovascular risk prediction due to better reproducibility and prognostic value than office blood pressure. Home blood pressure is recommended to identify white coat hypertension or masked hypertension. It is also recommended for long-term follow-up of treatment of hypertension because it improves BP control, especially when combined with education and counseling. And as I told you, it is useful for finding out white coat hypertension, masked hypertension, and home blood pressure monitoring is also useful in children. This is a home blood pressure monitoring separate device for children, and it is a separate device for the pregnant women, separate device for the elderly person. I don't see NK Singh here because NK Singh, if he's here, he's sharing, okay. Because if he's here, I'm very happy because the whole of my slides will be there in 2 of his CME group. More than 1,000 people will see. So I think his presence is very important because he can promote home blood pressure monitoring. Maybe considered because of the long-term follow-up children, this is very useful. Again, the masked hypertension I already told you. Then now coming to the pregnancy, home blood pressure monitoring can be a reasonable alternative to conventional office BP measurement to detect new onset of hypertension in women at risk for pre-eclampsia without pre-existing hypertension. Also reasonable alternative for BP control in women with gestational or pre-existing hypertension. And now the new technology. Now we have got home blood pressure monitoring with telemonitoring facilities. This is very useful. See, especially during COVID time, in pandemic times, people did not come to the hospital because of COVID fear. So for those hypertensives, we could monitor them from the home by doing telemonitoring. So telehealth has come into the market now and everybody is using. In fact, the European guidelines, which came last month, has said encourage use home BP monitoring and telehealth technologies to improve care for diagnosis, initiation phase, short-term follow-up and long-term follow-up. And one of the interesting home BP monitor which has come recently is called Night View Blood Pressure Monitor. What is this Night View Blood Pressure Monitor? This Night View Blood Pressure Monitor takes the reading at 2 a.m., 3 a.m. and 4 a.m. So it is a substitute for ABBM because when you take ambulatory blood pressure monitor, it gives disturbance to the sleep because every 20 minutes it inflates and deflates, so patient cannot sleep. So what you record in the ABBM in the night is not nighttime pressure. It is only daytime pressure because the patient is awake. So you must have a patient-friendly BP monitor, and this home BP monitor, which has got a new device which can record 2 a.m., 3 a.m., 4 a.m. The results are as equal as to ABBM. And that is now used in many countries. It is yet to come here, and few centers they use this. And this is also accepted as in many clinical trials. We have done many clinical trials with this new device, and acceptable association with markers of preclinical organ damage. And again, not only that, the home BP monitors also have the technology to record according to the environmental condition and to the specific trigger. If you have a hypoxia or a low heart rate, this triggers the BP, and then you can see the BP recording in this home BP monitor. Now there is one of the patient-friendly cuff has come called IntelliRiff cuff technology, where the cuff is all around the arm so that a patient need not worry about where the brachial artery is. The acceptable range is good. And we have got a very nice article, state-of-the-art review, where the research, development, and communication technology-based home BP pressure monitoring is there, where he has described all these things. Friends, again, very interesting thing. There are 5 or 6 home BP monitors have come, which are very good in recording the nocturnal hypertension. You know, nocturnal hypertension is one of the problems where we don't diagnose nocturnal hypertension with the office BP. Only ABBM can detect nocturnal hypertension. But fortunately for us, now the home BP has come, which is patient-friendly, which can record nighttime BP, so that when you control nighttime BP, you can control cardiovascular risk. What are the nighttime BP has come? One is called Medinote, using the Medinote. In the J-HOF study in Japan, they've done it. And ICT, information communication technology-based nighttime home BP telemonitoring device. And then, as I said, trigger nighttime BP, by hypoxia trigger or heart rate trigger. An ICT-based TNP for night-by-night evaluation. And now, there are wearable device, beat by beat, continuous surge BP monitoring available. And again, WSP trigger also is available. What is the trigger? With a preset of threshold for oxygen desaturation, which is continuously monitored by pulse oximeter, the home BP device is triggered to initiate BP measurements when the wearer's oxygen desaturation falls below threshold. So hypoxia triggered BP monitor. Again, the lowest heart rate trigger function detect the basal nighttime BP. And you can see the severe hypoxia produces BP surge, and then you can record the BP and then treat accordingly. And then ICT-based system for night-by-night evaluation. What is the day-by-day variabilities in nighttime BP profiles due to OSA severity or sleep quality during sleep, as well as by daily behavioral change. For example, if somebody takes more salt, somebody takes alcohol at dinner, at bedtime, awakening time, nocturia, environmental factors like temperature in the room, illumination, atmospheric pressure in the bedroom, all these things can change the BP, and that can be recorded by the novel home BP monitor. You can see this ICT-based trigger nocturnal home BP monitoring. This is spread device where it is connected to BP monitor and also pulse oximeter, plethysmogram, and the patient will have a peaceful sleep. Whenever there is an hypoxia, the BP will rise, and that can be recorded in this monitor. And again, I told you, thermosensitive morning hypertension documented using home blood pressure monitoring. See, we are talking about nocturnal hypertension. Even daytime, the morning pressure will vary. So we have a BP monitor which is thermosensitive. You can see in the monitor itself, the BP is recorded, as well as there is a thermosensitive available, which can record according to the thermal variation. And these are the instruments which are available, which are done by the Japan people and other people. I told you Medinote, triggered nighttime BP monitor, ICT-based monitor, wearable devices. And these are the trials which they've done with these monitors. JTOP trial, Vesipis trial. Nocturne trial is the first RCT of the nocturnal home blood pressure monitoring trial. And then Sunlight trial. All these trials are done by so many other experts in Japan, other places. They proved these findings are comparison with ABBM, and that is a very, very useful. And then I told you about, people talk about nocturnal hypertension. Morning home BP is also very important. because morning home BP also shown to have better reproducibility than ambulatory blood pressure and a stronger correlation with indices of vascular function, especially morning home BP incidence of strokes are more compared to evening BP. You can see this picture, the comparison of the morning systolic blood pressure with the evening systolic blood pressure. The hazard ratio is more for morning systolic blood pressure. And then BP variability. Everybody knows what is BP variability. This home BP predicts both variability and predicts both stroke and CV events and occurrence of total and non-fatal CV events as well as total mortality. And day-to-day variability in home BP also predicts hypertensive target organ damage. And nocturnal hypertension comparison between HBBM whereas ABBM by JHOP, they say nocturnal hypertension detected using home BP also significantly associated with increased risk of future events comparable to ABBM. And then anti-hypertensive therapy. So whenever you manage a patient with hypertensive therapy, give them home BP monitor. What does it do? You know, it is very good for optimal reduction in BP, improve BP control, reduce target organ damage and CVD risk. And also it empowers the patient. So when you do the patient counseling and training, patient is involved. Just like when you give a weighing machine, ask the patient to weigh before every meal, they know their weight is more. So like that, when you involve the patient, the control is more. And then BP reduction and control. Home blood pressure monitoring plays a crucial role in what is called a stepwise, personalized, optimal 24 BP control approach in the management of hypertension. If you see, first target the morning home BP. You control the morning home BP to less than 125 to 75. Then target the uncontrolled nocturnal hypertension by various methods like reducing the circulatory volume, vascular disease, insomnia, especially by melatonin receptor antagonists. So this home BP is a stepwise approach for controlling hypertension. And management of hypertension through telemonitoring. I told you in pandemic conditions and natural disasters, it can be used. Especially in earthquakes and all, the Japan, they managed for nearly 3 months the web-based home BP monitor. And there is a system called HELP system. It's called HELP DHI trial. This includes what Professor B.P. Thakur was saying on the algorithm designed to promote lifestyle modifications in conjunction with the medically validated non-pharmacological interventions. The primary endpoint is the change in the 24-hour SPB. So a HELP system is also there. And these are the wearable devices. Wonderful devices have come, have been validated using currently accepted clinical standards, and one has also shown good agreement with ABBM. This device also provides an environmental condition changes data and useful for detecting arrhythmia, because usual home BP monitor, you cannot detect atrial fibrillation. This can detect atrial fibrillation, etc. A very good, very useful device. The first one, Omron HEM, is FDA approved. Recently they have approved FDA, and a lot of people in Singapore, they go, they buy this and come back. And of course, the guidelines do not recommend still, but it is approved, and slowly, the novel wearable devices are going to be approved. And then there is one more device called wearable device beat by beat. This device successfully detects 3 nighttime trigger BP, like rapid eye movement, arousal, OSA episode. And this is the, again, wrist type tonometry, where you can see the triggered BP changes. And the wearable devices trials also there. So many wearable devices now come. There are a lot of trials which are approved, and sooner it will be coming into guidelines. So far, the wearable device is not approved. Now coming to artificial intelligence. Nowadays, we cannot talk without any artificial intelligence. And Alka Desi mentioning about artificial intelligence. Artificial intelligence cannot replace physicians, but physicians with artificial intelligence can be a better person. So this artificial intelligence loaded with home BP can identify patients at risk of developing hypertension. We can say these are the patients who are going to develop hypertension, and we can predict the CV risk by using the artificial intelligence along with the home BP monitor. And now, one important thing, I think Girish Mathur is here and BP Thakur is here. There are a lot of countries, they have home blood pressure monitoring guidelines. Girish Mathur, please listen. Their home blood pressure monitoring guidelines are not there in India. We got Indian hypertension guidelines, but we don't have HBM guidelines. China has got, Indonesia has got, Japan has got. I'm trying to develop this. If you can permit, we can do, especially when I take over, we'll do these guidelines for home BP, which is very, very good for Indian country. And number 2, the current status of Asia network, if you see, India is lacking. So what is the future directions for home BP? telemonitoring to control BP when close contact is difficult, wearable devices for cuffless, non-invasive beat-by-beat monitoring, generate data to inform artificial intelligence strategies, and devices with the ability to monitor temperature and environmental condition or detected arrhythmias. Because BP Thakur was mentioning about the climate change, this BP monitor also tuned to the climate change. Then the home blood pressure monitoring beyond home. See, you would say home BP monitor, it's not necessary to use home BP. You can use it beyond home, like in a flats or in the shopping mall and in barber shop. Because many people use this barber shop to diagnose BP. And I submitted a paper using this home BP monitor in barber shop, which was accepted in the International Hypertension Society, also the British Hypertension Society, where people accept this as a diagnosis and follow-up. And then the only source of knowledge is experience. Nothing teaches better than our own experience. So ladies and gentlemen, I would like you to promote home BP monitoring in whatever way you want, and promote hypertension clinic. I always say I'm fond of promoting hypertensionologist and hypertension clinic. And then whenever you want to give any gift to anybody in your 60th birthday, or because most people are 68, so that's why I said 60th birthday, give a BP monitor which will be useful for your mother-in-law, father-in-law, son-in-law, and whoever wants. And then I will conclude, the growing burden of hypertension has seen an increase in the use of availability of HBM device. A larger panel comprising experts from interdisciplinary teams, from the obstetrician, pediatrician, as well as GPs, can form guidelines, a comprehensive perspective. Current development and future advance of human HBM technologies, along with the targeted training and education, support their use. Will see home BP monitor continue to feature as an essential component of the continuum of care of hypertension, including diagnosis and both short and long-term monitoring of the response to antihypertensive therapy. It can play a key role in what is known as anticipation medicine strategy. We have a medicine strategy called anticipation medicine strategy, and designed to identify increasing risk, predict the onset of CV events based on series of data and collected over time, allowing proactive interventions to reduce risk and eliminate events. Friends, this lifestyle modification, I conclude with what BP Thakur said: control over his diet, takes regular exercise, has time to relax, does the right toil in discharge of his duties, observes proper hours of sleep and awakening, and is balanced in his actions, reactions, emotions and reasons, duties and rewards, conquers disease. This says Bhagavad Gita. So ladies and gentlemen, learning is beginning of health, learning is beginning of wealth, learning is beginning of spirituality. Thank you very much.
Excellent deliberation, sir. House is open for one or two comment. Or
just to let the chairpersons know, so we are running a little short of time. So if we could move to the next speaker, that would be wonderful. But and sir can definitely meet over a cup of coffee for questions, if that's okay. Just a request. Just a request.
I think if the chairpersons have already invited questions, we should
yes,
allow
we can have one
or two
sure.
questions, please. If you have any question, yes, sir. Dr. Kulkarni, please.
Sir, fantastic oration as usual. Can you recommend a particular model for masses? Because you get BP apparatuses which are from 800 rupees to 8,000 rupees. Right now, I have got a BP apparatus without a tube, without a bulb, but that can be used for exercise BP also. So, are there any conditions suitable for the Indian environment?
In fact, these wearable devices are not yet approved by any guidelines, recommendations. But you know, in the market, we have got Omron, Microlife. If you go to the website, they are the website monitors which are approved by many international guidelines. I think, Greece, we also should call the owners and validate, and we say API guided or recommended BP monitors. Even the simple LED monitors are good enough. So I think we can do a project like this. In fact, I told ICMR, because ICMR was, I'm one of the expert advisor in the senior, the RSD, the Indian Hypertension Control Initiative. I told them we should have a validated Indian monitors. We should call the manufacturers, and API should be there. We can say these are the monitors which are approved and recommended, so that everybody can buy. And now the BP monitors are less than 2,000 rupees. And if you buy bulk, it becomes 1,000 rupees only. So we have, we can easily do that and then market so that everybody can buy and keep it at home.
Can I
Thank you,
request
sir.
the chairperson
We
to
can-
please invite the next,
We can
please?
take more questions during the lunch time.
Thank you so much. Thank you.
We have another very important personality coming on the dais. Thank you, Dr. Muruganathan, sir, for a wonderful deliberation.
I thank DP Singh and other organizing committee under the leadership of BP Thakur, M. Kumar Sharma and other people having invited me and have a part with all the stalwarts of API. Thank you so much.
Thank you so much, sir. Thank you.
Sir.
Nice talk, sir. Now the next speaker is the well-known personality, and he is Dr. Preetam Gupta. He is senior consultant at Fortis Hospital, Shalimar Bagh, Delhi. He is the former president of Association of Physicians of India, Dean ICP 1415, editor-in-chief in Medicine Update 2018, and editor API textbook of medicine 9th and 10th edition. And he has got many awards and responsibility in API previously. To Dr. Preetam Gupta, sir, on hypertension paradox.
Thank you very much, Mr. Chairpersons, learned audience, Professor Thakur, Dr. DP Singh, for inviting me for this essential talk. Yeah, I'm going to talk for next 15 to 17 minutes on hypertension paradox. Most of the talks have been already given through home blood pressure monitoring by Dr. Muruganathan, so it will be much easier for me to discuss. If a cardio-cerebrovascular event, if it occurs before the age of 80, it's a failure of medicine, which Dr. Thakur has already told. I remind a very important, simple case which you, me, and everybody is confronted day and night. A lady, 63 years old, she's diabetic. She has got normal creatinine, normal HbA1c. Her blood pressure in the last 3-4 visits had been below 140/90, and she has been taking hydrochlorothiazide, losartan, and metformin. Now, she develops unconsciousness, lands to emergency room at 4 a.m. and diagnosed as intracerebral bleed through imaging. So, this is hypertension paradox. Despite the BP being controlled, the disease has worsened. No, it is due to BP variability, the nocturnal hypertension, abnormal morning surge, night surge, abnormal dipping, work stress, exercise, etc. So my main talk will be on the nocturnal hypertension. As the prevalence of the hypertension, you all know, varies from country to country, and the control rate is again variable, 10 to 60%. Now, statistics from our country, 142 studies meta-analysis was done by Dr. Achal Atlov from Hyderabad, and it revealed that 1/3 of the people are suffering by hypertension and 1/3 are having normal blood pressure, and rest of the 1/3 are pre-hypertensive. You are all aware of this famous slide, the BP elevation, multiple risks with CV risks. 69% of the first MI, 74% of the CHDs, and 77% of the stroke, and 91% of the heart failure, they are associated with the hypertension. Now, if we can reduce by 2 millimeters of systolic blood pressure, we can reduce the mortality by 7% due to coronary artery disease and 10% for stroke. And if we further reduce by 10 millimeter, we can reduce the mortality to 40 to 60%. Now, the criteria for the hypertension you all know, through ABPM, if the average blood pressure should be more, if it is more than 130/80, and during the morning hours, if it is more than 135/85, and during the night, if it is more than 120/70, this is hypertension. Through HBPM, if it is more than 135/85. Now, coming to the nocturnal hypertension, which is the actual topic which I am going to discuss, most of the topic has been discussed by Dr. Muruganathan through the home blood pressure monitoring. If the blood pressure is more than 120/70, this is nocturnal hypertension. But American Society of Hypertension, ACC, they have further reduced the targets to 110/65. The prevalence of nocturnal hypertension varies from region to region. It is from 7.7% to 77%. Now, coming to the impact of the nocturnal rise of blood pressure on the target organs, it could be clinical, it could be subclinical, It can lead to microalbuminuria, increased urine albumin creatinine ratio, increased BNP and pro-BNP, increased CMT, left ventricular stress, hypertrophy, and coronary syndromes. It can lead to silent infarcts and microhemorrhages, which can produce gray matter and white matter cerebral ischemia, cognitive dysfunctions, early dementias, Parkinsonism, and it can lead to lowering of EGFR. Now, a word about dipping. Normally, there is 10 to 20% fall of the blood pressure as compare of day in the systolic blood pressure. So this is a normal dipping. It is a physiological circadian rhythm of BP. It depends upon, it is related to the mostly central factors like various hormones, catecholamines, ACTH, thyroxine, insulin, leptins, etc. And also on the peripheral factors like normal sleep behavior in patients of sleep apnea, nocturia, arousals in the night. So behavioral factors also affect the nocturnal dipping. Now, depending on the amount of dipping, we categorize into normal dippers when it is 10 to 20%. If it is more than 20%, these are extreme dippers. If it is 0 to 10%, these are non-dippers. And if it rises, these are the risers. So please concentrate over this particular slide. These extreme dippers and non-dippers, they have got the clinical problem, clinical manifestations. Extreme dippers can lead to sudden abrupt rise of blood pressure in the morning, that is increased morning surge, which can produce a rupture in the plaque, which can produce thrombosis or hemorrhages in various regions. Similarly, non-dippers and risers, they produce blunting of morning surge, that's low blood pressure, which can produce again the gray matter and white matter ischemia, postural hypotension, particularly in patients of the old age group, which can lead to fall and fractures, early dementia and Parkinsonism, etc. In the heart, they can produce low myocardial perfusion, which can lead to ischemic cardiomyopathy, coronary syndromes, arrhythmias, and heart failures. In the kidney, it can produce renal ischemia and renal damage. So friends, this dipping is very, very important. Now coming to the morning surge, one word, you all know that there is a slight rise of blood pressure, systolic and diastolic, when the person wakes up. It's about 15 millimeter of systolic and 13 millimeter of diastolic physiologically. But if there is sudden rise of the blood pressure, if it is to the tune of more than 155, then the person is likely to develop cerebral involvement or myocardial involvement. It can produce cerebral hemorrhage or thrombotic infarct. It can produce acute coronary syndromes, acute pulmonary edema, or various arrhythmias. This morning surge is also related to the other factors like cold, exercise, work stress, smoking, alcohol in the previous night, insomnia, and sleep apnea. A word about exercise. Exercise is a very important precipitating factor. You all know our famous comedian, Raju Srivastava, while performing gym, he developed coronary syndrome. And lately also during Navratra, about one month back, there had been about 12 tragedies, 12 deaths in 24 hours while playing Garba. I don't say that it is due to exercise, but exercise is a precipitating factor. Maybe it has been blamed earlier by some people that it could be because of the post-COVID effect. Now, in addition to the morning surge, there is another entity, the night surge. The night surge, again, because temporary rise of sympathetic activity, it occurs mostly in patients of OSA, arousals, REM activity of sleep, and nocturia. So, the dipping is very important. Now, coming to the pathophysiology, There are two main factors: increased salt intake and salt sensitivity, and increased vascular resistance. The increased salt intake leads to increased sympathetic activity, RAS activation, and renal dysfunction. Other factors precipitating are old age, stress, obesity, diabetes, and sleep disorders. Now, this is a very important slide. Please take care of this slide. Increased salt sensitivity leads to increased circulatory volume, and increased circulatory volume will lead to nocturnal hypertension, and this nocturnal hypertension will lead to increased preload, afterload, and left ventricular stress and hypertrophy, which produces various cardiac events. At the same time, increased circulatory volume can produce increased cerebral perfusion, which can lead to hemorrhage and infarcts. Increased circulatory volume will lead to intraglomeralar hypertension, hyperfiltration, and renal damage. Friends, now question arises, why the circulatory volume in the night only it produces this problem? During the day, you all know, there is a pooling of blood in the lower extremities. But when the person lies supine, there is a redistribution of the flow, which increases the circulatory volume. Secondly, there is a transudation of the interstitial fluid from the soft tissues to the intravascular compartment. Thirdly, in patients, especially in CKD, there is salt retention, low salt excretion, and salt retention leads to fluid retention, which further adds fuel to the fire. So increased circulatory volume in the night is very, very important. Another point, another cause has been mentioned is the vascular damage due to increased vascular. It leads to increased vascular resistance. It is due to increased and diffuse atherosclerosis. It reduces the baroreceptor. It leads to baroreceptor failure, which produces sudden rise of the blood pressure in the night, which night surge, which triggers acute events. Now, lot of work has been, now the diagnostic, gold standard diagnostic criteria is ambulatory blood pressure monitoring. But currently, as Dr. Muruganathan has told, home blood pressure monitoring has come into play. The Amron company from Japan, they have invested a lot of money, and they have made a semi-automatic device called Medinote, which Dr. Saab has already discussed. I will not discuss. Lot of work has been done. It has been improvised by ICT technology, telemetry, and WSP trigger. And these are various models available, and lot of work has been done. Now coming to my last part, that is the treatment strategies. The goal of current control of high blood pressure is that there should be 24-hour control of blood pressure, including the night blood pressure, as well as maintenance of the circadian rhythm of BP. Second point is suppression of the BP variability. Now, this slide has already been discussed by Dr. Muruganathan. Our first aim is that our blood pressure during the day should be less than 130/80, and second target is that in the night it should be less than 120/70. The most important cause being the circulatory volume. It can be taken care of by salt restriction. You know, in Indian population, we daily are consuming about 13 grams of salt. It's very, very high. There is a study from Chennai by Dr. V. Mohan, which has been published, which has shown that 11 to 13 gram of salt every Indian is consuming, whereas 5 gram is needed. So salt restriction, diuretics, MR blockers, ARNIs, SGL2 inhibitors, they help in controlling circulatory volume. The vascular damage can be taken care of by the calcium channel blockers, and RAS blockades are combining both. OSA, it leads to increased sympathetic activity, which can be taken care of by positive pressure breathing, CPAP and BiPAP, but in addition, beta blockers and renal denervation. A word about CPAP. In patients of OSA, it has been seen that every patient we are not able to control nocturnal blood pressure in every patient through CPAP. So the ACC and ASH, they have kept as a class 2B recommendation for nocturnal hypertension in OSA. The reason being, by the time we diagnose OSA,
there had been irreversible vascular damage. And the last part is the insomnia, which can be taken by sedative care, can be taken care of by sedatives, melatonin receptor agnostics. So our aim is that our night blood pressure should be less than 120/70, and it will lead to perfect cardiovascular reduction. Lot of trials have been done by HBPM, GA-top study, Noctune study, some sunlight study, which Dr. Muruganathan has said. A word about the drug should be given in the morning or evening time, bedtime. There are a lot of studies, but they are very small, comprising of 100 to 500 subjects, and they are unconclusive. But lately, in August 22, there has been Times trial which has been discussed in Barcelona in European Society of Hypertension, which has, it is a UK-based study where 21,000 subjects were taken, and half of them were given morning dose and half of them given evening dose, and the results are astonishing. First point is they don't have any difference as far as the primary endpoints is concerned. In group 1, there had been, and group 2, almost same amount of deaths were there, which were statistically insignificant. So the drug can be taken at any time, before breakfast, after breakfast, before lunch or after dinner, at any time as per convenience of patient. Second point, they have said that the drug should be 24-hour working. Third point, the drug should be taken at the same time. If one person is taking empty stomach or before breakfast, he should take always before breakfast. And fourth point they have highlighted is there is no harm if you give the drug at bad time. So to conclude my talk, ladies and gentlemen, our aim is to control the blood pressure for 24 hours, including the nocturnal blood pressure and the normal dipping. And though ABPM is the gold standard for diagnosis, which is not freely available everywhere, HBPM with Medinote, the new devices, which is being tried and it should be used. Lot of work is being done, but still more work is required, and long-acting drugs which have got longer half-life, highly potent drugs like amlodipine, perindopril, candesartan, telmisartan, olmesartan, irbesartan, chlorthalidone, indapamide, spironolactone, and SGL2 inhibitor which have got longer half-life should be given. Avoid hydrochlorothiazide, hydralazine, losartan, nifedipine, and labitol. Thank you very much for your patience here.
Chairpersons, your comments?
I think when Dr. Pritam Gupta started with hypertension paradox, I am quite clear that now no paradox is here, but sir, you have so beautifully established the science of this hypertensive paradox, and I think this is very, very important in our day-to-day clinical practice. I think those who have missed will go to on the YouTube because the whole session is live. So I have also shared in our CM India group. So I think over more than 7,000 persons. So I think this was an excellent talk, sir, and I think at the very paucity of time, you are not allowing any questions.
Thank you.
So that for you, over to you, sir.
NK Singh. NK Singh.
I'm here. Hello, I'm here.
Sir, but आपका उन्होंने next गलती से वो डॉक्टर राजेश का दिखा दिया था. So मैं yes. So thank you so much. Can I request the chairpersons and both the speakers to please join us right outside the door, because there's a felicitation ceremony. We would like to give you a memento, take the pictures. Requesting the chairpersons and the speakers to please join us at the felicitation stage, which is specially created for good pictures. Can I request? Yes, sir, you can start, sir. At the same time, can I request our chairpersons to please join us, Dr. Alka Deshpande, Dr. P.K. Maheshwari, Dr. Shailendra Kum to please join us, if I'm not missed. And as you can see, our first speaker, Dr. N.K. Singh, is already on to the dais. Dr. Alka, please give your permission to get started.
It will be rude on my part if I introduce Professor N.K. Singh to this audience. I am a great admirer of Dr. N.K. Singh. He has formulated a CMA group, and I am a member of that. And every day we are waiting to hear something new from him. And he is really keeping the whole group updated in the medicine. Now today he is going to talk on some new topic, which is a new trend. And we are all eagerly waiting to hear from him. Would you like to say something?
Yes, madam. Soleus push-up. I have just heard about soleus push-up. It is most common and useful, especially in diabetes, a static type of exercise, because soleus is a flat and large muscle, and you can utilize it without having any activity, static. So I think he will add many more things in this topic. Sir, please.
Good afternoon. It is a huge privilege for me to having the Padma Shri Alka Deshpande here with co-chair, and I think the whole credit going to Dr. D.P. Singh, which I first thought to talk on the update on the obesity, but he gave me no, you go for the soleus push-up. आपको पता है कि सोलियस पुशअप पे पूरी इंडिया में आई थिंक आई एम द फर्स्ट स्पीकर जिसने इसको पिकअप किया, और फॉर द फर्स्ट टाइम इन द इंटीग्रेटेड इंडोक्रिनोलॉजिस्ट का जो सेशन हुआ था कलकत्ता में, आई स्टार्टेड दिस टॉपिक. सो क्या है, व्हाट इज दिस सोलियस पुशअप? व्हाई इट हैज बिकम सो इम्पोर्टेंट इन 2023? व्हाट आर द साइंटिफिक एविडेंसेज and future and current perspective? थोड़ा सा एनाटॉमी को रिवाइज कर लीजिए. ट्राइसेप्स को पता है आपका, मसल लोकेटेड इन द काफ, यू सी हियर, एंड द सी हियर द फंक्शन ऑफ द गैस्ट्रोनोमियस इज टू एलिवेट द heel known as plantar flexion. द फंक्शन ऑफ, उसी जगह पे अब सोलियस भी दिख रहा है आपको. The function of the soleus is exactly the same. वो भी वही काम करता है, plantar flexion, as the gastrocnemius to raise the heel. The only difference is that it works in a different position with the knee bent. So this is a very important point to learn here. Whenever you're doing a soleus push-up, the knee should be bent. And whole this thing of, I think, sensation in the whole world, this has started after this publication by Dr. Hamilton. So what is a soleus push-up? Why has the world gone crazy for this exercise? He told that it is a potent physiological method to magnify and sustain soleus oxidative metabolism, which improves glucose and lipids. So very important things, glucose and lipids. Again, थोड़ा सा एनाटॉमी में फिर एक बार आपको ले जाऊंगा कि we have got two type of fiber muscles, slow twitch and fast twitch. The muscle fiber types are generally defined by particular myosin heavy chain isoforms that they express, and a skeletal muscle fiber type can have a profound impact on muscle disease, muscular dystrophy, sarcopenia, and the aging-induced loss of muscle mass and strength. The human soleus leg muscle is a type 1 fiber. So second point to learn is कि human soleus leg muscle is a type 1 fiber, whereas the triceps, if I am moving like this is predominantly a type 2 fiber. इससे क्या अंतर पड़ता है? इससे सब अंतर इसी से पड़ता है. Once it is a slow twitch muscle, type 1 muscle, आप इसको करते जाइए, करते जाइए, करते जाइए, you will not get fatigue, number one. Speed of contraction will be slow, and metabolic type will be oxidative. A glycolytic pathway को use ही नहीं करता है, negligible. So this point is very, very important again. So इससे क्या होगा कि when you are using your fast twitch fibers, lactic acid is generated, एनारोबिक रेस्पिरेशन इज देयर, और आप एक सिंकिंग फीलिंग आती है आपको कि मैं थक गया, मेरे से अब काम नहीं होता है। और ठीक उल्टा काम होगा अगर इफ यू आर डूइंग विथ सोलियस पुशअप, दे डू नॉट, ए फास्ट ट्विच generally do not require oxygenation, you know, because there is fewer blood vessels and mitochondria than the slow twitch fibers, less myoglobin resulting in a paler color. So this is happening. और इसमें क्या शक है कि inactivity has become an ever increasing sursa. Although in my diabetic clinic I give 5 to 10 minutes for all my patients in all consultations for doing exercise, still after that only 20 to 30% people do exercise regularly. I think the same thing will be in your clinic also. So during exercise, you know that muscle glycogen is generally the primary carbohydrate to fuel the contractions. That accounts for about 70 to 95% of the carbohydrate oxidation when it is available in normal concentrations. But during period of inactivity, जब अभी आप बैठे हुए हैं, the skeletal muscles accounts only 15% of the whole body postprandial glucose oxidation. This has been seen in non-diabetic controls of similar age and BMI, despite being the body's largest lean tissue mass. And at present, 9 to 11 hours everywhere, people are inactive. So, a large number of studies have come up कि भाई अब बैठे हो तो 1 घंटे के बाद उठ जाइए, 2 मिनट घूम लीजिए, फिर आके बैठ जाइए, थोड़ा जंप कर लीजिए, थोड़ा स्ट्रेच कर लीजिए, ये किया गया है। लेकिन if you go here, if you go the latest research, it has clearly showing even if you combine all these short breaks, the large postprandial lab studies concluded that glucose and insulin were not decreased by standing versus sitting in the postprandial period. So what may be missed is that brief breaks which you are doing, by definition, the brief amounts of contractile activity, and thus only brief periods to potentially benefit from the oxidative metabolism, this is not sufficient. This is not going to tackle the whole situation. So critical question is, can soleus push-up be a solution? Like हनुमान जी मिल गए थे सुरसा को मारने के लिए, क्या सोलियस पुशअप कुछ वैसा कर सकता है? तो फर्स्ट टाइम लेट अस सी कि व्हाट इज सोलियस पुशअप, ये जानना आपको जरूरी है. दिस इज ए फोटोग्राफ व्हिच माय डॉटर इज डूइंग हियर. आई थिंक इज इट मूविंग? या, सो इट इज मूविंग. सो दिस इज अ सोलियस पुशअप. एंड थोड़ा सा ये डॉक्टर हैमिल्टन की वीडियो भी देख लीजिए कि हाउ ही इज डूइंग. I think again it is moving. So this is the correct way of doing the soleus push-up. Isolated plantar flexion when sitting comfortable, जैसे आप बैठे हुए हैं, आप अपने ऑफिस में हैं, आप अपने लैपटॉप पे वर्क कर रहे हो, आप सिनेमा देख रहे हो, घर में टीवी देख रहे हो, and you can do a soleus push-up. So interesting and so easy. So this is a specific type of plantar flexion dependent predominantly on the soleus muscle with some assistance from the gastrocnemius muscle. ये आप कर रहे हैं तो सोलियस इज वर्किंग. सो हैमिल्टन एंड ग्रुप दैट फाउंड दैट वाज ए वेरी टाइट लैब सिचुएशन कंडीशन वेयर दिस रिसर्च वाज डन लास्ट इन द 2022. उन्होंने 270 क्यूमुलेटिव मिनट्स का पुशअप करवाया और 130 का 2 मैं दिखाऊंगा अभी आपको. थ्रू आउट पूरे दिन में तोड़ के करवाया. एंड दे एक्सपीरियंस्ड ड्रामेटिक इंप्रूवमेंट इन ब्लड शुगर रेगुलेशन एंड इन मेटाबॉलिज्म डिस्पाइट द फैक्ट that the soleus is just 1% of the total musculature of the body. So that is the reason this has become a sensation. The soleus is a greater predominance of slow oxidative fibers, I told you, and compared with other leg muscles, this is in the highly controlled studies in rodents, also have found that soleus has a phenotype favoring more uptake of both plasma triglyceride and blood glucose. ये दोनों को खींच लेता है. So slow oxidative muscle has multiple intrinsic molecular and phenotypic features. It favors a specialization in prolonged contractile activity, and this is in part because of the capacity of the using more blood-borne fuels and hypothetically less glycogen in some physiological conditions. So ये तो हुआ कि उन्होंने दिखाया lab conditions में. But when I am talking to this gathering of scientific gathering, Even knowing that the soleus distinctive vascular features are enhancing the delivery of blood-borne fuels and oxygen, relatively high level of hexokinase 2 and glucose 4 transporter, and relatively low concentration of glycotic enzymes and glycogen phosphorylase. What is happening? So just let us, in 2 minutes, see what Hamilton did in the discovery. You can see his lab. I am not going in detail. Please alert me in 2 minutes back before. So he did a 2 type of experiments. One was the SU push-up 1 and 2. एक 270 minutes का था, एक 130 minutes का था. उन्होंने पुशअप कराया and he took कि ग्लाइकोजन को यूज करता है कि नहीं करता है इसको जानने के लिए a total of 60 muscle biopsies की गई. And during the active, the soleus push-up trial subjects never sat inactive for more than 4 minutes at a time while accumulating 270 minutes of soleus push-up contraction. And you can see here कि volunteers all responded well to prolonged कितना भी देर किया उसको fatigue नहीं हुआ, cramps नहीं हुई, joint pain नहीं हुआ, muscle soreness नहीं हुई. And even important to note that volunteers in experiment 1 were typically sedentary. उन्होंने ऐसे लोग को लिया था जो sedentary थे. None of them had a high aerobic cardiorespiratory fitness. So even इसमें details में मैं explain कर सकता हूँ, but the only thing to understand it कि जब इस lab में काम किया गया तो this contraction induced minimal soleus glycogen depletion. तो ये तो clear हो गया, proof हो गया. You can see here if you can want to go to the data. And also they showed that this contraction caused a significant VLDL and triglyceride decrease. And you can see here that minimal contribution from soleus glycogen to the total energy, this was shown, and the glycogen contribution was negligible at both 130 and 270 minutes, it was shown. And the most important finding of the human soleus of untrained adults, it is capable of sustaining a high local rate of oxygen consumption. It goes in parallel with a low amount of glycogen depletion. So this which I was talking has been proved by this experiment, and this is the basis of my talk today. Even if you then compared with the medial gastrocnemius and lateral, you can see here that it was only the soleus was working in this experiment. So comparison of muscle mass has been shown. Even they compared with the running with TMT by doing TMT, but they showed that soleus itself when worked more and more, the results came in favorable way. So this part I will tell you that this contraction improved the postprandial glucose tolerance. And kitna? It reduced significantly by 19 milligram per DL, even 30 minutes के बाद ही, and trending to decrease 10 milligram in soleus push-up 1 exercise. So this is, I think this is a great message that the postprandial metabolic rate after ingesting at 75 gram glucose load and sedentary at 2 levels of contraction. So उन्होंने glycogen को proof करने के लिए उन्होंने फिर glucose tolerance test भी किया और ये दोनों से उन्होंने दिखाया. So if you are interested, you go on the website, you can have the whole PDF freely available. So what I want to tell here that taken together of all these findings, हम लोगों ने ये दिखाया कि soleus push-up contraction were magnifying the normally low rate of carbohydrate oxidation by a very small mass of muscle to the point that it become the most dominant tissue of carbohydrate oxidation in the entire body for the 3 hours after ingesting glucose. जब उन्होंने ग्लूकोज टॉलरेंस टेस्ट किया और 3 घंटे तक करते रह गए तो उन्होंने ये दिखाया. तो ये क्लियर हो गया कि इसमें साइंस है. I think apart from this science, let us now go. These results indicate that the human soleus muscle is capable of raising and sustaining for hours and hours the local rate of oxidative metabolism to the highest level. Even if you compare it with a drug which is going to come up, a beta-3 agonist given at the FDA-approved drug. If you compare with that drug, even that, the soleus push-up contraction were capable of raising energy demand 10-fold older, no evidence of progressive fatigue, no other physiological limitations in the unfit individuals. So this summarizes the whole pathophysiology, how it is working, how it is without using the glycogen, just taking the glucose itself, taking the lipids itself, it is burning it, and it is doing the wonder. But whole of our society is ignorant about this unique thing. So looking deep, why so we are not any guideline you are getting it? The question is, if it is so wonderful, not a single guideline in the world tells you are go to do the soleus push-up. When I gave this speech at the IdeaCon Kolkata, and then they made an exercise concession which is under publication in the DRS, a high impact journal. First time on my talk, and I am also author of that paper, it will be published soon, the soleus push-up has been added for the first time. So what I am doing, because this was not a clinical trial, did not test the effectiveness of a free living life condition, it was not in a diabetic condition, and development of this contraction method provides a unique physiological method that has never been tested before to raise and sustain the muscle metabolism for hours, not minutes. So this is the reason कि हमारे पास data नहीं है. We have not done the study so far, and for in the whole world and whole of this our history of the human, this is for the first time Dr. Hamilton has shown this. So lots of questions are coming up, but as a diabetologist, what I am going to do, that we have planned a research on that. I will tell about that. You can see here, this study only identified some of the immediate responses to contraction. There is need to describe the additional longer-term cumulative effects of an intervention. They did not test this interaction of the hyperglycemic and contraction on the glycogen used by the soleus. So I have just planned a small pilot study for 12 weeks known as SPILD study, and I think our ethical clearance will be soon in the December itself. We are going with the 10 centers. We will determine the impact of 60 minutes of soleus push-up per day intervention after 12 weeks on glycemic control, insulin resistance, lipid profile, and quality of life in type 2 diabetes, and also see what happens with the lipids and other things. So we are doing, हम लोगों ने कुछ ऐसे sedentary लोग को चुनेंगे जो कि एक्सरसाइज नहीं ही करेंगे मालूम है, तो उसको लेके हम लोग करेंगे कि उन पे क्या होता है बिफोर HB1AC होमा IR क्या होती है. ओनली प्रॉब्लम जहाँ की हमारी रिसर्च अटक रही है कि हाई इम्पैक्ट जर्नल विल सेल कि वेदर आपका मरीज जो है सोलियस पुशअप घर में किया कि नहीं किया, आप कैसे जानते हो. वी आर डूइंग, देयर इज ट्रैकिंग डिवाइस आर वेरी वेरी कॉस्टली. वी हैव ए लिमिटेड बजट, सो वी हैव डन, वी विल डू वन with our staff, which will go and see on the WhatsApp, we will on the video control, we will see. So I think to end my talk here, you can also plan such a study, multicentric study. Dr. Hamilton and a study finding provides evidence that the human soleus muscle has the potential to contribute to systemic metabolic regulation. The human soleus can sustain a sufficient metabolic rate for an impressive duration and improve glucose and lipid metabolism. Many questions will need to be addressed in order to understand the full translational potential, and no prospective real-world case control studies exist at present to validate the soleus push-up in the type 2 diabetes. If proved to a realistic in scientific studies, it can pave way to new option for sedentary diabetics. It can be a boon in many situations. But मैंने अपने क्या किया कि मैं कलकत्ता से धनबाद आता हूँ, चाहे मैं अभी धनबाद से भागलपुर आ रहा था तो मेरी तबीयत बहुत ख़राब लग रही थी, सब सिंकिंग फीलिंग लग रहा था, खाना खाने के बाद चला था. मैंने पूरे रास्ते में एक घंटे किया सोलियस पुशअप, एंड आई केम हियर, आई वाज सो एनर्जेटिक. तो मैं 2-3 बार करके देखता हूँ कि रियली इट इज वर्किंग, बट आई कैन नॉट टेल यू अनलेस एंड अनटिल you prove it by the studies and you publish in a high impact journal. But for the first time we are giving you in the guidelines. With that I think this is all the postgraduates, if you are here, nobody is going to sponsor this research. ये आपको अपने करना होगा अपने पैसे से, इसके लिए कोई कंपनी पैसा नहीं दे रही है. So we have to plan something. Thank you very much. Thank you very much.
Thank you, sir.
Thank you, sir.
For exploring the soleus push-up mystery by fiber. Sir, one natural question is coming to my mind, that you have said that in 1 hour of soleus push-up, only 8 kilocalories is burnt. Okay.
Exactly what is happening, we need more studies and studies. But it is by using that, because he is working on the glucose itself and the lipids, we have found that they have found that there is a significant reduction. That P value was statistically significant. So we need more studies to validate all those things, and many new things will come up.
But can 8 kilocalorie energy burn 10 milligram glucose? एक चीज आपने बहुत अच्छा कहा सर कि लेजी लोगों के लिए ये सोलियस पुशअप एक वरदान है, बहुत अच्छी बात है सर। लेजी लेजी आलसी लोगों के लिए, जी सर। Now we are on almost on time, so one or two questions can be invited from the audience.
All right, we've got our next speaker ready. Can I request the chairpersons to please invite our next speaker? Yeah, but yes. उस समय सर मैं को हायर नहीं किया था ना. I don't mind, sir, being a part of that conference. Dr. DP Singh and Dr. Obaid has given me full advance payment, so I am not going to stop. Just keep it on time. Thank you so much, sir.
Thank you.
I welcome Dr. Rajesh Upadhyay, the noted gastroenterologist from Delhi, past president of API, past dean of API, ICP, and he is going to talk to us about PPI. The PPI being used by tons, and it is also available as a OTC product. So the patients little, thoda sa acidity ho gaya karke they take PPI, because it doesn't require prescription. So Dr. Rajesh Upadhyay, we are eager to hear to you.
Thank you very much, madam. At the outset, let me thank the API Bihar chapter for having invited me here today on this very important meeting, especially Dr. DP Singh and Dr. Hemshankar Sharma. And I'm even more glad that I'm talking about something, a drug, which is used day in and day out and commonly known as the gas ki goli. So this gas ki goli ya khali pet wali goli is also very popular. And why we should be careful and use it only for appropriate indications for appropriate time. But before I start, let me tell you that dyspepsia is a very common problem in India, and patients are often distressed by it. Doctors are having difficult time to treat it, but the bright news is that the dyspeptic Indian is actually driving the industrial growth of India. And if you see this slide, the index of industrial production is 2.54 for these drugs as compared to electricity, cement, and sugar. So yes, it is a major contributor. Worldwide, it is being used very commonly because it is used in a whole variety of acid peptic diseases, and it was thought to be a very safe drug, and it is now estimated that the market size of PPIs by 2026 will be a whopping $3.7 billion. The Indian market, as I am told now, is about 8,000 crore market only for this drug. So people go buy the drug right, left, and center and do not stop. They do not even bother to consult the doctor. So over the last decade or so, there have been various reports about the safety of PPI use and the risk of complications. And I think we should all be aware of this. PPI and the C. difficile infections, PPI and pneumonia, dementia, PPI role in cardiovascular risks, PPI in kidney disease, micronutrient deficiencies like calcium, magnesium, and B12, and there has been a lot of literature on bone fractures, particularly hip fractures, in patients using long-term PPIs. So this is 2021, we did a review and published in JAPI because there was a lot of scare going on, and there was a lot of scare particularly from the print media. So what conclusion we came to is that about the safety, the verdict is pending. Most of the studies which had incriminated PPIs were weak studies. We need more evidence before it can be incriminated. But yes, we need to be cautious. We need to use it very judiciously. So what do we mean by judicious use of PPI? Is choose the appropriate PPI for the appropriate indication, use it for the appropriate duration, be aware about the drug interactions, and that is very important, and we should be aware about all the adverse events which I have just shown. So let me just start by comparing different PPIs, and the first PPI to come into the market was omeprazole. So if we keep the potency of omeprazole at 1.0, you will see that esomeprazole and rabiprazole are about 1.6 and 1.8 times more potent than omeprazole, whereas lansoprazole and pantoprazole are less potent. So this is the theory of PPIs. What about the peak time of action of PPIs? Omeprazole is the quickest to attain the maximum effect, and most of the other drugs are about 1.5 to 3-4 hours. What about the cost? Because that is another consideration which we must keep in mind before we prescribe. Cheapest, omeprazole, second, rabiprazole, and then you have the various others. Now, all the previous studies were aimed at sustaining the pH of 4, which was thought to be critical for reduction of the gastric pepsin activity. And if you compare the literature for all the different PPIs, you find that esomeprazole has a 20 to 40% gain when you compare it with all the other PPIs. But does that mean that it has a better healing effect or a better symptomatic response? So in order to understand that, you please look at this slide, and on the left-hand side is day 1, on the right-hand side is day 5, and you find that the green bar, let's say, which is least on day 1, it becomes quite comparable to all the others by the time it is day 5. So the PPI effect has improved and therefore may not have a major effect on clinical healing rates. So more acid suppression may not be necessarily better, and we need to look at the clinical effects, which I will do in subsequent slides. But before that, I think it is important that we look at the drug interactions. And you all know that PPIs are extensively metabolized in the liver with the cytochrome P450 system, the CYP2C19 system. And this is inhibited by omeprazole. Therefore, this enzyme is required for activation of several drugs, including clopidogrel, and that is why you get the interactions. Omeprazole interaction is also seen with commonly used drugs like warfarin, phenytoin, benzodiazepines, etc. Interaction with heart, also we know reduction of protease activity. And remember one thing, minimal drug interaction is seen with rabiprazole and for pantoprazole. So if you are not sure about the interactions, this may be the drug. Also, it is important to know that about 20% of the Indians are either rapid or ultra-rapid metabolizers of these drugs, and therefore require a higher dosage or a drug which does not go through the CYP2C19 system. So that is again another importance. So let us come to the clinical efficacy part now. Summary of the RCTs comparing PPIs in GERD. Well, no study has compared all the PPIs, but if you look at these 26 RCTs involving more than 23,000 patients, esomeprazole, pantoprazole, rabeprazole are all comparable in their symptomatic effect and superior to omeprazole. Endoscopic healing, again, comparable effect is seen with esomeprazole and rabeprazole, which is superior to omeprazole. So which PPI is first question? Well, all PPIs have similar symptom relief and lesion healing rate. The choice of PPI in GERD may therefore be individualized depending on various factors. For patients who are on polypharmacy, it may be preferable to use either rabeprazole or pantoprazole. For poorly compliant patients and those with nocturnal symptoms, for poorly compliant, dexlansoprazole may be considered because it can be taken before or after meals. And it has got a dual release system, so it may be useful for nocturnal symptoms. Recommendations for PPI in GERD: 4 to 8 weeks empirical trial, optimization in partial or non-responders, stop therapy in 8 to 12 weeks, except in patients with erosive esophagitis, severe types, C and D, and of Barrett's esophagus. More than one switch of PPI in non-responders is not recommended. So many a times when a patient is not responding, we switch over to another PPI. You can try that once, but there's no point in trying it more than once. Again, maintenance therapy. Which patient? Those with erosive esophagitis, LA, C and D, those with Barrett's esophagus and peptic strictures. Erosive esophagitis, remember, responds better to PPIs than the non-erosive esophagitis, which is called NERD. On-demand PPIs for those with recurring symptoms. So give treatment, stop. If they have recurring treatment symptom, try that again. Dexlansoprazole, unaffected by meals, have already come. And this newer preparation, which is omeprazole sodium bicarbonate combination, may be useful for nocturnal symptoms. What do I mean by optimization? Well, lifestyle has to be checked, because that is very important in the management of GERD in particular. Check compliance. Is the patient taking the drug? Is he taking it at the right time, which is 30 to 60 minutes before breakfast? And double up the dose if the patient is not improving on it, or switch over to another PPI. What are the indications for high dose or double dose PPIs? Well, those who are partial or non-responders in GERD, healing of erosive esophagitis if the initial treatment fails. Now, those patients who present with extraesophageal symptoms like those with laryngitis, chronic cough, etc., they should be started on high dose of PPIs, double dose PPI. And if you're treating H. pylori, maybe optimization will be better if you use the high dose of PPIs. Again, bleeding ulcers are another indication for high dose of PPIs. Now, dyspepsia is a very common indication for PPIs, and I've shown you all the different types: peptic ulcer, GERD, Barrett's, Zollinger-Ellison, etc. But treatment of functional dyspepsia, which is a common problem in Indian population, and broadly speaking, there are two types. One is the epigastric pain syndrome, which mimics peptic ulcer disease, so they get pain in the epigastrium. The other is called the postprandial distress syndrome, which is bloating predominantly, or early satiety. Now, the role of PPIs in functional dyspepsia has been a little controversial, but it has been shown to be better than placebo. Best response we see is in patients with epigastric pain syndrome, so clearly they may be used in such patients. No significant benefit in patients who have this typical postprandial bloating without having pain. ACG recommendation, which is the American College, they use it as an empirical treatment in patients who are H. pylori negative or for symptomatic post-eradication. Efficacy is comparable to H2RA, but PPI is preferred. But even if the patient is responded very well, try to withdraw the drug in 6 to 12 months. But you should not continue PPI if there is no response by 8 weeks or 2 months. No evidence that doubling of the dose in this condition is not going to be useful. What about the Asia Pacific guidelines? And in Asia, we find that there's a lot of overlap between functional dyspepsia and GERD. Lot of overlap. You'll find that patients who have heartburn also have पेट में भारीपन हो गया, खाने के बाद पेट फूल गया. So they have defined it into 3 groups. The left you see is those who are impaired gastric accommodation or those with bloating type, where they said use the fundal relaxant or the acosciamide. Fundal relaxant may be the first line drug there. Whereas for the others, especially those with duodenal eosinophilia or those with duodenal hypersensitivity, PPI again is indicated. So just to summarize how long, GERD, well, 8 weeks to 12 weeks, but for patients who require long-term treatment, you can go on indefinitely. H. pylori eradication, we started with 7 days, moved on to 10 days, now standard therapy is 2 weeks. Duodenal ulcer, 4 weeks, but it can be increased in refractory cases. Gastric ulcer, 8 weeks, again, may be increased in refractory cases. What about bleeding peptic ulcer? IV PPI at 8 milligram per hour for at least 72 hours. And there is a consensus on this. Gastroprotection in patients who have high-risk diseases and they are continuing to take non-steroidals or aspirin, this may be a long time. Dyspepsia, again, depending on the symptomatic response. Zollinger-Ellison will continue indefinitely. This is a summary, but I will just go straight to the conclusion now. All PPIs are broadly comparable in GERD and dyspepsia treatment. Therefore, the choice has to be individualized based on patient characteristic. So if let's say a patient is not compliant, so dexlansoprazole try kar lein. If the patient is not taking drugs on time, again maybe dexlanso. Cost is a factor, you may consider omeprazole or rabiprazole. Treatment duration, I have clearly said 8 to 12 weeks in GERD, 4 weeks in DU, and 8 weeks in gastric ulcer. Maintenance therapy indications I've already given. On-demand treatment for patients who respond but have recurrent symptoms, for them use on-demand therapy. Nocturnal dosing for nighttime symptoms. Nighttime symptoms, you can either use nocturnal PPI, you can use nocturnal H2 receptor antagonist, but there is a tachyphylaxis effect, so the H2 receptor effect gradually wears off, or you can try dexlansoprazole type of drugs. PPI in functional dyspepsia is based on symptomatic response. If they respond, try to stop after 6 to 12 weeks and stop in 8 weeks if there is no response. And the biggest problem in clinical practice is the patients who go to the chemist and they keep on popping without coming to the doctor, and it's very difficult to get them or wean them off the PPI, but we can try various methods, including alternate day, twice a week, switching over to H2 receptor antagonist. Thank you very much, but before I leave, I will like to make one announcement. You're all aware that Apicon 2024 is being held in New Delhi between 22nd and 25th of February at a wonderful venue called Bharat Mandapam, which was the venue for the G20 meeting. And I would invite and request all of you to please join us there for this great scientific feast. Thank you very much.
Thank you so much, sir.
Thank you, sir. You have completed the whole topic in very interesting manner, and it is beauty of your deliberation I have previously seen. But there is one a small topic, sir. What do you say about the psychosomatic element which is attached in almost every patient of functional dyspepsia? So,
because of paucity of time, I could not go into that. Now, if you look at GERD, there is a esophageal hypersensitivity type of patients as well. And there are clearly defined by doing a pH monitoring. And if the acid reflux is not seen, then lots of time, I would say, neurotropic drugs are used, particularly amitriptyline, etc., has been used successfully. And similarly, again, the same thing you see in patients with functional dyspepsias, very common. All these are a sort of a bag full of issues. But again, use of neurotropic agents in such patients is very common.
Thank you, sir.
Thank you so much. Thank you.
I would like to also thank sir for finishing it on time.
Oh, really?
Yes, so we're just going to get 5 minutes coffee break, and we're going to start with Dr. Rajesh Kumar Jha. Can I have the slide? Yes, because now lunch is also on for everybody, but we will move to the next one as well. Lunch is a running lunch between 1 to 3:30. So anybody and everybody can join us for lunch. And I would like to thank the chairpersons and the speakers. The speakers, please, you need to collect your mementos, take the pictures just outside the door. Mahi and the team. Mahi, बाकी के जाओ ना उधर, वो बुला रही है, क्या कर रहे हो? ये क्या बाहर? Just on the left hand side. Yes. The next session is going to be by Dr. R.K. Jha. So, लाइव कर दे उसको. हाँ, let it be. Hi, good morning. किसके सर का? इनके सिंगली वहाँ पर पढ़ा है क्या? बोलिए ना।
ये जो है ना हॉल बी में जो ये चल रहा था प्री पेपर का रिजल्ट है, दिस बॉय हैज स्कोर्ड हाईएस्ट।
ठीक है,
ये
ये मैं डॉक्टर मनीष को मैं
मनीष को ही दे दीजिएगा।
हाँ।
और ये एक एक्स्ट्रा था, ये भी ले लीजिए।
ठीक है,
ठीक है,
Thank
मैं
you.
फ्री हो गया।
यस सर, थैंक यू सो मच। डॉक्टर सिन्हा, ये It's time to get started with the session, and we would like to have all the delegates inside. I would request our chairpersons with us. And we've also got Dr. U.B. Singh, who's also graciously accepted to be the chairperson for this session as well. Or we've got Dr. Rajesh Kumar Jha all the way from Indore as well. We would like to get started with the post-lunch session. And to do that, can I request our chairpersons to please join us? We have Dr. Sinato, thank you so much, over there. Dr. U.B. Singh is also there. Dr. U.C. Jha and Dr. Professor Himanshu and Dr. P.K. Bhattacharya as well. Dr. R.K. Jha, who's going to be our speaker. I request sir to please join us on the stage. With the permissions of the chairperson, can sir start his talk? Yes, sir. Total time is 20 minutes. Timer 17 का है. 15 पे buzzer बजेगा. 2 minute concluding के लिए फिर से buzzer. Thank you so much. Yes, sir.
Dr. Rajesh, Professor and Head, Aurobindo Medical University, Indore, is a well-known person, a good academician, a good clinician, patient and student friendly. He is coming to us with some details of broken heart. Okay, Dr. Rajesh.
Thank you. So one part is there. I will try my best to finish within time so that there should be no time constraint. And as the topic is broken heart syndrome, as name is there are so many names, although there is no postgraduate is there, but for their purpose there are so many LICs like Takotsubo cardiomyopathy, stress-induced cardiomyopathy, transient left ventricular apical ballooning syndrome, then apical ballooning syndrome, broken heart syndrome, and ampulla cardiomyopathy. These are the name which anyone can ask in the examination, and you must know with the name. And as the name is happy heart syndrome with the COVID, this happy heart syndrome is more common. Purpose is simple. During the COVID period, usually happy hypoxia term was known to everyone. Similar thing is there here. Both the thing, stress and happiness, that may cause sometimes broken heart syndrome. Now, this Takotsubo cardiomyopathy first described in Japan in 1991. And this cardiomyopathy named after the Takotsubo, which is an octopus trap. Usually shape of the trap is similar to the appearance of left ventricle apical ballooning noted in patients with this form of cardiomyopathy. So if you will see, it looks like the octopus, and usually when left ventricle apex is having the ballooning, it mimics like that. For that, this two photograph is there. The B is basically Takotsubo trap-like picture, and when the left apical ballooning is there, it mimics like that. So this is the two things that has caused this name. Then, what is the clinical mimicry of the acute coronary syndrome? It looks like, presentation is that I will deliver, it will looking like exactly as acute coronary syndrome, and 2% of the total chunk of acute coronary syndrome is accountable with this cardiomyopathy, and mortality range is 0 to 8%. The happy heart syndrome, although it is rare, and among the Takotsubo cardiomyopathy, 1.5% is having this part, and it is more commonly seen in men. Usually, initially it was told it is the disease, a special disease of the postmenopausal woman, and more than 80% of the cases are female, and mean age was 58 to 75 years. But the new era is telling it is also seen in the male. Reason is simple, they are having the more stress, and particularly with the early year, they are having the stress that may cause this part. Then what are the triggers? Either there may be a stress like death of the loved one, or some catastrophic news, then devastating financial losses, or natural disasters, physical illness, or ICU admission like thing. These are the triggering factors. If there anyone, loved one, or the close kith relatives is having the admission, or they may suffer from this financial loss, that may trigger this problem, and then patient will come with this presentation. Now there are certain pathogenesis. It is all these are postulated. There is an excess of catecholamines. That is, norepinephrine levels are elevated in approx 75% in some studies. Plasma catecholamines are significantly higher than in cases of myocardial infarction, and may induce microvascular spasm or dysfunction, that is myocardial stunning or direct myocardial toxicity. So these are the things that will mimic like that. Then limited endomyocardial biopsy data consistent with the histological signs of catecholamine toxicity. The next one is coronary artery spasm, and third one is microvascular spasm. So these are the postulated hypotheses. So what are the presentation? Usually it mimics like acute MI, what I have already told. So it is substernal chest pain will be there, and if you will go for the ECG, in that you will get sometimes ST elevation. Usually anterior pericardial leads are the commonest one, where 82% patients is having this ECG change. Sometimes it is ST depression, T-wave inversion, and QT prolongation, as well as abnormal QFs, and there may be chance of bradyarrhythmia or tachyarrhythmia. So these are the common changes in ECG. Then if you will see the cardiac biomarkers, these are also elevated. Patient may have not only chest pain, rather the patient may develop dyspnea, sometimes shock or syncope-like clinical presentation may be there. What are the ECG changes? That we can see in lead 1, you are getting the ST elevation and T depression. Similarly, in the V4, AVL, V2, V5. So these are the changes which mimics like acute coronary syndrome. Now, what are the complications of this Takotsubo cardiomyopathy? It is tachyarrhythmia sometimes, and bradyarrhythmia may be there. Sometimes patient is presenting with pulmonary edema, cardiogenic shock, transient LV outflow tract obstruction, mitral valve dysfunction, acute thrombus formation, and a stroke may be the presentation. Although 0 to 2% is the death rate, but sometimes it may develop, although usually the death rate is seen in earlier weeks. That we will see in follow-up slide. Now, how to evaluate the patient? Because presentation is similar to acute coronary syndrome, so proceed to cardiac catheterization or PCI can be done, and if available, fibrinolysis can be done. But LV ventriculogram or echocardiogram can both be used to visualize apical ballooning with akinesia or dyskinesia of apical half to two-thirds of the left ventricle. So if you are getting the changes are with the left ventricle, that 2 in the apex, either it is half or two-thirds, either akinesia or dyskinesia, you may think for this Takotsubo cardiomyopathy, and that part should be visualized. And usually in the recent time, if the patient has developed today or 2 days back, then LV ejection fraction may be reduced 20 to 49%, but gradually the ejection fraction will improve. If you will see the ventriculography and echocardiography, that will allow the evaluation of left ventricular outflow tract obstruction, and approximately 16% of the patients are having this presentation. If you will go with the cardiac catheterization, that will reveal the lack of flow, limiting coronary lesion or evidence of plaque rupture. So, what are the things that we will see in this photograph? The apical ballooning seen in C and D that we have shown in the previous slides also, and the angiography can be normal also. Now, what is the radiological evidence that can help in establishing this condition? That include echocardiography. Then echocardiography shows abnormal movements in the walls of the left ventricle. The main abnormality in Takotsubo cardiomyopathy is ballooning, and that is in the lower part of the left ventricle, particularly the apex. And during this systole, this bulging ventricle resembles the Takotsubo octopus and trap used mainly by the Japanese fishermen. On that name, it is named. The average LV ejection fraction that I have already told, 20 to 49%. If you will go with the MRI, the cardiac MRI may be required in a few cases. 4 distinct patterns of dyskinesia and ballooning are recognized. It may be apical, that is most common, sometimes biventricular, midventricular, and basal may be. There is typically an absence of late enhancement on delayed contrast sequences, which helps in differentiating Takotsubo cardiomyopathy from anterior wall STEMI. Now, how to manage this case? As usual, you must have the supportive treatment, and conservative therapy should be the primary job. In that, you may avoid the stressors and adequate hydration as per left ventricular ejection fraction. Thing is there, you must hydrate the patient. But one part is there, if the pulmonary edema is there, if the ejection fraction is higher, then when in hydrating, you should think how much fluid can be given. Then treat LV dysfunction by either using the beta blocker. When you are using the beta blocker, you must be cautious. If the heart rate is more, then you give the thing so that the heart will get a bit rest and beta blocker will act. But if the patient is having the pulmonary edema, then give the beta blocker with caution. Then S inhibitor and ARVs can be also utilized. The diuretics, if the volume overload is there, meaning by if the failure part is there, digoxin, SGLT2 and ARNI are the other stalwart that can be utilized according to the patient condition. Then as the anxiety should be there, to reduce that, anxiolytics should be used, and that will decrease the adrenergic surge also. Then for pain, the aspirin can be given and usually treated for 6 months. Thing is there, it should not be beyond 6 months. You can give up to 6 months, and to reduce this aspirin should be given to reduce the risk of thromboembolic events. Regarding the prognosis part that I have already told, overall good prognosis. If patient survives the acute phase, the long-term prognosis is excellent, number 1. Number 2, if the patient is admitted, usually patient should be admitted in the ICU, and patient should be cared for first 3 days. Then patient should be for 3 to 7 days if the patient will survive. Then for 2 to 4 weeks, patient should be monitored as outpatient. and 0.08% in hospital mortality, likely closer to 1.2%. Recovery of the left ventricular function typically comes back by 1 to 4 weeks and may last up to 6 months. That is the maximum part. And late sudden cardiac death is the rarity. So you have to treat the patient, caution the patient, warn the patient for first 4 weeks. Then generally due to the arrhythmia and recurrent disease, less than 10% have been reported, so that part should be taken care. These are my references. Thank you.
Thank you, Dr. Rajesh. You started with broken heart and finished as a happy heart syndrome. So, any question from from anyone is invited. If anyone wants a question, please raise your hand and ask the question.
Yes, sir.
So I didn't hear the Upadesh of Dr. Jha Sahab. But tell me one thing. If you are practicing in a remote area where forget about PTCA and angiogram and whatnot, what do you advise to a remote doctor working in a rural area if he finds that he has got a case of acute myocardial infarction documented on ECG, what steps he should take?
If you are asking if the patient is having acute coronary syndrome, because if the patient is having the acute coronary syndrome, that should be treated as usual path. But if the patient, this is not the case of acute MI, sir. It mimics like MI. But for MI, at least if the patient is remote, in Tamil Nadu, government has allowed all the doctors to give the aspirin, give the clopidogrel, give the salmeterol. And because at that place in Kerala and Tamil Nadu, most of the patient is getting free angiogram. And if a stent is required, it is also free. So just to reduce that, in API, we have seen 3 or 4 years back, there should be given this primary treatment, that is the OPD basis, and thrombolysis is also available nowadays in OPD basis. But your question is pertaining to the rural belt. Thing is that, sir, science is changing, so it is better to diagnose it clinically. It should be verified by your investigation part, and if the 2 is there, then you should treat as if the normal treatment. Yes. And if it is not so, in this case, the history is most important. If the patient is having the history, it mimics like that, only end result is better in this case.
Next slide. हाँ ठीक है, next slide कर दे अजित.
सबसे बड़ी बात सर का जो टॉपिक था, नमस्कार सभी को, मैं डॉक्टर आर के झा, स्पीकर भी सर डॉक्टर आर के झा ही हैं. एक सबसे बड़ा मैसेज जो इसका है कि ब्रोकन हार्ट सिंड्रोम को हम लोग जितना लाइटली लेते हैं और जितना मेडिकोज में ये है कि जब दिल ही टूट गया तो जी के क्या करेंगे, नहीं, देयर आर मेनी ऑप्शंस कि जिससे हम लोग उस ब्रोकन हार्ट को फेविकोल लगा करके जोड़ भी सकते हैं. तो इसलिए इतना निराश नहीं होना है. ब्रोकन हार्ट सिंड्रोम है तो उसका भी इलाज होगा. इतना ऑप्शन सर ने बताया है, हम लोग कोशिश उसको हम लोग आत्मसात करें, यही हमारे लिए बहुत बड़ी बात होगी. धन्यवाद सर, आपका बहुत बहुत, इतना अच्छा कार्यक्रम आपने ये किया.
Dr. R.K. Jha is coming from the famous place, Indore or क्या sir?
Cleanest city. Cleanest city.
Yeah. महाकालेश्वर का आशीर्वाद लेकर के आए हैं. एंड वहां से ब्रोकन हार्ट की बात करना ही जो है बेकार है.
सर इसीलिए इसका दूसरा
हार्ट ब्रोकन नहीं हो सकता.
इसी का जो दूसरा नाम है हैप्पी हार्ट सिंड्रोम का करके. So it is not so, it is only broken heart.
Yeah.
Finished with happy heart. Yes, purposely it was done, because these are the LSS.
Okay. Thank you very much for your.
बच्ची कुछ पूछना चाह रही है सर, most welcome. उसको दे दीजिए सर.
All right. Quick one, quick.
After giving treatment and if LV ejection fraction recovers, patient recovers from that and patient becomes asymptomatic, will we still continue giving him medications for LV dysfunction
No,
for
no,
lifelong?
no. If your diagnosis is perfect, if you are thinking like that, then after 6 months, nothing to be worried, nothing to be given for this part. But if the patient is having some comorbidity, then you have to treat.
Okay, sir. Thank you.
Thank you so much. With that, we would like to move to the next one. Can I also request our chairpersons, as we are already there, just wanted to invite them again. We have Dr. R.K. Jha from Darbhanga as well. Yes, thank you so much for joining in. And Dr. Samarjeet Banik sir is also there. If he is here, please. Thank you, sir. आप please, अगर आपने खाना खाया? He would, yes, we would like to definitely be hospitable. Dr. Devi, all right. So, उसके बाद, yes, so दो talk और हैं उसके बाद. So I request Dr. Devi Ram sir to please start with his presentation.
Thank you very much, honorable chairpersons, learned delegates. 10 minutes before, when I entered this house, my heart was really broken. Believe me.
Hello, sir. From chairpersons, you are requested to stop your talk before although your introduction is not needed.
Oh, sorry.
For the courtesy and for the process, I have to follow this protocol. Dr. Devi Ram is a legend person, not only for Purnia or Bihar, but he represents the Bihar in API, National API. He was the chairman, he was the president or chairman of Bihar API also. And he represents the governing body in API, National API, still now. And so far as his contribution, he came from England 30 years before. At that moment, Purnia was a small city, and there was no scope for cardiac diagnosis. First time he introduced the echocardiography at Purnia, and we came to know that what is the ejection fractions and what is the left ventricular hypertrophy by this EA, what is the ischemic heart disease by the echocardiogram. This is the most contributions Dr. Devi Ram has done for Purnia peoples 30 years before. And just I asked to Dr. Devi Ram sir, as 2 days before he celebrated his birthday, adopted the 61 TB patients for 6-month therapy with nutritious diet and vitamins. He is the just represented Purnia, and we will have the clapping for him.
Thank you.
Thank you.
Sorry, chairperson, I missed that protocol. So, honorable chairpersons and learned delegates, a very good afternoon to all of you. Being virtually a part of API Bhagalpur, due to close proximity, geographically, and dil se, I take opportunity to welcome you all. Particularly, we are indebted to our distinguished faculty from outside Bihar, who has taken enormous pain to attend and bless this conference. Over the years, and also in this grand conference, we have been enriching and updating each other's knowledge to improve patient's care and his health. But for a change, for next few minutes and so, we shall be discussing to improve our personal care and health and quality of life. Hence, I sincerely request you all for your kind attention for a few minutes and your kind views and suggestions at the end of my talk. At the outset, I wish to be excused for any of my views and points to which you don't subscribe and don't agree. The talk is living with growing age, particularly for doctors. मैं गीता पर शपथ खाकर बोलता हूं कि मैंने कुछ भी कहीं से नहीं लिया। उल्टा कैसे चल रहा है भैया? दबो भैया, इतना होशियार रहते तो बुढ़ा ही होते। हाँ, और ऊपर राइट। भागवत गीता के 2nd chapter verse 27, जत से ही ध्रुवो मृत्यु ध्रुवो. In other words, one who is born is bound to die. And as you grow old, sooner or later, you tend to have these signs of aging, unless you are lucky enough not to have these. That's decreasing vision, hearing, sleep, teeth, appetite, muscle and bone strength, declining function of lungs and heart, kidney and muscles, and wrinkling of skin, loneliness and depression. In addition to physical, there are many mental and psychological changes with aging, along with other social problems at times, like loss of loved ones, children leaving home and settling elsewhere, or problem in their settlement and their family life, etc. So, if aging is inevitable, can something be done to minimize its impact? Of course, we could minimize its impact and make the aging graceful. Staying healthy and feeling your best is important at any age, and you very much deserve it. And following tips taken from my personal experience in the family and society and in the town can help to cope with changes that accompany with growing old and live life to the fullest and graceful. It is said that prevention is better than cure. Hence, various ways and precautions at times, though might appear trivial, taken with advancing age, could prevent many serious disasters. In fact, the effects of aging start from home. Healthy parents, healthy pregnancy is important, and if the child is born underweight or overweight and or affected by bad habits of parents like obesity, overeating, smoking, alcohol, diabetes, child's aging effect is likely to be bad. Through various stages of life, from childhood to adulthood to elderly, we need to follow healthy lifestyle, which has been discussed at length in the morning by Professor B.B. Thakur as well. जैसे अच्छे संस्कार बचपन से बनते हैं, वैसे ही impact of aging could be reduced by care from बचपन. Longevity of Indian doctors is only 59 years, unfortunately, less than the general population, which is 68 years plus. And recently you might have heard young, energetic, famous doctors dying in their 40s. So question raised is why? In my opinion, reasons might include followings: work and work and work, either no or least rest. European working hours are 34 hours a week, Saturday half day and Sundays off. But no need to say what's working hour of some of us. We work even on Sundays when even shops remains closed. At least one relaxing holiday yearly is must for Europeans. You must have seen them lying on the sea beach with goggles and a book and magazine and a bottle of beer. But when we go for holidays, it's just tabartod. Mathura in the morning, Agra by evening, and so on and so forth. Bad food, carb and fat-rich foods, bad and irregular timing of meals, and fast eating. Excessive indulgence in alcohol, खास करके बिहार से बाहर चले गए तो एकदम टूट पड़ते हैं कि साला क्या मिल गया, इसको आज पूरा बॉटल ही खत्म कर देना है. Smoking, tobacco, etc. We seldom smile. While working in UK, I saw most of the consultants, nurses and whatnot, they keep making jokes with the patients, relatives and others. But we seldom smile. We remain rather serious in our clinic and day-to-day life and never make jokes with patients, attendants, family members and neighbors. When गांव की औरतें चमकती हुई साड़ी पहन के आती है, I often ask them, कता से खरीद लिए ही? हम भी अपने बुढ़िया के लिए खरीदेंगे. That one sentence is probably enough to have a nice connect with your patient. Rather than being irritable and serious, we need to enjoy our job. Laughter and smile is the best medicine for body and mind. Unnecessary tension, thinking about trivial things, thinking more about others than ourselves. Tension of serious admitted patients, bad behavior, threat and demanding patient and attendance, which has become a culture nowadays. Doctors dealing in emergency department and ICU, etc., do worse. So what should be the aim of our life? Earning, 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 and earning. You need to, I need to, we need to maintain the balance sheet of life as you file income tax at the end of the financial year. And being a Marwari, who else could tell you better than the balance sheet? Ex-CEO Coca-Cola, Mr. Brian Dyson, after 40 years of his corporate experience, delivered an important speech that we keep playing with 5 balls in our life. One of these balls is of our work, which is made of rubber. Others are family, friends, health, and zeal, utsaah, made of glasses. If rubber ball falls, which is of work, then it will bounce back as one keep getting chances to work. But if other balls of glasses fall, then it will break into pieces and could not be repaired. Profession and money isn't everything in the life, and that has to be very clear in our mind. I wish to be excused if any of persons sitting here don't take it like that, but this is the sole cause of fall in our integrity and credibility. We have to put some comma and some full stop somewhere in our life. One of the richest person in the world, Warren Buffett, was asked on his 50th marriage anniversary about secret of his successful married life. He replied that almost every day he takes dinner with his wife and then walks for 30 minutes. And he continued to do so with their children and used to teach them daily for 30 minutes so that they could learn the value of family life and their culture. And what we do, एक अच्छा सा ट्यूटर बोर्डिंग स्कूल में बच्चे को डाल दिया and our responsibility is finished. और बड़े प्राउड से बोलते हैं कि हमारे बच्चा तो फलानी जगह पढ़ता है. This is a real story. A busy doctor from nearby area of Purnia took 5 appointments with me at his convenience for his wife's consultation, but he couldn't make it. And at last, dropped in my clinic without any appointment at my most inconvenient hour, which is between 3 to 5 p.m. when I go to take rest. Still then I obliged, and eventually he did send her investigation reports by his staff next day, which showed lot of abnormality and absolutely rubbish care of diabetes with HbA1c of 10.5. I just wonder that if one hasn't got time for his wife and children, then what for one is working and earning. I have no regret in saying कि हमारी हालत some of us सबसे खराब है. The aim of life, of course, should be to relax and enjoy and take adequate rest. Probably have earned enough, and we are not going to be Mukesh Ambani anyway. We need to change our priority as we grow old, readjust our time to take care of our physical, mental health, fitness, and beauty. You are the most important person for yourself. You are the most important person for yourself. Treat yourself as king and queen. Take care of your beauty. My son has established in Siliguri, he is a radiologist. And every time I go, which is virtually almost every month, my potaji will take me to the beauty parlor. कि दादू थोड़ा आपका मैनिक्योर पेडिक्योर ये सब नाम भी पहले मैंने नहीं सुना था, ये सब करवा ले. Then there is a sauna bath and steam bath. Go and enjoy it. Use moisturizer for body and skin, and dress colorfully and smartly. I would say that those who can easily afford, this is the time at the age of 65 plus, buy the most expensive branded clothes and glasses and watch and use it. There are few more things which we probably अपनी जवानी में नहीं कर पाए. Pick up, कितना बहुत टाइम चला गया क्या? 30 seconds. So pick up the long neglected hobby, travel somewhere, spend time in nature and fishing. Most of us don't have time to sit with family and play with our children and grandchildren, so love them and play with them and spend quality life. I would like to take only 2 minutes. Don't ignore your medicines. Particularly, don't depend on MR supply. Always use drugs of most reliable company. If you are a diabetic, take special care of hypoglycemia. Do some social work and take steps to avoid falls like using rally while going up and down, using large and wide anti-skid floor mattresses, use lassless comfortable shoes, install hand rods to support when getting up in bathrooms from commode,
Apologies.
use sensor light which switches on and off with body motion in bathroom, and keep foot lamps on throughout the night in the bedroom. Be careful when you get out of the car,
Particularly when getting out of the wrong sides.
and यार इतना टाइम थोड़े पास कर गया.
सर हाँ सर नहीं वो तो recorded भी है मैं आपके
Anyway,
साथ समय ऐसे ही
the
चला जाता है.
lifestyle modification has been discussed in great length in the morning by several speakers. About your food, main concern is protein, which must be a gram per kg, and the good sources are paneer, eggs, dal, and fish. Take care of vitamin D and calcium and B complex, and these common problems of elderly, constipation, urinary problem, eye problem, ears, memory and thinking must be taken care of. And you must not ignore recent onset of breathlessness, investigate for cardiac cause, loss of weight and appetite and anemia, go for tumor marker, and do not forget vaccination against influenza, pneumococcal, herpes zoster, etc. etc. Thank you very much.
Thank you so much. Since we are running short of time, we will not have any Q&As. Also an update, we're going to have Dr. Raja Dhar going in next. And then this is going to be the last talk for this session. After this, all the chairpersons and the speakers will be requested to please present the memento. Can I request Dr. Raja Dhar sir to please join us on the stage? And I can see Dr. Raja Dhar running in because he knows time is of the essence. And I'm not going to cut his time, 17 minutes. And with the permissions of the chairpersons, can he get started, sir? If you give a thumbs up, bhi chalu kar denge, mujhe lagta hai. Yes, thank you so much. Dr. Rajadhar, you can get started.
Thank you very much. Absolute pleasure. So I can see Shantanuda here, Dr. Singh. Thank you for inviting to this meeting and making me feel at home every time I can come to Bihar, Bhagalpur, etc. So this is what I'm going to do in the next 20 minutes. I'm going to speak about challenges of interstitial lung disease, and I'm going to try and give you an Indian perspective. I've got about 50 slides, so I want to stick to my 20 minutes, and I'll race through the slides. A lot of what I'm going to say is known to you, but I want to put things in your clinical perspective so that you can take home some messages which you can use in your clinical practice from tomorrow. So when you see someone with breathlessness in your clinic in front of you, think of the patient as belonging to one of these 5 verticals. So pulmonary and cardiac are the most important ones. And these studies, longitudinal studies, which have shown that about 80% of patients who come to your clinic with breathlessness either belong to the pulmonary or the cardiac vertical. And then there are neuromuscular diseases, vascular diseases. In the box of others, you have anemia, anxiety, obesity, etc. Let's focus on pulmonary because that's where I'm going to speak about. So in pulmonary, widely speaking, broadly speaking, you would think about obstructive airways diseases and restrictive airways diseases. And when you think about obstructive diseases, you think about asthma, COPD. And when you think about restrictive lung diseases, you think about interstitial lung diseases. How I would do it in my clinic is to listen to the chest. So use your stethoscope, and I'll show you a little bit of data in a bit about how the stethoscope is going out of vogue, wrongly so. So if you hear bilateral basilar crackles at the bases, you've got a diagnosis of interstitial lung disease. You've even got histology. Most likely, this patient has got a UIP pattern of disease. So bilateral basal crackles, you hear on auscultation, it's almost diagnostic, not just of ILD, but a UIP pattern. And then you do investigations to find out whether the UIP is IPF or UIP from some other cause. If you have a typical HRCT thereafter, you have a confident diagnosis of interstitial lung disease, and then you can define the subtype of interstitial lung disease thereafter. So let's take a step back. How do you diagnose and investigate a patient of suspected interstitial disease in your clinic? So you, of course, do a history and clinical examination. You ask about occupation. You ask about drugs, exposure to sort of triggering factors like pigeon exposure, air cooler exposure, etc. Once you've done all that, you would do a chest X-ray and a spirometry. If the spirometry is restrictive, if the chest X-ray is suggestive of some interstitial opacities, or even if it's normal, and you've heard the crackles that we spoke about on auscultation, you confirm the diagnosis. You confirm the diagnosis by a CT. You do blood tests trying to find out the cause of interstitial lung disease. And once you have a confident diagnosis, you do assessment of severity with tests that are listed on the left in front of you. So your full lung function test, your 6-minute walk test, overnight oximetry, etc. Once you don't have a confident diagnosis, you can think about doing a BAL, and you think of doing a biopsy. There are various ways in which you can do a lung biopsy. You can do a cryobiopsy. You can do a transbronchial lung biopsy. You can do an open lung biopsy. It depends on the infrastructure where you're working. But the number of patients who require a biopsy are going down as we go along. And then to add all of this together, you have a pulmonologist, a radiologist, a pathologist, maybe a rheumatologist, all sitting together to do what is called an MDT assessment. So that's how you work up a patient of interstitial lung disease. So that's about ILD. 15% population, according to the Indian Registry of Patients with ILD, will have IPF. I'll say that again because it's important. About 15% of patients with interstitial lung disease in India have what is defined as idiopathic pulmonary fibrosis. So what's the diagnostic algorithm for IPF? You have someone who's suspected of IPF, maybe based on listening to the chest. You try and identify the cause. Is this connective tissue disease? Is there drug exposure? Is there occupational exposure, etc.? If there isn't, then it is not IPF. If there is no identifiable cause, you would do an HRCT. You would actually do an HRCT anyway. And there, based on the HRCT, you define the patient as having IPF. And if it's non-UIP, it's a non-IPF diagnosis. I'll hold that slide for 10 seconds. So what I'm telling you is, when you see a patient, all you need to define is this patient IPF? Is this patient non-IPF? The rest of it, for a physician or even a middle-grade chest physician, is unimportant, because the distinction between IPF and non-IPF can easily be made on the basis of a CT and a set of investigations, and it also helps to prognosticate your patients further. There's the position of surgical lung biopsy, which is required in 10% of patients. And then once you've classified these patients into IPF and non-IPF, you can prognosticate in these patients. So the valuable question here is this UIP versus everything else? Why is UIP IPF so important? It's important because the prognosis in the two diseases is very, very different. And I show you the prognosis here. So on the top, you have patients who have a non-IPF diagnosis. So you see the upper line on there, a non-IIP diagnosis survives far better as compared to someone with IPF who, even with treatment, has a lifespan of somewhere between 6 to 8 years. So I'll say that again. Someone with IPF, even with good quality treatment, has a mean lifespan of somewhere between 8 to 10 years, whereas it's far better in a non-IPF diagnosis. So the crucial issue in the last slide was, the earlier you diagnose someone with ILD, the better the chances of the patient surviving in the long term. So earlier you diagnose, better it is. For early diagnosis, is screening something which is essential. So there's been a lot of studies, and I'll show you a couple, which have looked at trying to diagnose patients with ILD early. The ILD India registry showed that patients get diagnosed with ILD 4 years into their illness. So 4 years down the line, they get diagnosed. You understand they only have a couple of years to live thereafter. So this is a lovely study, a proof of concept study, which got published in the Blue Journal, which showed more or less the same. After 4 years, if you see at 5 years, 50% or more of your patients are dead by that time. So if you're diagnosing at 4 years, you're losing about 40% of your patients. The patients would be dead by the time you get a diagnosis. Why are these patients diagnosed late? These patients are diagnosed late because of insidious onset. The symptoms are non-specific. There's minimal symptom burden in these patients. The knowledge about fibrotic ILD is scarce, and there are long waiting times. Can I request you to not speak in the front row, please? Excuse me. Excuse me. Can I please request you not to speak in the front row? It disturbs me. I'm very sorry. Thank you. So the reason fibrotic ILDs are diagnosed early is because of insidious onset, non-specific symptoms, minimum symptom burden. There's scarce knowledge about fibrotic ILD among primary care physicians, and there are long waiting times in specialist centers. What are the potential solutions for diagnostic delays? So greater awareness about ILD is important. Picking up finger clubbing in these patients is important. Identification of ILD on imaging is important. And picking up what is called interstitial looking lung abnormalities, ILAs, is important. I'll show you this in a moment. You remember I spoke about the importance of the stethoscope a little while ago. So this is a lovely study which came out not so long ago, 2 years ago, which talks about the importance of the stethoscope in improving clinical outcomes in patients with interstitial lung disease. And Vincent Cotin from France, one of our pioneer workers in this area, says that the only genuine tool for the diagnosis, early diagnosis of IPF is the use of a stethoscope. This is something that I was hearing about in Hall B. Dr. Kulkarni spoke about this very eloquently. This is digitally recorded lung sounds. And if you look at the diagnosis of bilateral Velcro crackles in patients with interstitial lung disease, you can see unilateral versus bilateral. Hearing crackles on both bases is almost diagnostic for patients with IPF, better than any other use of stethoscope that you would know of. This talks about ILA. This is from the lung cancer screening studies. This shows incidental identification of interstitial lung disease. And in the lung cancer screening program in the US, where they screen for lung cancer, they found 15%, 15% of patients, 1 out of 6 patients had ILAs or interstitial lung abnormalities on CT scan. What happens to these patients is the important question you might ask. So if you find someone with ILA, 50%, 1 out of 2 patients will progress to ILD over a period of next 5 years. So what do you do in your clinical practice? You repeat a CT scan every year, annually in these patients, because you are looking for progression. You would do an FVC in these patients, a spirometry in these patients every 6 months to look for progression of disease. And that's how you screen these patients. You don't treat them, you follow them up. If they develop honeycombing, if they develop traction bronchiectasis, you would treat these patients in the long term. These are patients who need to be screened, the so-called high-risk group for interstitial lung disease, advanced age, male sex, tobacco smoking, environmental or occupational exposure, and carriage of certain genetic alleles are the predisposing factors for the diagnosis of interstitial lung abnormalities. So advanced age, male sex, tobacco smoke, occupational environmental exposure, and the allele that we have spoken about. So I'll leave that, but you have lovely algorithms and lots of physicians in the audience. Remember this, this is from the American Thoracic Society. This looks at patients who are diagnosed with clinically significant ILD, subclinical ILD, and no ILD. The no ILD gets excluded. For patients who have subclinical ILD, you have an algorithm that you follow, which is based on doing an HRCT annually and doing spirometry every 6 months to look for progression. Clinically significant ILD gets treated as such. So if you remember one thing from my talk, remember about screening for fibrotic ILD, because that's going to be the future for all the physicians in the audience today. So I'll skip the key messages and show you a little bit of data. I said I'd present Indian data. So this is our data from the ILD India registry. So this is now about 6 years dated. We had a registry with just more than 1,000 patients. Our nodal center was in Jaipur, and we had external validation by the Seattle Center in Washington. So the Washington, Seattle, USA acted as our external validating center. So 27 centers, 19 cities. One of the most robust studies of its time happened between 2012 and 15 and got published in 2017 in the Lancet. Inclusion criteria was patients more than 18 years with interstitial lung disease. And these were the diagnoses that came. So chronic HP, chronic hypersensitivity pneumonitis, is the commonest cause of interstitial lung disease in India. And 1 out of 2 patients with ILD that you see in your clinical practice have chronic hypersensitivity pneumonitis. CTD ILD at 14%, IPF at 14% come next, and then you have the other causes. There's another study from PGI Chandigarh done by my good friends Ritesh Agarwal and Inder Mohan Sehgal, who have shown that sarcoid is much more prominent than this study, but that's a North Indian faculty. So People in North India seem to have much more sarcoid. Rest of the country seems to have much more of chronic hypersensitivity pneumonitis. What's the most important trigger for chronic HP? Birds and air coolers. Birds, especially pigeons, and air coolers seem to be the most important exposures for chronic HP. The downside of this registry, the Indian registry, was that very, very few people had histopathology. So biopsy was done in only 7.5% of patients. I'll quickly show you the crux of the pioneer study, which I was fortunate enough to be the lead author for. This was looking at pirfenidone and its result in interstitial lung disease. So 2 or 3 carry-home messages for all of you. We found that the mean dose used for pirfenidone across the country was much lower than what was recommended at 1,000 milligrams. All of you know that the recommended dose for pirfenidone in ILD is 2,400 milligrams. So we are giving patients across the country only 40% of the recommended dose. The patients that we had moderate interstitial lung disease, and we found on follow-up that pirfenidone, even at that low dose, caused some stabilization of lung function. So if you achieved a dose of 1,800 to 2,400, which is the recommended dose, the stabilization effect of lung function would be far greater. 40% of patients in the study had a non-IPF use, which is now something that we see in studies across the board, that antifibrotics work well in patients who have progressive pulmonary fibrosis. PPF is a new nomenclature. And we also find, so I'll skip those, and I'll show you data about the other antifibrotic, which is nintedanib. So these are studies which have looked at nintedanib as an antifibrotic. All of you would have used this drug in COVID and COVID-induced fibrosis. This shows that in patients with IPF, use of nintedanib reduces the rate of decline of FVC. Remember this, this is something you need to remember. If there's one data that you need to remember, that antifibrotics reduce the rate of decline of FVC in patients with interstitial lung disease. Nintedanib also reduces acute exacerbation and is a drug that can be used instead of pirfenidone in the right population of patients. How much time do I have? I cannot see the watch from here. 2 minutes? Okay. All right. Okay. Thank you. So just some evidence I want to put together for you for your clinical practice. What would you do if you see a patient with IPF? You should give your patient the choice of both drugs. Nintedanib is a more broad spectrum antifibrotic, so you can use it for both for an IPF and for a non-IPF category of patients. If you have someone with pure IPF, you would want to give these patients pirfenidone because there's more data with pirfenidone. If your patient with ILD is more exacerbation prone, your drug of choice is nintedanib. If you have smoker's lung, so you have combined pulmonary fibrosis and emphysema, you're going to give these patients nintedanib. And in patients who have less symptoms, early disease, the sooner you start treatment, so FVC of more than 90%, a little bit of honeycombing at the basis of the lung, even in these patients, with an FVC of more than 90%, you would want to start antifibrotics early on in their disease process. So what is the most important gap in IPF management? These are the facts which came out of the French registry, which has the largest number of patients in the world till date. So these are the gaps that you have in the management of IPF and also of ILD. That there's less of MDT, early diagnosis is not happening, there needs to be treatment with proven efficacy, more patients need to go on to antifibrotics if they have the indication for it, and there's less of registries, we need more registry data. What's there in it for everyone, across specialties, all physicians, what is there for us? Have a listen to the chest, look for inspiratory crackles on auscultation, and a restrictive ventilatory pattern on spirometry. If you find these, your patient has fibrosis, has ILD, most likely has IPF. If you have the facility to treat them, start treating them, start antifibrotics early, because this is what increases longevity in people. So my carry-home messages, last slide, think of chronic HP and sarcoid as the most important differentials in ILD. So 6 out of 10 patients you have in this country with ILD will either have chronic HP or they will have sarcoidosis. Take an appropriate history for exposure. Make sure you liaise with pick up the phone and speak to your radiologist if you've not got the capability of interpreting the HRCT yourself. Biopsy only when appropriate. The number of cases where biopsy is needed is going down. Make sure your patient is safe before your biopsy. and select your drugs wisely. There's only 2 antifibrotics to choose from, but make sure you choose wisely between the drugs. And it's the pattern that you're treating, UIP versus NSIP versus DIP. It's the pattern that you treat rather than the disease itself. Thank you very much for listening.
Thank you, Dr. Rajadhar. You are our future speaker in several conferences. You are nicely presented the topic of ILD in such a simple way. And Dr. Devi Ram sir का तो कहना ही नहीं है, तो सर का यदि 1-2 घंटे का टॉपिक हम लोग के लिए हो यदि, तो हम सारे डॉक्टर्स के लिए ये बहुत बड़ा मैसेज होगा और टेक होम मैसेज। और इस कॉन्फ्रेंस का मोटो भी होना चाहिए कि सर ने जो हम लोग को टिप्स दिया है उसको हम लोग सब लोग फॉलो करें। अभी हम लोग प्रेजेंटेशन सेरेमनी के लिए आगे जाएंगे, अभी टाइम क्वेश्चंस के लिए नहीं है। थैंक यू
सर। सॉरी बट क्वेश्चंस का समय नहीं है। If I can request you to please meet him offline, that would be. Yes.
हाँ जी, तो आपने बिल्कुल सही कहा। So you said it yourself. You said कि diagnosis के लिए आपने बोला spirometry and HRCT, and pulmonary hypertension is the most dreadful complication. You know, so that is the reason I did not say it in diagnosis. So you're very right. I did not have time to cover pulmonary hypertension. If a patient with interstitial lung disease has add-on pulmonary hypertension, their mortality is increased many folds. So it's very important to an echocardiogram, but that's after you've established the diagnosis of ILD in those patients. But very, very relevant. So one is echo. The second is a 6-minute walk test. Those are things which will indicate you in favor of someone having pulmonary hypertension. So valid point. Thank you, sir.
Thank you so much. Requesting the chairpersons and the speakers to please move for the felicitation ceremony. And I request our chairpersons for the next session to please join us. Can I request Dr. S.K. Ghosh, Dr. S.C. Jha, Dr. Abhilesh Kumar and Dr. D.P. Singh to please join us as a chairperson. As we have our first speaker, Professor Dr. A.N. Rai sir. I request Dr. Rai sir to also please join us on the dais. Again, a general reminder, total time allotted is 20 minutes. The timer is going to be set for 17 and the buzzer is going to ring on 15. Thank you so much. Over to the chairperson.
I have got the proud privilege of inviting teacher of the teachers, Dr. Professor A.N. Rai sir, to present some interesting clinical cases, and I am sure each of those cases have got a message for all of us. Please, sir.
Thank you, chairpersons. Dear colleagues, after the lunch, most of you will be sleepy, but this is a case presentation. So this will require floor participation. Sir, so please watch the ECG first, ECG. This is middle-aged lady presenting with the palpitations, history of recurrent palpitations. This is the ECG. You find it is a wide QRS complex tachycardia, isn't it? It's wide, but what is different? Is it VT? This ECG is wide, but it is a fast, broad, and irregular. FBI, fast, broad, irregular. So it is a wide corresponding tachycardia, and differential diagnosis, before I tell you diagnosis, differential diagnosis will be polymorphic VT, fast broad irregular tachycardia due to pre-excitation with AF, prolonged QT, tertiary point. So out of the three, it is diagnosis is second one, fast broad irregular tachycardia due to pre-excitation. This patient, a pre-excitation ECG with atrial fibrillation directly passes, the rate is very fast, it passes directly through excessive path because AB node has got refractory period, check period. Normally 180 doesn't allow, but with the excessive path it can pass to the ventricle and the rate can be very fast and it can be fatal. So how can you just see the next This is the post-Ishizaki ECG. You can see the WPW syndrome. So this patient had WPW syndrome presenting with the recurrent palpitation and diagnosis was atrial fibrillation, not the VT. So final diagnosis is WPW syndrome. 35-year-old diabetic male was admitted with a history of sudden weakness and giddiness since morning. Pulse BP, pulse was 40 per minute, BP 160/100. ECG is given below. This ECG I have shown several times. But I am carrying it because it gives message. Because some of you will be new. So what is the diagnosis? This ECG, you can say there is extreme bradycardia, there is no P wave and tall T wave. So what is the diagnosis? Obviously, quite clear diagnosis. Hyperkalemia. It's a classical ECG of hyperkalemia. Now, how will you manage? First, medical management, we all know. The investigation finding in this case of blood sugar 300 milligram, serum creatinine 3.5, serum potassium 6.5. So how will you manage? Patient will manage continually by given IV calcium and insulin. Since glucose was blood sugar 300, so normally we get glucose in insulin. He was advised dialysis when he did not show improvement, but refused to. After the medical management failed, and medical management calcium, we always give IV calcium. How does IV calcium act? It blocks the cardiac activity of the cardiac, and glucose insulin transfer the potassium from extracellular to intracellular, you know all. So with this, when the medical management failed, patient was advised dialysis, but he refused. And then his condition deteriorated and he developed this ECG. What is this ECG? So what is this called? Is it? It's again white complex tachycardia. What is it VT? This is called cine wave. Cine wave. This is a cine wave due to merger of white quartz comes with white T wave. When serum potassium, the serum potassium of the patient was saved around 7 milliequivalent. Patient was saved after 7. This cine wave is very critical. Anytime patient can go into cardiac arrest. So this patient eventually agreed for dialysis, and after dialysis, his potassium came to 5 milliequivalent and ECG he was saved. This is the normal ECG. Case 3. A 45-year-old female presented to the emergency department with recurrent seizures since 1 day. She was diagnosed with epilepsy 6 years back and was on sodium valproate 300 milligram BD. No proper workup for seizure was done. This is the finding, clinical examination finding: pulse 75 per minute, BP 150 by 90, respiration 88 per minute, no pallor jaundice actress, no lymphadenopathy, severe within normal limit, RS within normal limit. And this we do routinely ECG. What does this ECG shows? This is so prolonged QT. Prolonged QT can occur into idiopathic QT, prolonged QT syndrome, that is common, but normally it can occur in hypokalemia, hypocalcemia and hypomagnesemia. So hypokalemia, hypomagnesemia, hypocalcemia. This patient present with the seizure. So is there any correlation between the two? Hypocalcemia, because hypocalcemia can cause seizure. And this is a CT. Actually, photo is not very clear, but it shows bilateral basal ganglion calcification. This is specific of one clinical condition. bilateral basal ganglion calcification. What is the diagnosis? Specific condition, primary hypoparathyroidism. So this patient was for seizure for 6 years, being treated for seizure, but eventually she came out to be case of primary hypoparathyroidism and by routine ECG. Recurrent, this salient feature, recurrent seizure, QT prolongation, bilateral basal ganglion calcification, hypocalcemic seizures, blood sugar, blood urea, serum creatine, electrolyte normal. Investigation, serum calcium you can see was low, albumin 4.5, serum phosphate was high, you can see. Vitamin D normal, serum magnesium normal, PTH is very low, you can see. I am going fast because time is not there. So final down in our case, primary hypoparathyroidism was diagnosed on the basis of low serum calcium, high phosphate, and low PTH in background of normal magnesium level along with radiological evidence of basal ganglion calcification. Management IV calcium initially followed by calcium carbonate and vitamin D 60,000 once a week. Antibiotic for symptomatic management for seizures. After 3 months, antibiotic drug was stopped and patient now did not develop any seizure. So this is the importance of proper diagnosis. Now this is 65-year-old female presenting with a sudden quadriparsis. This patient had previous history of recurrent paralysis, quadriparsis, and she now presented with a sudden quadriparsis. Again you can see the ECG. Yes. Prolonged QT with paralysis is hypokalemia. Prolonged QT with convulsions is hypocalcemia. So I have not presented this case for simple hypokalemia and this paralysis. This is a common periodic paralysis. Everybody knows it can occur. If a patient presents with the recurrent paralysis and features of hypokalemia, what diagnosis come to your mind? What you should do? Apart from pediatric hypokalemic palsy, what else, which is a treatable condition, can come? Yes, connected is you are right, but anything else? Anything else? Thyrotoxicosis. Thyrotoxicosis, hypersensitivity, due to this adrenal hypersensitivity, there is shift of potassium from this, and this patient had she was being treated for hypokalemia for last 3-4 years. So when she came, we did the thyroid function, and you can see the thyroid function I am going to show. She has classical hyperthyroidism, and by treating that, these are very important, uncommon cases, but very good cases. And this is not taken from the text. This is taken from our institution. This is the finding you will see, and this is a thyroid profile. You can see. Classical thyrotoxicosis. She was given potassium recovered and she was given treatment for thyrotoxicosis. 50 years female, having 2 kids, youngest 2 years old, presented with a history of weakness, lethargy, weight loss, and amenorrhea since 2 years. Her thyroid function report is given below. What is the diagnosis? This is also what is the diagnosis? What thyroid function shows? In spite of low TSH, T4, TSH is not raised. So what is the diagnosis? Yes, it is a case of secondary hypoparathyroidism. And in case of female, presenting with the history of 2 months amenorrhea, what is the most likely diagnosis? Sheehan syndrome, classical Sheehan syndrome. You do understand classical Sheehan syndrome. This is cortisol. We did the cortisol, it was very low. Prolactin, you can see. salient features. So her TSH anything, they are very low. I think. We did the, I think, gonadotrophin also, it was low. That one also free T4 normal and low and normal TSH. Secondary hypothyroidism. Secondary hypothyroidism. And this, I think the slide is missing. We did the FSH analysis, it was low. And cortisol was also low. So, she is a case of classical Sihan syndrome, postpartum. Young male woke up early in the morning with history of, this is very common in our part in rainy season. He had difficulty in swallowing. He was admittedly well when he went to sleep last night. He gave no history of fever, poisoning, any white. His photograph at the time admission is given below. Classical snake bite, carrot bite. Because this is important, because what happens, you say, when we say carrot bite, patient relative will say, no, it was got kata hi nahi hai. But you see, when cobra bites, there is usually bite mark, and there is a slight, some redness or cellulitis. But carrot bite, sometimes patient may not notice in deep sleep, and neural area. And patient presents the bilateral ptosis, difficulty in swallowing, all these things. He was given anti-snake venom, and then he recovered. So this is a case of a classical carrot bite. I am leaving time. If time is there, then I will go for spot diagnosis. Also, I can go for spot diagnosis. Mother of 3-year-old male child came to OPD at AIMS, Gaya, with complaint that whenever her baby passes urine, it turns brown or black in few hours. What is the most likely diagnosis, clinical diagnosis? Alkaptonuria. Yes, two diagnoses, but it's alkaptonuria. Porphyria, it will be from the start. But in alkaptonuria, that's so classical alkaptonuria. This is 3 hours after. So that was, first was the fresh urine, and second was 3 hours after. We did the homogeneity acid. For example, it was negative. So it was positive in the urine. So alkaptonuria was there, and it is a classical diagnosis. So diagnosis was alkaptonuria. So I'm leaving that spot diagnosis. Thank you. Thank you very much. Hi, तब तो हम खत्म कर सकते हैं. Oh, अच्छा. Case 2, 8-year-old girl presented with the epileptic fits. Her CT scan is given below. What is the abnormality? Yes, yes. The posterior horn is very much prominent and enlarged. This is called colpocephaly. This is a congenital abnormality. It is a congenital brain abnormality in which the occipital horn, the posterior or rear portion of the lateral ventricle of the brain are larger than the normal because has failed to develop or thicken with partial or complete agency of corpus callosum. So that was a case of colpocephaly present epileptic fit. Case 3. It's a common condition, we must be knowing. A 35-year-old male presented with purpuric spots and his fever, joint pain and sore throat for 3 days. What is the most likely? So one is a drug reaction. What is the other differential diagnosis? fever, pain, joint pain. Have you heard the name of purpura aromatica or anaxolin purpura? Have you heard the name? Why can't it be? Anaxolin purpura aromatica. It is IgA, related to IgA. Previously we were anaxolin purpura. This is a classical sign. It is called.
Can I request the chairperson to please give their comments and
excellent cases, each with a clinical impression and message to all of us.
Thank you.
our next speaker is Dr. B.B. Rivari.
Kindly put his slide. To talk on another vital clinical topic of overview of HIV cure and vaccinated and vaccine research, we have got Dr. Bharat Bhushan Rivari, sir. Over to you, sir. The field is yours. Important topic.
Good afternoon. I would like to thank the organizers, particularly Dr. D.P. Singh, Dr. Himshankar Sharma, for giving me this opportunity. I don't know how many of you have heard of any patient being cured of HIV ever? No? Yeah. So there was a news of one patient, sixth patient being cured of HIV in July 23. So there are 6 patients who have been cured of HIV, but we'll see how long they have really been cured, or it is just a kind of increase in the immunity and disappearance of viral load. So briefly, my talk will cover what is the present standard of care. Since this is an internal medicine specialist here, we would like to know what is the present standard of care, why we cannot cure HIV with currently available drugs, is it a myth or reality in future, and where are we with HIV vaccine trials. So just to give you brief, the first cases of HIV were reported in 1981, and after that every 2 years there have been some advances like discovery of virus in 83, the diagnostic test becoming available in 1985, first drug became available in 1987, but what changed the game was in 1996 when triple drug therapy became available, what was earlier called highly active antiretroviral therapy, and this changed the scenario of HIV from a virtual death sentence to a chronic manageable disease now. The current guideline is basically that we need to treat everyone with HIV infection. Some of you might be knowing earlier this used to be less than 200 CD4, less than 350, less than 500, but the guideline is currently anyone with HIV infection should be started on antiretroviral therapy regardless of CD4 count or a baseline viral load. And the standard of care is a triple drug combination, what is called tenofovir, lamivudine, dolutegravir, 300 milligram tenofovir, 300 milligram lamivudine, 50 milligram of dolutegravir in a single pill once a day, lifelong. That is the standard of care, and this is available across the country free of cost at 2,000 ART sites including link centers, and Bihar presently has got 25 ART centers providing this treatment free of cost. Dolutegravir has been chosen because this suppresses virus very rapidly. There is a viral suppression within 4 weeks, very little toxicity compared to earlier drug which was efavirenz. It has a high genetic barrier to resistance, so there are hardly any known treatment emergent resistance, and there are very minimal drug interaction with dolutegravir. So this is the current standard of care that should be provided to any person with HIV. It has been a boon. The drugs cost have come down significantly, which used to be $10,000 a year to $45 a year. That is just 2,000 rupees, 2,500 rupees a year to the program. In the market, this is available for 1,500 rupees a month. So it is very efficacious. Most countries have got free antiretroviral therapy, including India, and this has improved clinical outcomes significantly. And now we have in pipeline some drugs which are long-acting drugs which are to be given once in 2-3 months. So that is basically the current standard of care. But we know that it is a lifelong therapy. The virus rebounds the moment the treatment is stopped. So a person has to take treatment lifelong without any interruption with a good high. And why we cannot cure because in spite of reduction in the viral load, when we are able to suppress the person and virus is not detected in blood, still the virus persists in some reservoirs, which includes the T cells, macrophages, in lymphoid tissue, in gut, brain. That is why we cannot eradicate the virus from these sites, which are called potential reservoirs. So why do we talk of cure when it is so effective? We know that is lifelong treatment. People, once they get well, they tend to stop treatment. Treatment fatigue is a major issue. There are some long-term toxicities, and resistance emerges if the adherence is not good. So ART works well for most, but some people which are serodiscordant basically, or patient who have failed on first line, second line, third line, we really need to see whether we can offer a cure or not. And we also know that despite being on treatment, HIV is a chronic inflammatory condition. There is a persistent immune dysfunction and inflammation, which increases the risk of non-AIDS related disorders like cardiac disorders, renal disorders. So comorbidities are also significantly present. So if there is a cure, it can address many limitations of ART, including this inflammation, excessive morbidities, and imagine 21 lakh people in India coming to a hospital every month or 2 months getting treatment for the rest of their life, how much a burden is on health system. So when we talk of cure, there are two types of cure. One is basically you eliminate all cells, all HIV infected cells, which is called sterilizing cure, or else a cancer model whereby you provide some treatment, antiretroviral therapy, you stop it, still the virus remains suppressed for some period, which is called as functional cure. But what is the barrier? As I said, barrier is basically that the virus is latent, it is in the latent reservoirs, and these reservoirs persist for years together, and they are very stable, there is no decay over the time, so the virus persists over long time hidden in certain reservoirs. But can we achieve cure? I said in the beginning 6 people have been cured of HIV, and this was the first person, Timothy Brown, who is a German patient who was cured of HIV. He actually had a malignancy for which he was on bone marrow transplantation, and the bone marrow transplantation given from a Caucasian population which is naturally resistant to HIV. They have got a beta 32 deletion in their chromosome and they cannot get HIV, so a bone marrow transplant is given from that population, then we can really cure person of HIV, eradicate the HIV. But that is not a practical option. We know that bone marrow transplant itself is a tedious costing procedure with high mortality to the tune of 15 to 20%. So these are the 6 persons basically, the Timothy Brown, a person in Boston, a baby in Mississippi, who have all been cured for some time, but in most cases the virus returns back except in the Timothy Brown, because these persons did not get a bone marrow transplant from that particular population, Caucasian population. And the 6th patient I talked of, which was disclosed in July, basically had stem cell transplant 20 months after stopping the treatment, is still undetectable, but we don't know whether it will remain like that. So what are the main approaches? How can we really cure HIV? And our purpose basically is to kill that hidden latent reservoir cells. And how can we reach? We can activate them, bring them out of the reservoirs, and then kill with antiretroviral therapy. So we can activate them through certain drugs called HDAC inhibitors, protein kinase inhibitors, certain growth factors. So we can bring them out, what is called kick and kill approach. We bring them out and then kill. Silence. We do immune suppression activation of T cell through cyclosporin and other drugs, or have a gene therapy whereby we can make changes in the gene and delete this CCR beta 32 phenotype, which is called zinc finger talons or recombinases, so that we can really lead to a cure. So eliminating these cells is not easy because we have to do the approach of kick and kill through certain drugs which are called, methylene inhibitors, HDA1C, HMT inhibitors, disulfiram. These are some of the drugs which can bring out the virus and then we can really kill them. And the antiretroviral therapy will prevent the new cells from being infected simultaneously. But how difficult it is, we'll just see. Because with these agents, every infected person will not become active, every cell will not become active because they require several rounds of stimulation to come out. They will not just come out with one. And finding this is very difficult. I'll show you how difficult it is. If we just take an example, this shows that this is the way, it's like a one person standing in 11 football stadium, and each football stadium has got capacity of 92,000. So you have to search one person in 11 football stadiums, how difficult it is. So that is the reason that so far HIV cure is eluding us basically. But that is these patients like Timothy Brown have provided basically a proof of concept that it is possible to find a HIV cure in near future. We can also make cells resistant to HIV. As I said, CCR5 receptor is one of the binding sites. So we can knock out certain genes which bind to this receptor, and then basically we can make the cells resistant to this. So scientists are working basically modify culture and reintroduce these cells which are CCR5 resistant to increase the body resistance to the virus. Other areas are stem cell transplantation, therapeutic vaccination, which basically comes with broadly neutralizing antibodies, which can bind and kill a variety of HIV mutations. These are also being pursued in both preventive and curative strategies for finding HIV cure. So strategies to cure HIV basically, particularly sterilizing cure, will be optimized treatment, provide treatment to everyone so that we can eliminate replication. I don't see it's there, okay. So we can I think some connection is loose. Okay, it's okay now. So we provide treatment to everyone, make them adherence to a treatment so that they become virally suppressed, they are not able to transmit the virus further, reverse the latency, increase the viral protection, immune-based therapies, therapeutic vaccination and gene therapies are some of the strategies which are being pursued to find a cure for HIV. So take-home point from HIV cure is that it is the focus of scientific community, even the government funding agencies. But it is definitely hard to prove that a person is cured because virus may re-emerge from latent cells even after few years. And there is only one person, Timothy Brown, who has been actually cured and virus did not return even after stopping therapy for many years. But always remember, prevention is always better than cure. So we need to prevent people from getting infected. So when we talk of prevention, naturally one thing which comes to our mind is vaccine. Talking about HIV vaccine. Why do we need vaccine? We know from measles, our experience with measles, in 1980 there used to be 40 lakh infections globally of measles, but once the measles vaccine came in 2016, we just had 180,000, 1.8 lakh. So we know our example from COVID that we need a vaccine to prevent such infections. But we still don't have a vaccine because the virus is silent. It does not evoke a effective immune response. When a person gets infected with HIV, antibodies are produced which persist throughout the life, but these are not neutralizing antibodies, and these antibodies either too late or too non-specific to stop the infection. So antibodies against HIV do not protect against HIV infection. It is shifty. Shifty means it changes all the time. It changes much more faster than flu virus or even the COVID virus. Even if we are able to do a vaccine trial and develop some vaccine, by the time antibodies are developed to that vaccine, the virus has mutated and it is subversive. Basically, we really know how the cell infects HIV once they are activated. The T cell activation itself basically means more cell to be infected. So over the years there have been a number of vaccine trials for HIV, but none of them have been successful. The earliest trial in 2003 basically did not show any efficacy and was stopped because these were only antibodies and not neutralizing antibodies. In 2000, it showed some efficacy, but it did not show efficacy. Rather, there was more risk of HIV infection among people who were receiving the vaccine. This was a trial which showed some efficacy, but efficacy was only 31% after 3 years. So it is just statistically significant. And it was only against the weakest tier 1 viruses, a low risk population. So this trial also did not work much. And now this HPTN 505 trial basically again was halted earlier. So we are fast tracking to basically to other trials which are mosaic vaccines. The examples have been taken from COVID vaccine, particularly the messenger RNA vaccine, and these are being basically now used to kind of find a vaccine. But I still feel we are quite far away from vaccine. I don't foresee a vaccine for HIV coming in maybe next 5 years or so. Though there are similarities between SARS COVID virus and HIV, but if you see the the diversity of SARS virus was limited acute infection, limited to glycoprotein of S, neutralizing antibodies, readily accessible to antibodies, but HIV, enormous diversity, persistent infection, high levels of glycosylation of envelope proteins, and neutralizing epitopes structurally they are shielded, and antibodies are not readily elicited in natural infection, and even vaccination is not able to actually develop antibodies. But lessons from COVID are being utilized. We are using branched neutralizing antibodies, and these are RNA platforms are now being used to drive antibodies towards breath. So these are some of the new trials which are undergoing using messenger RNA technique. So this is a little overview about HIV cure, vaccine. The scenario is not very clear now, but we are hopeful that in years to come we will be able to. But the therapy, in terms of therapy, antiretroviral therapy has provided a panacea. People are still living longer. Dr. Deshpande herself may be having patients of 20 years on ART. I myself have patients 16 years on first-line treatment. And now we have injectable cabotegravir, rilpivirine injection coming in once in 2 weeks or once in 3 weeks. You can just give those injections, and some other drugs are in pipeline. So to close this, I would like to thank the study volunteers basically who are dedicated and their commitment in research for HIV cure, and also to the colleagues and people who are working on this. Thank you very much.
Thank you, sir. Raveri sir, you have presented the case, presented the paper very nicely and very elaborately. One thing that I have to say, when the HIV virus is integrated in the human cell and in human DNA, that cannot be killed. I was few years back, I was nodal officer of this institution of AIDS. I was teaching the students that the drugs that has not come still now. If you block the drugs attachment, if you block the HIV attachment with the cell, that can only kill the virus. When it is integrated, you cannot kill the virus.
Absolutely right. If you prevent the fusion of the virus itself to the CD4 cell, basically which is facilitated by CCR5 and CCRX4 receptors, if you can block that, there are some drugs which have come in Maraviroc, other thing, but they have not been very successful. There was another drug called fusion inhibitor T20, which also came in, but they are not still in clinical use and not been very efficacious.
Messenger, a second thing I have to say, sir, messenger RNA vaccine, that can be effective in case of coronavirus, but that cannot be effective in case of HIV virus, because it is when it is integrated, the messenger RNA vaccine will not be fully active, fully successful, cannot be fully successful.
No, I don't say it is effective, but it is a lesson that we have.
also wants to
How can we move ahead with the vaccine research? It is just providing us some direction. Yes,
Dr. Raj Kamal, you want to contribute something to it?
Yes,
please.
So first thing, you said that it has been cured is correct, because in the global scenario, it has been seen that the patients of HIV has been cured. The second thing is that those patients who have been cured, they have been stem cell transplanted, and all the old cells have been become out, and new cells have been inducted, but not a single HIV cell has been found. These are the two observations regarding the HIV, that it is going to be eradicated.
Absolutely right.
The first thing. Okay. The second thing is regarding the vaccination. The HIV vaccine is very soon coming. It will be coming in the form of the messenger RNA, in which we will put the antibodies against it, and that will act. But it is in the stage of trial. So these 2 points I wanted to clarify. And since I am the nodal officer of the ART, that's why I'm telling you.
All right. No, I think your comments are well taken.
For the lack of time,
Just one comment.
For the lack
Yes.
of time.
Last comment from him, and then
no,
we can move
I
to the next
fully
one.
agree with you. The person, there is only one person who is cured, not because of antiretroviral therapy, but because of stem cell transplantation of bone marrow from a Caucasian population, not from a normal. And vaccine, I don't foresee coming in next 5 years or so. Even messenger
Not in
RNA
5 years, in 10 years it will come. So
Thank you, Dr. Rewari sir, for your excellent presentation. For lack of time, we can't allow more questions. And but you have triggered a point, triggered an issue, which will continue to be there in the mind. Our next speaker
Is Dr. Sankha Sen. Dr. Suryakant is on his way, so we've just got him, and he's also promised me that he's going to finish the talk in 18 minutes. 18 minute ka timer lagana, question answer mat karo. So that's what he's promised. So yes.
It is my privilege to introduce Dr. Sankha Sen, the leading physician, cardiologist of West Bengal, and the fellow student of my alma mater. I know him personally. He will finish in time, though he has to deal with a subject which is a very massive one, sepsis and septic shock, current management. Over to you, Dr. Sankha Sen. The field is yours.
Good afternoon, everyone, and my thanks to Chairperson Sir, my senior Dada at Calcutta Medical College for their kind introduction. I am a physician, mainly dealing with intensive care also, so my choice of topic when I suggested to Dr. Manish was sepsis and septic shock. It's a huge topic. I will try to be brief and fast. And if time doesn't permit, I will skip some of the slides later, but I'll be speaking mainly on the antibiotic choices, the IV fluid management, and usage of corticosteroids. So as you all know, this can be a case, a 58-year-old male presenting with cough, fever, chills, high heart rate, low blood pressure. The patient is drowsy. So more or less the patient is critically ill. The vitals say that patient is going into septic shock, and one important finding is lactate, it is 4.2. These patients are usually septic. For them to increase the blood pressure, we need IV fluids at the beginning, then we may need norepinephrine, and ultimately we are not sure what to do. So that's our discussion, that should we approach these patients. We give more fluids, and after a certain time, we have to add vasopressors. Regarding the surviving sepsis recommendations, that is 30 ml per kg of crystalloid should be given within the first 3 hours of recovery. These are important, the first 3 hours, the golden hours. Now regarding sepsis, and also is not a specific illness but a syndrome, and it is one of the leading causes of mortality, around 19.7% of all global deaths. So 1/5 of all global deaths might be due to sepsis, and most complications in our ICUs lead to sepsis and they die. And it involves most of the systems in the body, from the respiratory system, the cardiovascular, and the renal, and so on. So it's quite important. So sepsis, is it a new terminology? No. The definition of sepsis goes on changing every 2 to 3, 4 years. Initially, the SIRS criteria was designed, but later, SIRS with infection was taken as sepsis. Then with severe sepsis is when sepsis is at least one sign of organ dysfunction. And when there are multiple organ dysfunction with refractory hypotension, then it is septic shock. So I'm not going into the details, but this is the basic which I should discuss. And sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. So this is very important. So it's not the infection, it's the life-threatening organ dysfunction which is caused by the host response, which is dysregulated. If it is a normal host response, it would not go into sepsis. If it is a dysregulated host response, it is sepsis. So septic shock is another subset where the abnormalities are with a greater risk of mortality. When there is adequate fluid resuscitation, vasopressors are added, but still the mean arterial pressure is not more than 65, and the lactate is more than 2 millimole per liter. So lactate is coming into the picture very often. So how to diagnose? The quick SOFA is a very important criteria nowadays. If there is hypotension of a systolic blood pressure of less than 100, if there is tachypnea, respiratory rate of more than 22 per minute, and if there is altered mental status, if 2 or more of there, so it's a poor outcome, and that is a quick SOFA. We can diagnose it in our clinic, we can diagnose it in an emergency, that these 3 criteria, if 2 is there, then it is very important. But very importantly, the new definition in sepsis 3 said that the non-inclusion of lactate, the measurement of lactate is paramount nowadays to diagnose septic shock. So non-inclusion of lactate in this SOFA score is something problematic. Earlier days, we used to define sepsis with SARS, but very importantly, it was not so specific, and it did not reflect the severity. So nowadays, we don't rely on the quick SOFA only. A combination of the search criteria and quick SOFA could be an advantageous for early detection of sepsis. Why early? Because if we treat early only, then we can decrease the morbidity and mortality. MUSE is another criteria, a new warning system with respiratory rate, heart rate, systolic blood pressure, and temperature. More or less, these are very similar, but nowadays, serum lactate level is very important. In any critical care setup with an ICU setting, you need to measure lactate in these patients. Now, lactate is an important guide for resuscitation to normalize the patient who are having tissue hypoperfusion. And tissue hypoperfusion is mainly due to sepsis and septic shock. And it increases significantly in those cases, and it's an independent predictor of mortality. And the septic shock, the lactate level more than 2 is indicator of sepsis, and more than 4 is high mortality. So early clearance of lactate, if the levels are coming down, we know that we are having better outcome. Now, I initiated with how to diagnose and why are you treating sepsis. Now, regarding sepsis management, the 3 important points is hemodynamic management. We have to give IV fluid vasopressors to increase the blood pressure. As I said, the mean arterial pressure should come up to above more than 65. Infection management in the point of good antibiotics and source control, and definitely modulation of the host response. So we have to start resuscitation very early with source control. It is again highlighted, source control is important. If there is an abscess, we have to drain it. Like that, intravenous fluids and antibiotics, and definitely the guiding resuscitation to normalize the lactate in patients with elevated lactate levels are a marker of tissue hypoperfusion, because that means we are in the right line. So appropriate routine microbiology culture should be sent at the earliest, but suppose the patient comes at night, we will not wait for the culture should be sent, but within 1 hour, we have to start good broad spectrum antibiotics. When sepsis is probable, we have to start antimicrobials immediately, ideally within 1 hour of recognition. And if this is not so serious, we can wait. If we are thinking of some non-infectious causes of sepsis, we can start within 3 hours, but not less than 3 hours. So sepsis is also a medical emergency, like time is brain, time is myocardium. Similarly, for sepsis, the golden hour is very important. See, with the delay in the start of antibiotics, the mortality increases. So early combination therapy with at least 2 antimicrobial classes is very important, probably gram-positive and gram-negative both, and also sometimes atypical coverage is important. So if there is no, we don't think that the patient is having some MDR risk, then we have to think of 2 antibiotics. But if there is low MDR risk, then MRSA might not be covered. Only methicillin-sensitive Staph aureus like antibiotics can be given. But if there is multi-drug resistant risk, then the MRSA, you have to give an antibiotic active against methicillin-resistant Staph aureus, and at least 2 agents active against gram-negative organisms. And that also should be active against Pseudomonas aeruginosa. So we are treating sepsis, we have to keep the most dreaded bacteria in our mind, that is gram-negative one, that is Pseudomonas. Similarly, the recommendation says colistin is for routine use, but linezolid also we use rampantly should be restricted because we have other suitable alternatives available. In the ICU setting, we'll try to avoid usage of, okay, then I am telling you, in the ICU setting, we have to avoid usage of amikacin sort of aminoglycosides. That is important because most of them are renally compromised. And also for colistin, we have to use the antibiotics in such a way in a compromised dose. So we have to adjust the dose accordingly. And definitely fluoroquinolones also should be cautiously used in monotherapy. So for anaerobic coverage, we have to ask whether in ventilator-associated pneumonia or all those things in the ICU, when anaerobic coverage is usage. Because when the patient is having low consciousness and when there is chances of aspiration pneumonitis, then we have to use antimicrobial which have anaerobic coverage, like clindamycin or metronidazole, and it should be added. But if the patient is already on a carbapenem or a piperacillin tazobactam, which already has some anaerobic coverage, we may not need to do that. And when is atypical coverage needs to be given? Usually certain risk factors like Legionella conjugation in the hospital supply in the elderly, with the patients with low immunity like corticosteroid therapy, cytotoxic chemotherapy and all. We can use levofloxacin or moxifloxacin or a macrolide like azithromycin. Duration, usually 7 to 8 days of antimicrobial therapy, but certain cases with non-fermenter gram-negative bacilli, that is Pseudomonas or Acinetobacter, we may need to give it till 14 days. So antibiotic stewardship comes into the picture, and here it's important. that we have to de-escalate the antibiotics as early as possible. And here the procalcitonin comes into the picture, because the de-escalation helps us in not only for that particular patient, but also to prevent resistance. There is no recommendation for the routine use of antiviral agents, but empiric antifungal therapy can be used in certain cases. So procalcitonin is not for diagnosis, but serial measurement. If the procalcitonin is coming down, we know that we are in the right track, and we can de-escalate the antibiotics. Source control, like as I said, abscesses, volvulus, pyonephrosis, cholangitis needs to be treated, and the source control will help in resolution of the treatment. Now regarding septic shock, the fluids are most important, and here comes the bundles. What are the bundles? The early phase of resuscitation, then the middle phase of maintenance, and later the de-escalation. What will happen? See, from 2008 till 2018, now to 2021 guidelines are the latest one. From 6 hours bundles to 1 hour bundle has come. And these treatment bundles give us guidance that how to treat early. As I said, we have to diagnose early and treat early. We have to measure the lactate levels. We have to give adequate fluids, if needed, vasopressors, and also broad spectrum antibiotics. And the lactate levels are a guide, as I said. Similarly, for the latest guidelines says the fluid management is paramount. We have to measure the lactate. We have to give proper antibiotics after sending proper blood cultures. So this part I have discussed regarding antibiotics and so on. One important thing in the ICU is the fluids, and when to start fluids, and also when to stop. So de-escalation not only about antibiotics, regarding the fluids we should know. And if there is fluid overload, when to start fluid removal in the form of dialysis and so on. So these are very important, the drug, dosage, and everything. The ROSE criteria is something that we have to resuscitate, we have to optimize the IV fluids, we have to stabilize the patient with IV fluid so that we can have organ support, and evacuation phase when the organ recovery and the resolution needs resuscitation by removing the IV fluid, which is extra amount of fluid which you have given. So the fluids in sepsis in the ICU should be balanced crystalloids, but also nowadays are preferred, but the normal saline is not so preferred nowadays because there are certain recommendations. Regarding usage of balanced crystalloids, there are certain studies because these contains organic anions such as lactate, gluconate, citrate, acetate, which are rapidly converted to bicarbonate upon admission. The earlier RCT said there was very good analysis showing that the balanced crystalloids are nowadays drug of choice, but there are certain ones which are refuting it. So we are using nowadays plasma light, ringal lactate more than the crystalloids like normal saline. Regarding albumin, there are certain cases where albumin might be helpful. When there is capillary leakage, albumin can be helpful. In short time, in small volume, you can have this, but this is not the first line agent. Albumin has its restrictions. There are certain benefits of albumin, but it's not a routine fluid to be given for in the ICU. So resuscitation, the initial resuscitation and the continued resuscitation, there should be balanced, because nowadays restrictive IV fluid is very important. Most of these patients are suffering from ARDS. They have fluid overload in the lungs, and for that, fluid restriction is very important. Regarding vasopressors, norepinephrine is the first choice vasopressor, and vasopressin, epinephrine can be added to norepinephrine if the situation arises. So too much fluid is detrimental because the patient might be in ARDS. Peripheral edema is an indicator. Abdominal hypertension also, and abdominal compartment syndrome is another thing where too much fluid can be harmful. So the stop fluids when they are no longer needed, and the patient can have oral fluids. This is the dictum. Patient can take orally, stop IV fluids, and go on to oral fluids. The third point I wanted to discuss, and I have time for that, is the theoretical benefit of steroids in sepsis. Initially, the critical illness-related corticosteroid insufficiency was not properly understood, and it is defined as inadequate cellular corticosteroid activity for patients who are in critical illness. So for this patient, it can occur in several acute conditions like sepsis and septic shock, which we are discussing now, severe communicable pneumonia, ARDS, cardiac arrest, post-major surgery also. There are certain putative signs and symptoms that these patients are having corticosteroid insufficiency. This is a huge list we can go through later. There are various studies from the Frenchman, Anane et al., and also from the Australian team, the Cortica study group. Some said there was no improvement, some said if there is decrease in mortality, and some said that if there is even no decrease in mortality, it decreases the time spent in ICU because the resolution of symptoms are sometimes helpful. So all this trial, along with hydrocortisone and fludrocortisone, showed that the risk of death in patients with septic shock can be decreased, particularly who are having relative adrenal insufficiency. So this is a very much important balance we have to keep in mind. So the final dictum till date is that we can use 200 milligram hydrocortisone at around 50 milligram IV 6 hourly in these settings when the patient is in septic shock and when the requirement of vasopressor therapy is such that it is not being maintained. Then only you can use corticosteroid in the form of hydrocortisone so that it can be given 50 milligrams 6 hourly so that we can have resolution in their septicemia. Last few points on mechanical ventilation, we have to try to, nowadays guidance says we have to use high PEEP, and someday, you know, now during the COVID times, most of us came to know that using a proning over supine position was helpful, and very importantly, use of beta-2 agonists are not very important, like we give salbutamol and all. It can be given only if there is bronchospasm. And lower tidal volume with high PEEP is recommended. Regarding glucose control, the target should be less than 180. Is not like that 110. Hypoglycemia also should be avoided, but the glucose should be maintained less than 180. And for that, we have to be very frequently measuring the glucose by the capillary blood glucose by the glucometers. Regarding renal replacement therapy, definitely only increase in creatinine or oligurin is not the indicator. If there is hyperkalemia, if there is fluid overload, this also adds to it. And we have to guide our patients in such a way. And nowadays, the patients are in shock. And in these septic shock patients, you can't go for dialysis immediately. You will need CRRT or something like SLED, which will have less chance of hypotension. Nutrition, definitely early parenteral nutrition is not recommended. We have to try enteral nutrition from the beginning. Even in critically ill patients, we can give IV glucose and enteral feeds as tolerated. But don't rush into parenteral nutrition from the first day. Till 7 days, we can wait with enteral nutrition and intravenous glucose. Then only we can think of parenteral nutrition. So, and another thing, if the patient is only having risk for aspiration, then only we can look for the measuring the gastric residuals by the, we can check that how much residual volume is there after every feed. We can use prokinetic agents in the form of domperidone or levosulpiride in these patients so that there is less chance of aspiration. Regarding blood products, RBC transfusion less than 7 is indicated, and if the patient is having some cardiac issues, we can give it below, even below 9. But nowadays, the target is low, and for platelets, less than 1,000, regardless of bleeding, you would have to transfuse. But more than 50,000, usually they don't need, and if there is significant risk of bleeding or bleeding at any point of time, we can give platelets. Bicarbonate, no. There is no use of bicarbonate or reducing vasopressor requirement unless the pH is more than 7.1. If the bicarbonate is less than if the pH is less than 7.1, then only we can use bicarbonate. And in my last 30 seconds, I will discuss regarding DVT prophylaxis with enoxaparin, low molecular weight heparin, definitely. And in cases we are having creatinine clearance less than 30, dalteparin is preferred. For those where there is coagulopathy, we can use mechanical prophylactic treatment in the form of compression stocking and devices. Regarding stress ulcer prophylaxis, H2 blocker or proton pump inhibitor might be used. And here, proton pump inhibitor, if needed, is better than H2 receptor antagonist. So we have to set our goals clear, and vitamin C is one thing which was studied, nowadays is not recommended. My last slide is regarding lack of proper understanding of the signs and symptoms of sepsis is the most common roadblock in our ICUs. Prevention is better than cure, and strict implementation of infection control bundles, as I mentioned. Time for fluid stewardship is also there. Antibiotic stewardship we are keeping in mind, but fluid, we have to stop fluid as and when the patient is taking orally. De-resuscitation and de-escalation are equally important. When we start treatment, we should know when to stop treatment also. I thank you for your patient hearing, and it is not the final word in sepsis, no, or the starting point of discussion today, no. These are ongoing science. Probably next year we'll have something more to add or something more to subtract. Thank you all. And every 2 minutes a person dies from sepsis. So we are discussing MI, we are discussing stroke, but definitely sepsis is one thing killing 20% of our patients in the ICU. Thank you all for the patient hearing.
Thanks, Dr. Sen, for your nice presentation. What I advise to my PG students, when a patient of sepsis, suspected sepsis, comes in my clinic or in my hospital, what I advise to my PG students, I say two things. One, the estimation of the serum lactate level, and second is mean arterial pressure. That you have not mentioned clearly, sir. mean arterial pressure and the lactate, serum lactate level. And after that, if lactate level is more than 2 and the serum mean arterial pressure is less than 65, we start the, straight away we start the fluid challenge. If the patient doesn't improve in three hours time, then I stamp that case as a case of septic shock. Thank you, sir. Your nice presentation. One thing I want to share for my learned speaker, Dr. Deshmukh, Alka Deshpande, madam. One thing I add, when Dr. Shivnarayan Singh retired from PMCH, he said in the farewell ceremony, कि for a good doctor, what is required? Average brain, average labor, but full dedication and full devotion. And second thing he said that गरीब आदमी तुमको पैसा भी देगा और दुआ भी देगा, अमीर आदमी तुमको पैसा भी नहीं देगा और दुआ भी नहीं देगा. Thank you, ma'am.
Thank you so much. With that, yes.
Dr. Sankho Sen.
Any last words?
Any message?
Yes, sir. Sir, what sir mentioned, mean arterial pressure less than 65 defines sepsis. So blood pressure is measured, and we have to calculate the mean arterial pressure less than 6. We have to keep it more than 65. Otherwise, it's no point. The patient is in shock, and lactate is the first marker. Regarding antibiotics, definitely procalcitonin is very important. So procalcitonin and lactate are two important things other than ABG we will need in our pathology laboratories in the setups where we are treating septic patients.
Thank you. Thank you so much. Can I request all the three speakers and the chairpersons to please join us for the felicitation ceremony, which is just right outside the door. Dr. Sen? Yes. At the same time, I would like to get started with the next one. An update for all the people here. Number one, we are on time. If you look at it, it's 4:35. At 4:40, our debate, which was scheduled by Dr. Jayanta Panda and Dr. Amit Kumar Das, they are stuck in traffic and they shall be arriving soon. So we are moving to the next session where we have Dr. P.K. Bhattacharya and Dr. Suryakant is going to be speaking. And can I request the chairpersons to please join us? Can I request Dr. R.K. Modi, Dr. Sunil Kumar Agarwal, Dr. Sujit Kumar and Dr. Mohammad Sadiq to please join us as the chairpersons. We're going to have Dr. Suryakant going in first, followed by Dr. P.K. Bhattacharya. And after that, if we have Dr. Jayanta Panda reaching in time, we shall have the debate. Otherwise, we will have the party in the evening. Requesting Dr. Suryakant sir to please join us on the dais to check if everything else is in place. The chairpersons giving again a reminder for all the speakers. The total time is 20 minutes. The timer is going to be set for 17 plus 3 minutes for the discussion. And the buzzer will ring on 15. So we'll have 2 minutes more to conclude.
So how much total time?
Total 17 minutes talk time, 3 minutes discussion. Buzzer 15 and 17 pe bajega.
Okay, so
and you're looking good, sir.
No, thank you for managing the time by cutting short the time. It's a good management. So at the outset, really, I'm thankful to the organizing committee and especially my friend Dr. D.P. Singh for the wonderful show. And it's a very important talk. I will cut short into the try to cut short into the 20 minutes. So a national TB elimination program is everybody is aware of. It is a very heart-touching program of our Honorable Prime Minister Shri Narendra Modi ji. And how to engage the private sector, that is the real challenge. Because if you see where the tuberculosis patient go, the 50% go to the government sector and 50% go to the private sector. The government sector is working as per the protocol. We need to sensitize our private sectors. So I think most of the audience here is from the private sector. So I think Dr. D.P. Singh has chosen the right topic for us. So So what is the importance of lung and breathing? As a pulmonologist, I want to highlight that we breathe around 25,000 times a day. We can live without food for 3 weeks, we can live without water for 3 days, but we cannot live without air, without breathing for more than 3 minutes. So that is the importance of breathing, and from where this breathing occurs, this is the one pair of lung, beautiful one pair of lung, and 10,000 liters of air passes in and out every 24 hours, and same amount of blood also passes every 24 hours. Am I audible, the caller mic? Okay, so now it is comfortable for me. So this is the, now if you see the history of TB, then we should be proud of that the first description of tuberculosis is in the first book of the universe, first book of the world, and the first book of the world is the Rig Veda. We know that there are 4 Vedas, but the oldest one is the Rig Veda, and the description, the first description of tuberculosis, it is found in Rig Veda, so we as the Indians should be proud of. And this is the first very important landmark in the history of tuberculosis, that is the discovery of causative organism of the tuberculosis, that is in 24th March 1882 by Robert Koch, and that's why 24th March is being celebrated as World TB Day, and he got Nobel Prize also in 1905. Now this is the evolution of TB control in India. I will not waste any time. It started in 1962, and later on, the latest thing is that on 24th March 2023, Prime Minister Modi organized a One World TB Summit at Varanasi. Fortunately, I was also present in that meeting, and a lot of things happened, a lot of things have been started on this World TB Day, and I will share you what new things. This is the Global TB Report 2023. And what is more important in this Global TB Report, that the WHO has congratulated India because first time since 2015, the cases, the incident cases, they have decreased by 16% and mortality has gone by 18%. So that is the good news for India. As you know that Prime Minister launched the NTB by 2025 on 13th March 2018, and since then we were working hard. Anyway, in 2020 and 21 due to COVID, the tuberculosis diagnosis and management went down, and that's why there was a lot of problem. But anyway, in 22, late 21, 22 and 23, the country did a lot for tuberculosis, and that's why WHO has congratulated this year in the TB report, Global TB Report 2023, because incidence has gone down by 16% and mortality by 18%. So this is the photo picture with the Director General of WHO on 13th March 2018 when Prime Minister Modi declared NTB by 2025. A very fascinating target which is 5 years ahead of the international guideline, because the Sustainable Development Goal, this aims NTB by 2030. And this is the Pradhan Mantri TB Mukt Bharat Yojana launched by our President of India. And this was the One World TB Summit when the Prime Minister as well as the Executive Director of Stop TB Partnership, Dr. Lucia Gitui from Romania, she also participated, and the representatives of high burden country, 11 countries were also present in the Varanasi meeting. And as you can say, after the meeting, we did a lot of media interview also, what's the impact of this meeting. And then I will say a very basic slide for you, that everybody think that if I am exposed to a tuberculosis patient, next day onward I will have TB. No, it is a wrong notion. If you get exposed to a tuberculosis person, because you are a doctor, you can be exposed. There are only 3% chances that you may develop active tuberculosis in your whole life. So don't have the misunderstanding of people who are afraid of tuberculosis patient. Extrapulmonary tuberculosis, sputum negative pulmonary tuberculosis, childhood tuberculosis, they are not infectious. Only AFB positive pulmonary tuberculosis is infectious, and out of which the possibility of getting exposure and after exposure to active tuberculosis, its chances are only 3%. So don't afraid of tuberculosis. And this is the National TB Elimination Program, and this shows that 4 pillars are there: the prevent, detect, treat and build. And on the basis of this, this whole program is working. Why TB is not detected? Why TB is still problem? आप जो बाहर वाला गोला देख रहे हैं, I think it's not working. Okay, it's working. जो आप बाहर वाला गोला देख रहे हैं इसमें बताया गया है कि मरीज को सिम्टम है। फिर दूसरे गोले में दिखाया गया है कि सबको सिम्टम है, वो जाते नहीं डॉक्टर के पास। जो दूसरा गोला है उसमें वो लोग हैं जो सिम्टम होने के बाद डॉक्टर के पास गए। फिर तीसरे जो सर्किल है उसमें दिखाया गया कि उनका प्रॉपर्ली इन्वेस्टिगेशन हुआ। फिर उसके बाद जो सर्किल है उसमें प्रॉपर्ली इन्वेस्टिगेशन होने के बाद रिपोर्ट आई और उसको फॉलो अप हुआ। उसके बाद फिर टीबी डायग्नोज हुई, उसके बाद फिर ट्रीटमेंट शुरू हुआ। और वो लास्ट सर्किल ये है, अभिमन्यु की तरह ये 7 द्वार है, 7वें द्वार में जाके आपकी टीबी कंप्लीट होती है, डिक्लेयर हो, आप क्योर किया जाता है। दैट इज वाई द प्रॉब्लम कि हम अभी टीबी क्यों नहीं कंट्रोल कर पा रहे हैं। वो जो लेफ्ट अनट्रीटेड है, लेफ्ट अनडायग्नोज है, दे रिमेन इन द सोसाइटी एंड दे कंटिन्यू द स्प्रेड द tuberculosis. That's the problem. Okay, thank you. So, involvement of private sector, that is my topic. With this under background, this is my topic, and I want to say that involvement of private sector is a very essential part of the National TB Elimination Program, or for the sake any program. Because in tuberculosis also, the 50% of the patients, they are going to the government sector and 50% going for the private sector. So that is how the policy says, that is the roughly public and private divide, roughly 50 and 50. So what is the diagnostic model for the private sector engagement? Now this is the patient. You can see this is the presumptive TB patient, and here the private practitioner diagnosing him. And here the sputum collection and the free diagnosis facility is available. If you ask the program, तो प्रोग्राम में जांच फ्री है, टीबी की इलाज फ्री है, साथ में टीबी को मरीज को 500 रुपया महीना फ्री है उसके डायरेक्ट बेनिफिट ट्रांसफर में। दिस वी हैव टू डिसेमिनेट। और आपका पेशेंट आप ही का पेशेंट रहने वाला है। कई लोग प्राइवेट प्रैक्टिशनर को लगता है कि मैं प्रोग्राम में दे दूंगा तो प्रोग्राम का पेशेंट हो जाएगा। ऐसा नहीं है, वो आपका ही पेशेंट रहेगा। बल्कि आप नोटिफाई करेंगे तो जब पेशेंट वो ठीक हो जाएगा तो आपको भी 1000 रुपया पर पेशेंट कंप्लीशन ट्रीटमेंट पे इंसेंटिव मिलेगा। कितने लोगों को ये बात पता थी? पता है सर, लेकिन सर मैं बताऊं सर, भारत सरकार 3000 करोड़ रुपए टीबी के मरीजों को डायरेक्ट बेनिफिट ट्रांसफर कर चुकी है 1 अप्रैल 2018 से। मिलेगा, देर आए दुरुस्त आए, मिलेगा सबको। और मैं आपको बता दूं वो 500 रुपया महीना ना डॉक्टर सूर्यकांत के खाते में जा सकता है, ना डॉक्टर डीपी सिंह के खाते में जा सकता है, ना आपके खाते में जा सकता है, ना मोदी के खाते में जा सकता है। सर सुनिए, दिक्कत तो बहुत कुछ है सर, दिक्कत तो बहुत कुछ है। राजीव गांधी के जमाने में होता था कि 15 पैसा मिलता था रुपए में, तो दिक्कत तो बहुत थी सर। अब दिक्कत उतनी नहीं है, दिक्कत है लेकिन दिक्कत नहीं है। देर सवेर मिलेगा सर, उसका पैसा कोई नहीं मार सकता है ना, उसका पैसा कोई नहीं मार सकता। मैंने कहा ना, वो जब रजिस्टर हो गया उसका निक्षय पोर्टल पर। हाँ, प्रॉब्लम कहाँ होती है? प्रॉब्लम होती है जब उसका आधार कार्ड के साथ मोबाइल नोटिफिकेशन नहीं होता है, पासबुक जमा नहीं करता है। ऐसे ही एक बार मेरे अभी कुछ दिन पहले एक पत्रकार आए। सुनिए सर, एक एग्जाम्पल देता हूं आपके लिए। एक पत्रकार महोदय आए, मेरी भतीजी का ट्रीटमेंट चल रहा है, आप तो डॉक्टर सूर्यकांत हर प्लेटफॉर्म पर बोलते हो 500 रुपया महीना, इसके अकाउंट में तो पैसे आए ही नहीं। मैंने कहा बुलाओ, मैंने अपने डॉट्स वर्कर को बुलाया। मैंने कहा, तो उसने पूछा कौन सा मोबाइल नंबर बिटिया डलवाई हो? बोला मम्मी का। बोलो, मम्मी का मोबाइल नंबर डाला, 3 महीने की किस्त मम्मी के अकाउंट में ट्रांसफर हो चुकी थी। अब उनको पता ही नहीं था। वो बिटिया से पूछ रहे थे तुमको 500 रुपया महीना मिले? अरे लिफाफा में रख के थोड़ी बिटिया के पास पैसे आएंगे भाई, वो तो अकाउंट में जाएंगे जो अकाउंट नंबर आपने दिया है। तो कई बार नोटिफाई नहीं होता पेशेंट। आप नोटिफिकेशन करेंगे, निक्षय पोर्टल पे है मरीज, तभी पैसा मिलेगा। आप सोचें कि आपने मेडिकल स्टोर से 184 लिख दी और उसको 500 रुपया महीना मिलेगा, तो नहीं मिलेगा। सर कॉन्सेप्ट हमारे क्लियर होने चाहिए, वी हैव टू नोटिफाई। हाँ सर, इससे मैं सर उत्तर प्रदेश में हम 100% दे रहे हैं, 250 करोड़ रुपया हमें 1 अप्रैल। मैं 10 साल से उत्तर प्रदेश स्टेट टास्क फोर्स का चेयरमैन हूं। अभी मैं नॉर्थ जोन टास्क फोर्स का चेयरमैन हूं। बिहार मेरे अंदर नहीं आता है, जम्मू कश्मीर, दिल्ली, पंजाब, हिमाचल, हरियाणा, राजस्थान, उत्तराखंड, उत्तर प्रदेश आता है। मेरे 9 राज्यों में कोई प्रॉब्लम नहीं है। बिहार में डॉक्टर डीपी सिंह साहब बैठे हैं, इनसे ये क्वेश्चन करिएगा।
अरे क्वेश्चन उनसे कर चुके हैं, वो हार मान चुके हैं
सर। पूरे नहीं, हार और जीत की सवाल नहीं है सर, ये
नहीं मिलता है तो फिर क्या करें?
हार और जीत की सवाल नहीं है, लेकिन 80% तो कोई सहमत नहीं हो सकता। इस हॉल में मक्खी मच्छर भी बैठा होगा, वो भी सहमत नहीं होगा 80% से। डॉक्टर डीपी सिंह बाद में कमेंट करिएगा। लेकिन यहाँ आपके स्टेट टास्क फोर्स है, स्टेट टीबी ऑफिसर हैं, स्वास्थ्य मंत्री हैं, मुख्यमंत्री हैं, आप उनको लिख के दे सकते हैं। स्टेट हेल्थ इज ए स्टेट इशू, ट्रांसफर करना उनका काम है। क्यों नहीं कर पा रहे हैं मुझे नहीं मालूम, हमारी यूपी में तो कोई प्रॉब्लम नहीं, मैंने 9 राज्यों का उदाहरण दिया, कोई प्रॉब्लम नहीं कहीं। अब बिहार स्पेसिफिक प्रॉब्लम तो ये है कि भाई मैं गया था अभी, मैंने सोचा एक जो यहाँ विक्रमशिला यूनिवर्सिटी है, विक्रमशिला यूनिवर्सिटी गया मैं, लेकिन रोड जाम, गड्ढा, सड़क खराब होने की वजह से बीच में ही वापस आया। मैंने कहा मेरा लेक्चर छूट जाएगा। तो ये तो स्टेट प्रॉब्लम है सर।
सर आप टॉक पे रहो।
ओके सर। सर आप ही ने रोका था। ये 3 मिनट मेरे निकाल दिए जाए टाइम से। तो ये फ्री डायग्नोसिस है। डायग्नोसिस तो सर फ्री हो रही ना प्रोग्राम में, उसमें तो पैसा नहीं लग रहा ना। ठीक, थैंक यू। फ्री डायग्नोसिस है, फ्री ट्रीटमेंट है। और मैं फिर कह रहा हूं, बड़े पुख्ता जिम्मेदारी के साथ कह रहा हूं, मैं इस देश में 9 राज्यों का टास्क फोर्स, नॉर्थ जोन टास्क फोर्स का चेयरमैन हूं, 9 राज्यों का काम देखता हूं। अनफॉर्चुनेटली बिहार मेरे पास नहीं है, तो नहीं तो मैं आंसर दे देता। एनीवे, तो आप चाहे पब्लिक सेक्टर से जाएं या प्राइवेट सेक्टर से जाएं, ये सब चीजें आपको फैसिलिटी मिल सकती हैं। और अभी इस हमारे पहले स्पीकर ने बोला था, चेयरपर्सन ने बोला था कि गरीब आदमी पैसा भी देगा, दुआ भी देगा। अगर इस गवर्नमेंट सेक्टर से उसको दवा दिलवा देंगे, निक्षय पोर्टल पर नोटिफिकेशन कर देंगे, तो उसको भी 500 रुपया महीना मिलेगा, और जब वो ठीक हो जाएगा 1000 रुपया आपको भी मिलेगा। तो मैं उस चेयरपर्सन की बात को रिपीट कर रहा हूं कि गरीब आदमी का भला करिए सर, उसको प्रोग्राम में डालिए, निक्षय पोर्टल से नोटिफिकेशन करिए, और उसको प्रोग्राम से फ्री दवा मिलने दीजिए, और 500 रुपया महीने भी मिलने दीजिए। मिलेगा, देर सवेर कहीं नहीं जाएगा। और कुछ चैलेंजेस हैं हमारे उसमें, कि जैसे हम लोगों की जो गाइडलाइन बनी है, वो गाइडलाइन आप सभी के पास नहीं है। तो हम सबकी ड्यूटी है कि वो गाइडलाइन, टीबीसी इंडिया एक वेबसाइट है, टीबीसी इंडिया वेबसाइट पे सेंसिटिव टीबी और ड्रग रेजिस्टेंस टीबी की गाइडलाइन मौजूद है। मेरा आपसे निवेदन करबद्ध यही है कि सेंसिटिव टीबी आप ट्रीट करिए, आप प्रिस्क्रिप्शन लिखिए, आप दवा दिलवाइए, ड्रग रेजिस्टेंस टीबी प्रोग्राम में जाने दीजिए। क्योंकि ड्रग रेजिस्टेंस टीबी में जब बिडाकुलिन या वो बेस्ड दवा मिलती है, तो ये मार्केट में नहीं मिलती है, केवल प्रोग्राम में मिलती हैं। लाखों की दवाएं हैं, फिर भी भारत सरकार इनको फ्री मुहैया करवा रही है। सो चैलेंजेस इन पब्लिक सेक्टर्स में बहुत सारी टेस्ट चैलेंजेस हैं, लेकिन फिर भी हमारी जो कनेक्टिविटी है गवर्नमेंट सेक्टर के साथ, सबसे बड़ा चैलेंज यही है कि हालांकि हमने इंडियन मेडिकल एसोसिएशन को एंगेज किया, आईएपी इंडियन एकेडमी ऑफ पीडियाट्रिक्स को एंगेज किया, एपीआई को कॉन्ट्रैक्ट किया, इंडियन चेस्ट सोसाइटी को एंगेज किया, सभी से कोशिश करने की जारी है। स्टेट में स्टेट टीबी ऑफिसर होता है, डिस्ट्रिक्ट में डिस्ट्रिक्ट टीबी ऑफिसर होता है। जिस डिस्ट्रिक्ट में आप रहते हैं वहां अगर प्रॉब्लम कोई डीबीटी की आ रही है, डायरेक्ट बेनिफिट ट्रांसफर की, तो आप अपने डिस्ट्रिक्ट टीबी ऑफिसर को संपर्क कर सकते हैं, उनसे हेल्प ले सकते हैं। वो इसीलिए डिस्ट्रिक्ट के टीबी ऑफिसर हैं कि किसी भी तरह की प्रॉब्लम हो तो वो सॉल्व करेंगे। और नहीं तो आप ये जो जिला क्षय रोग समिति होती है, उसमें सीएमओ भी होता है, डीएम भी होता है, दोनों से भी कह सकते हैं कि साहब हमारे पेशेंट को पैसा नहीं मिल पा रहा है, या आपको भी 1000 इंसेंटिव नहीं मिल पा रहा है। आपको मैं फिर कहूंगा, जब आप नोटिफाई करेंगे, ट्रीटमेंट पेशेंट डिक्लेयर होगा, तभी आपके भी अकाउंट में आएगा, नहीं आपका भी नहीं आएगा। मैं एक उठते दूं, देहरादून में अभी गया था, उत्तराखंड में, तो उसने कहा कि सर 3 लाख तो मुझे ट्रांसफर हो जाते हैं डीबीटी से, तो मुझे कुछ करने की जरूरत ही नहीं। तो आयुष तक के लोगों को सेंसिटाइज किया जा रहा है कि भाई आपके पास भी पेशेंट टीबी का आ सकता है, लेकिन आप भी प्रोग्राम को फॉलो करिए। सो नेशनल प्लान फॉर टीबी इन्फेक्शन मैनेजमेंट, ईबी जो इन्फेक्शन हो जाता है उनके लिए भी कैसे हम कंट्रोल कर सकते हैं, उसके लिए भी प्रोजेक्ट चल रहा है। मॉड्यूल जो चलते हैं, ये 2-3 एनजीओ हैं, ये अभी पता नहीं, जीत किसी के पास आते हैं, जीत के रिप्रेजेंटेटिव हाथ खड़ा करें। जीत के रिप्रेजेंटेटिव किसी डॉक्टर के पास आते थे, तो अभी जीत 2 शुरू हुआ है, अब फिर आएंगे। जीत 1 में उन्होंने कुछ जिले और कुछ चीजें दी गई थी, तो आपके इसमें भी प्रोजेक्ट चला था, ये 7-8 जिले थे। आई कैन हियर, ये बिहार मॉडल था, उसमें भी 6-7 जिलों में ये प्रोजेक्ट चलाया गया था। आई कैन रीड द नेम्स फ्रॉम हियर। यहाँ पे पटना था, यहाँ पे नालंदा था, गया था, और इसमें भागलपुर भी था। अब क्या क्या सर्विस हम लोग दे रहे हैं, तो एवरी सर्विस इज बीइंग गिवन, एलिजिबल प्रिजम्पटिव टीबी केस ट्रीटमेंट एडरेंस लिंकेज और जीन एक्सपर्ट, सीवी नेट, निक्षय नोटिफिकेशन, हर चीज की लिंकेज और हर चीज की सर्विसेज डिस्ट्रिक्ट टीबी सेल यानी डिस्ट्रिक्ट टीबी ऑफिसर के द्वारा दी जाती है। कोई भी इंफॉर्मेशन आपको लेनी है तो यू कैन कॉन्टेक्ट योर डिस्ट्रिक्ट टीबी ऑफिसर। और अब आप देखिए कि प्राइवेट प्रोडक्ट और प्राइवेट प्रोवाइडर फैसिलिटी, प्राइवेट फार्मेसी, गवर्नमेंट हेल्थ फैसिलिटी, इन सबके बीच में लिंकेज हो और आपका जो ड्रग प्रोवाइडर है यानी आपके अंदर अगर मेडिकल स्टोर भी है आपके यहाँ तो उसको भी हम फार्मेसी प्रोवाइडर करके लिंक कर सकते हैं। दवा उसी के यहाँ रख दी जाएगी या दवा वो दे सकता है, तो ये आपके यहाँ नोटिफिकेशन भी हो सकता है, आपके यहाँ दवा भी मिल सकता है। ये सब तरह का एंगेजमेंट इस सेक्टर में चल रहा है। तो हाँ, हम क्या क्या कर सकते हैं, बस 2 मिनट लेंगे, 3 मिनट जो बीच में मेरे खराब हुए थे। यूजिंग इंसेंटिव्स टू एनकरेज द प्लान। इंसेंटिव आप बात करें तो आपका जो कंपाउंडर है उसको भी पर पेशेंट नोटिफिकेशन 100 रुपए मिलेगा, फॉर केमिस्ट 30 रुपए पर पेशेंट फॉर 1 मंथ एफडीसी डिस्पेंशन, और फॉर लैब जहां से अगर कोई प्राइवेट एग्रीडेड लैब से डायग्नोसिस बनी है तो उसको भी 120 रुपी फॉर कोमॉर्बिडिटी डायबिटीज यानी HIV की स्क्रीनिंग के। तो इस तरह से पूरा, और बस क्या है कि जितनी रसीदें हैं वो सब मेडिकल स्टोर वाले को इकट्ठी रखनी पड़ेंगी। तो ये नोटिफिकेशन हो और ये स्ट्रिक्ट एंड इंटेंसिव नोटिफिकेशन हो। इसके नोटिफिकेशन टीबी नोटिफाइबल डिजीज है, ये 7 मई 2012 को लागू हुआ था, लेकिन इसका स्पेशल इंटेंसिव नोटिफिकेशन जो है 16 मार्च 2018 को हुआ, और उसके बाद ये पूरा लिंकेज सिस्टम है जो हम ऑलरेडी आपको बता चुके हैं। एडहेरेंस ट्रीटमेंट का होना बहुत जरूरी है। आपका बहुत अच्छा पर्चा है लेकिन पेशेंट कंप्लाई नहीं कर रहा है, और जब से देखिए जब से लोगों में ये हुआ है कि दवा के साथ 500 रुपया महीना में मिलता है, तब तक मैं आपको बता दूं कोई मरीज दवा बीच में नहीं छोड़ता है। इससे एडहेरेंस भी काफी इंप्रूव हुआ है। आउटकम आप देख सकते हैं, इससे आउटकम भी बड़ा है। और अंत में हम यही कह सकते हैं कि हाथ बढ़ाएं, जीवन बचाएं और टीबी मुक्त बिहार बनाएं, ऐसा करके अवेयरनेस प्रोग्राम भी चल रहा है आपके यहाँ। ये मेरी स्लाइड है जो मैंने अपने खुद के लिए बनाई है, कहीं मिलती नहीं है, कि 4 C's होती हैं, करेक्ट डायग्नोसिस, करेक्ट कैटेगराइजेशन, करेक्ट प्रिस्क्रिप्शन एंड कंप्लायंस। जो मेरा टॉपिक है प्राइवेट एंगेजमेंट का खत्म हो गया। मैं 1 मिनट में ये बात खत्म करता हूं कि अब जो है वो डायग्नोसिस धीरे धीरे मॉलिक्यूलर या बैक्टीरियोलॉजिकल की तरफ जा रही है। रेडियोलॉजी जो है वो काफी उसका रोल कम रह गया है, अभी भी है, लेकिन केवल रेडियोलॉजी पर अगर हम पल्मोनरी ट्यूबरकुलोसिस डायग्नोसिस बना रहे हैं तो 50% हम गलत हो सकते हैं। हर दूसरे एक्सरे में हम गलत हो सकते हैं। इसलिए हम ये सब सीबी नेट, ट्री नेट, एलपीए और स्पीयर माइक्रोस्कोपी, इन सब का माइक्रोस्कोपी 2 तरह की, दोनों तरह में कैसे बैक्टीरिया दिखते हैं इसमें दिखाया गया है। एक्सरे में आप देख सकते हैं एक्सरे हैं, लेकिन फिर भी इंटर ऑब्जर्वर एग्रीमेंट केवल 70% होता है, जबकि एफबी में 98%। चेस्ट एक्सरे में जो स्पेसिफिसिटी है वो केवल 50% है, जबकि स्पुटम में माइक्रोस्कोपी में 99% है। और इसीलिए 96 में मैं जब टेम्पररी लेक्चरर बना किंग जॉर्ज मेडिकल यूनिवर्सिटी डिपार्टमेंट ऑफ रेस्पिरेटरी मेडिसिन में, तो मैंने देखा कि लंग कैंसर का पेशेंट है उसको भी एटीटी चल रहा है, क्रॉनिक ब्रोंकाइटिस का पेशेंट है उसको एटीटी चल रहा है, इंटरस्टिशियल लंग डिजीज का पेशेंट है उसको एंटी ट्यूबरकुलर ट्रीटमेंट चल रहा। तो मैंने एक डायलॉग कहना शुरू किया, वो आज भी प्रचलित है, ये 1996 से चल रहा है, कि जैसे हर चमकती चीज सोना नहीं होती, वैसे ही एक्सरे का हर धब्बा टीवी नहीं होती। ये मैसेज जरूर जाना चाहिए जनरल प्रैक्टिशनर के पास। और सीरोलॉजी जो बहुत कहते थे एलिजा टेस्ट, उसका कोई रोल नहीं है। 2011 में WHO ने बैन कर रखा है, 2012 में भारत सरकार ने बैन कर दिया है। तो ये जो आते हैं IgG, IgM लग के, इसका कोई रोल नहीं है, प्लीज इसको ना करवाएं। ये डायग्नोस्टिक एल्गोरिदम है, और जब मैंने भारत सरकार से बात की कि क्या इसको मैं सिंप्लीफाई कर दूं, तो मैंने सिंप्लीफाई कर दिया। ये मेरा वर्जन है, मेरे ख्याल से ये ज्यादा सिंपल है। नेट प्रेस चेस्ट एक्सरे हम करेंगे किसी भी पेशेंट का, अगर रिफेम्सिन रेजिस्टेंस डिटेक्टेड है तो फर्स्ट एंड सेकंड लाइन एलपीए एंड ड्रग सेंसिटिविटी टेस्टिंग करेंगे, और फिर हम ड्रग रेजिस्टेंस ट्रीटमेंट देखेंगे कि शॉर्टर रेजिमेंट दें या लॉन्गर रेजिमेंट दें। अगर रिफेम्सिन रेजिस्टेंस नहीं डिटेक्ट हुआ तो हम फर्स्ट लाइन एलपीए करेंगे, कोई रेजिस्टेंट नहीं आया तो इसको ड्रग सेंसिटिव टीबी मानेंगे, और अगर आया तो फिर हम मोनो या पॉली रेजिस्टेंस मानेंगे। तो केवल 3 तरह की दवाएं आपको देनी है, ड्रग रेजिस्टेंस टीबी, टोटली ड्रग सेंसिटिव टीबी या मोनोपॉली रेजिस्टेंस। इसके अलावा ड्रग सेंसिटिव टीबी में लास्ट है रेजिमेंट।
3 मिनट भी हो गए थे,
हो गए सर, ठीक है। 2 महीने तक HRE जेड देते हैं, फॉलोड बाय 4 to 6 मंथ HRE, और ड्रग रेजिस्टेंस टीबी का ड्रग रेजिस्टेंस के हिसाब से करते हैं। ये ट्रीटमेंट कार्ड है, और ये फैसिलिटी फ्री डायग्नोसिस, फ्री ट्रीटमेंट, 500 रुपया महीना। DBT स्कीम, निक्षय दिवस हम लोग मनाते हैं उत्तर प्रदेश में हर 15 तारीख को। एक डिफिकल्ट टू ट्रीट टीबी क्लिनिक यहाँ चल रही ना बिहार में, डिफिकल्ट टू ट्रीट टीबी ऑनलाइन क्लिनिक हम चलाते हैं महीने में एक बार, जिससे कि कोई भी प्राइवेट प्रैक्टिशनर हो या सरकारी डॉक्टर हो अपना डिफिकल्ट ट्रीट टीबी क्लिनिक उस क्लिनिक में डिस्कस कर सकता है। अगर बिहार में नहीं चल रही है तो मैं कहूँगा आप भी चलाएं, ये चल रही है। ये मैं आपको जानकारी बता दूं कि इंटरनेशनल यूनियन अगेंस्ट ट्यूबरकुलोसिस एंड लंग डिजीज ने इंडिया में 5 सेंटर ऑफ एक्सीलेंस फॉर ड्रग रेजिस्टेंस टीबी चुने हैं। एक में हमारा किंग जॉर्ज मेडिकल यूनिवर्सिटी रेस्पिरेटरी मेडिसिन भी आता है। सो आई एम प्राउड टू शेयर। और ये हमारी किताब है, मैंने अंग्रेजी में किताब ही नहीं लिखी, सोशल अवेयरनेस पब्लिक अवेयरनेस का काम करता हूँ। पहली किताब मेरी 2014 में आई और उसके बाद 2 किताबें और आई, और ये किताब अभी लेटेस्ट मैंने लिखी है। अभी जो भारत की एजुकेशन न्यू एजुकेशन एनिवर्सरी 29 जुलाई को मोदी जी ने जो 100 किताबें हिंदी में रिलीज की हैं उसमें से एक टीबी की किताब मेरी भी है, और ये मेरे पब्लिकेशन है। और आपने धैर्यपूर्वक हमें सुना, इसके लिए बहुत बहुत धन्यवाद। इस तरह के आर्टिकल भी आप लिखते रहिए। बहुत बहुत थैंक यू।
थैंक यू।
धन्यवाद सर, बहुत अच्छी अपनी भाषा में सारी बातें समझाई। कोई एनी क्वेश्चन फ्रॉम ऑडियंस?
So the time has run out, so please we would like to move to the next speaker. We have Dr. P.K. Bhattacharya sir. Sir, माफ कीजिएगा जो
आप मेरे साथ बाहर चाय पे आ जाएं भाई।
Yes, thank you so much sir. Thank you so much Dr. Suryakant. Can we have Dr. P.K. Bhattacharya sir to please join us on the dais? Yes, sorry, but since the time for the discussion also was taken for the presentation, please adhere to the next speaker.
Sir,
Thank you so
one thing
much.
I like to add sir कि काउंसलर बहुत जरूरी है हर मेडिकल कॉलेज में, बिकॉज मरीज दवा बीच में छोड़ देता है, एमडीआर लेके आता है 2 महीना बाद। और दूसरा जीन एक्सपर्ट जो हम लोग करते हैं तो अल्ट्रा जीन एक्सपर्ट बाहर में हो रहा है, दैट इज मोर सेंसिटिव। कैन यू रिकमेंड गवर्नमेंट?
Water if you need, that's a fresh water.
Not yet started, no? No, no, no. If you want, you can change it. No. I can use this also for the changing. This one, no?
All right, a kind request for the next speaker to please, let's respect the next speaker. I request the chairpersons to please give a go ahead. We have Dr. Prashanta Kumar Bhattacharya with us. And yes, chairperson, if you can just give a thumbs up also, sir is ready. Yes, he's given a thumbs up. Let's have the talk. Sir, over to you, please.
Chairpersons, ladies and gentlemen. So my talk is little different from the previous interaction. This is on a critical appraisal of a scientific paper, that is a scientific publication. I come from Assam, working in the state of Meghalaya in a central government institution currently. And this is a part of my duty besides being a physician for research methodology as well as for medical ethics. So who should be reading a scientific paper and why? So these are the issues we have for career improvement, for mentoring postgraduates and PhD scholars, and for academic interest. I don't see the timer here. Can I see that? Yeah. Oh, okay, thank you. And other than that, do we need this for practicing doctors? The answer is a big yes. And why? Because it helps them for a better clinical appraisal of any articles, the weakness and strength, and to apply it in evidence-based model in clinical practice. So is clinical experience not enough? You have worked for 10 years, 20 years, 30 years, 40 years. Is it not enough? I would say that it is not enough because clinical experience is mainly anecdotal. It is derived from personal experience or limited to a few experiences. So then where to find the answer? There is a rapid pace of expansion of the medical knowledge, and most information is not of practical relevance. And how to find the right article at the right time? That is to find a needle in a haystack. So this is the way how you can find out the article that you actually would require for your particular publication. So what is the limitation in information collection? See, this is the data about 10 years from now or 20 years from now. At that time, there were 52 RCTs published every day. And a doctor, to keep pace with only the RCTs, had to work in day and day night, leaving aside the other types of articles as we have here. Then where do we find the right answer? For that, you need to read an article or an original article critically. You have to try to find out the lies in between a paper that lies in there. There is 3 ways by which an article is being read. One is browsing, you flip through the books and journals looking for anything that might interest us. Reading for information and reading for research. You seek gain comprehensive view of the existing knowledge, ignorance and uncertainty in a defined area. So reading for information and its practical application in solving clinical problems is essential for the practice of evidence-based medicine. So next, what do you do? Is the paper worth reading? So if you go to the article, it is usually found in the IMRAD model. I need not elaborate on the IMRAD model in front of the learned audience. But one thing that is important is you look specifically for the methodology of the paper. Don't go for the other areas. Look for the methodology rather than for the results and other things, because many published papers have potentially serious methodological flaws, and that will affect the outcome. A few preliminary questions to ask. What clinical questions are there, research questions, what type of a study has been done, and is the study design appropriate for the research question? So these are the different types of research questions that can come to the mind of a doctor, starting from clinical observation, biological phenomena, anecdotes, clinical reasoning, case reports. I have not been permitted that much of time to go into each and every one of them. These are very interesting areas. Case report, I would say that even HIV AIDS was diagnosed based on a 4-case series that is a breakthrough. So case series, case reports also are hypothesis generating issues which are very important. From there you generate the hypothesis, go to the study objectives. The study objective leads you to the type of clinical research, and from there you get the output in a paper or as a publication, and this can also be applied. So that is the ultimate aim. So what is it? So did the investigator assign an exposure? If it is yes, it is an interventional study. If no, it is an observational study. Was comparison group assigned? If it is no, it is a descriptive study. If yes, it is again an analytical study. There are 3 types of basic observational analytical study. One is a cross-sectional at the lowest rung of the evidence, then the case control study and the cohort study. So this is what we have. Is the study design appropriate to the research question? So depending upon the type of the research question, what I should do about the condition, what causes the problem, does this problem have a condition or a problem, who will get the condition, and how common is the problem. Based on these, we have the type of a research question, whether it is interventional, etiology, diagnosis, etc., and the type of study, either it is an RCT, a cohort, or a case control study, or it is either a survival study, depending upon that. So these charts helps you to find out that. This is the hierarchy of evidence. The lowest at the bottom, case reports, highest is systematic review and meta-analysis. Some of the statistical issues for the non-statistician. Have the authors started the study correctly? So this is one thing we should know. Are their groups comparable and, if necessary, adjusted for baseline differences? In all studies, we find the first slide usually is comparing the baseline parameters of both the groups, and you will find that the P is always insignificant, greater than 0.05. That means the groups were similar when they were picked up, and so that you can either put on the intervention or not. So that is the basic thing. Then type of data obtained, whether the statistical tests were appropriate, and have the data been analyzed according to the original study protocol. If the original study protocol said that you analyze the data at the end of 6 months, if you're finding very good results, not like the mutual fund or the stock market, you cannot stop the study there. You have to go to the end of the 6 months. If the reports are not coming in favor of your trial at 6 months, you cannot go 1 month ahead. You have to stop the study and find it out. So that was the protocol. So you cannot change the protocol. There are variables, data and paired data that are coming in. So why we require paired data sometimes? If something is measured twice in each participant, like supine and standing blood pressure, or the hemoglobin before and after giving iron, we require to calculate in each individual a pre and a post data. So whether this was done or not. Then the second concept is about the tails and outliers. So certain studies have got two tails while analyzing the statistics. This is required in most of the interventional studies when you are testing two different interventions. You cannot know before you start the trial that the new intervention will be better. If you do a one-tail study, it will definitely show superiority trial. So if you do a two-tail, it can show a comparison of equivalence, inferiority, as well as a superiority trial. So that is why a two-tail study is always required. The second point is outliers. Sometimes while taking the data, you find that some of the data are either too high or too low. This can happen most of the time because of errors in correction. But sometimes these can happen because of disease in one or two of the individuals. Supposing you're taking a growth hormone data of individuals and suddenly the growth hormone shoots up in one or two. That is an outlier. So is it a mistake? You re-verify and find that it could be a person with acromegaly. These are facts. Then the concepts of correlation, regression, and causation, whether they have been done or not properly. Correlation tries to find out between two parameters, dependent and independent, whether there is any relation between them. Wealth of a person and curly hair are not related to each other, so there is no correlation. But the weight of the age of an individual and the serum creatinine are correlated. As long as the person ages, the creatinine goes up. So that is it. The second concept is the regression. In regression, what do we want to find out? The senior resident wants to know whether we can take out the patient from the ICU. So what are the parameters based on which he is going to take him out? Whether it is hypotension or bleeding or a tachycardia or a SpO2. So this will be analyzed by a regression model. There are different types of regression models, univariate, multivariate, and Cox regression model depending upon the time. We will not go into that, but this is how the regression model is started. Then after that you have found out, after the correlation and the regression has been done, whether one is a cause of the other. So that is called the causation of the study. So what is causation? If you want to test causation, you will have to find out these particular areas. Is there evidence of true experiments? Association has been strong or not? Whether it is consistent from study or not? So there is a list of causations. How many more minutes we have now? Okay, coffee. So is the association consistent from study to study? Is there a temporal relationship which is appropriated? Is there a dose-response gradient? Does the association make epidemiological sense? Sometimes we do a lot of studies but does not have any scientific reasoning. Is the association specific? And is the association analogous to a previous proven causal association? Then the last thing that is interesting for the PG student or for the researcher is whether the p-values and the confidence intervals have been calculated and interpreted correctly. So what is the p-value or the probability? If you want to study out whether a difference exists between two groups in a yes and no term, whether surgery is definitely superior to conservative treatment in a disease like acute cholecystitis, the concept of hypothesis testing and the p-value would definitely come in. So this p-value gives a quantitative estimate of the role of chance coming into play to produce the difference between two groups. If you measure the blood pressure of an individual several times by the same instrument at the same moment, you will not get the identical value. So these values are either higher and lower than the original. So these are by chance. If you measure the blood pressure by two different types of instruments, an electronic or an aneroid or a mercury, you will get different readings, and these different readings are because of bias. They will go in one direction, this will go in both the directions, so this is chance. To eliminate chance from your experiment, we have to take the help of this p-value. So if the p-value is small enough, by convention we take it as less than 0.05, the role of chance in producing such a difference between the groups is less than 5 in 100 times or less than 1 in 20. And then we can accept this difference as statistically significant and not influenced by chance alone. As the p-value becomes smaller, the role of chance coming into play diminishes and becomes more and more significant. The p-value is therefore a quantitative estimate of the probability that differences in the effects of two interventions or comparators could not have happened by chance alone, assuming that there is basically no difference between the two groups. So that is the p-value, and most of the postgraduate students and also the younger mentors are very apprehensive whether the p-value would come in significant or not. Sometimes we actually want a p-value which is not significant. During the recent trials of drugs during COVID, people wanted that this p-value should not be significant so that you can throw away the drug, most of the drugs, that they are not necessary. Now, what is confidence interval? P-value has got a limitation because you have to give an answer in yes and no terms. But sometimes an answer comes in such a way that you're getting a good positive result, but you cannot prove it by a p-value. So what are you going to do that, and why it is happening? Most of the time it is happening because the structure of the study is at fault and the sample size is less. That is the most common cause. If you increase the sample size or the duration of the study by protocol, the p-value would become significant. So if you don't have the time for that, you take out the confidence interval. So what is the confidence interval? It is the alternative method to overcome the limitation of hypothesis testing, and it tries two questions. What is the single value most likely to represent true difference in treatment and control? And secondly, what is the plausible range of differences within which the true difference lies? Then we come to the next thing, is whether our result is going to give us some benefit or harm. That is the most important thing. So this is a 2-by-2 table, and 3 of the calculations are important. One is a relative risk reduction, one is an absolute risk reduction, and the third one is number needed to treat. How many persons you have to treat to get an answer? Let us take a study in France, carrying out randomly assigning 198 patients to aspirin compared to 204 patients not receiving aspirin for secondary prevention of stroke. During the 3-year follow-up, 17 of the intervention group developed a fatal or non-fatal cerebral infarction as compared to 31 of the 204 patients in the control group. And from these calculations, I will not go into the calculations here, you will find that the relative risk reduction was 43% with aspirin, which is quite significant. Absolute risk reduction was 6.6%, the more than 6%, and the number needed to treat, that means how many patients you have to treat with aspirin to prevent a secondary stroke, is 15. So that is the calculation which the clinician would ultimately want. So what are the key messages? Knowledge of research is essential to both medical teachers and practicing physicians for critical appraisal of medical literature, for making clinical decisions. Evaluation of the paper should be in terms of its methodology, validity and relevance to the contents and results. Results should not only be statistically significant, but should have clinical significance. And finally, it should have applicability in day-to-day clinical practice. Thank you all.
Thank you. And I think this is the last topic. And any query, question?
Yes, we have time for questions because Shur has finished in time. All right, I think since there are no questions, we would now move to the debate, and I would like to thank the chairpersons and the speakers. We would like to felicitate the speakers and the chairpersons with a small token of appreciation and a memento. We've got our scientific chair with us as well. Dr. S. Sharma, could you please do the honors and present the bouquet, memento, and the shawl at the felicitation ceremony? Yes, it is ready, and I'll just get it the moment I start with the debate. For the debate, we've got, thank you so much, chairpersons. Thank you. Dr. Manish, I'll just start with the next session and I'll get it done. Can we, yes. For the debate, we've got Dr. Jayendra Panda versus Dr. Amit Das, right? हाँ लड़ाई में सर आप ही तो ठीक है आप कर दीजिए हम इंतजार करते हैं yes yes it's coming For the debate, I believe Dr. Jayanta Panda would be going in first. Yes, could you, in the meanwhile, check, because you know the time is of the essence over here. The total time is 20 minutes, so I would say 8 plus 8 will be given to each, and then Dr. Jayanta would get a rebuttal. Am I correct? उनको भी ये पूछना पड़ेगा ना?
आपको मॉडरेटर बुलाना है ना?
हाँ, उनको तो बुलाऊंगा ही, लेकिन मैं तो चालू नहीं कर रहा हूँ, लेकिन मैं सोचा कि तब तक हम लोग ग्राउंड रूल्स बना दे, कितने ओवर की मैच होगी, कौन बैटिंग करेगा पहले?
Same. Put 8 minutes.
Yes.
And then
4
rebuttal,
minutes.
4 minutes.
Correct. Okay. Total 2 minutes.
2 minutes.
ठीक है, हो जाएगा. थोड़ा सा last है. You know, the fortunate part in this disguise is this is the last debate and the session for the scientific. So a few minutes for the rebuttal can, you know, we can extend more, but yeah, we'll be strict for the 8 plus 8 for sure.
So
क्योंकि थोड़ा सा will be fair. Yes, I'm just waiting for the moderator. वो photo खिंचा रहे हैं Instagram और Facebook के लिए. हाँ, नहीं उधर तो सेशन तो चलेगा ही. ये हॉल ए का है ना. I believe Dr. R.K. Modi is also going to be the moderator, if I'm not mistaken, correct?
Yeah, Dr. M. Shankar Sharma and Dr. R.K. Modi.
Can I request Dr. R.K. Modi in the meanwhile, if he's here, to please join us as a moderator on the stage? And yes, requesting Dr. R.K. Modi. नहीं अभी तक नहीं है. Dr. Hem Shankar Sharma, please, if you could join us, because आपका ही इंतजार हो रहा है और आपने ही कहा था कि ये कॉन्फ्रेंस को समय पे चलाएं, तो आपके बोलने पर ही तो मैं अब हाँ. All right, so we've got our moderator, Dr. R.K. Modi, sir. Thank you so much, sir. In the meanwhile, just to let everybody know, 8 minutes plus 8 minutes plus 2 minutes for rebuttal. Okay. So. हाँ सर. नहीं सर, just.
कारगिल वार.
आपके बिना कैसे चालू होगा? Sir, 8 minutes plus 8 minutes, very strict, and then 2 minutes का rebuttal थोड़ा सा leniently. ठीक है?
How many minutes you are giving to us?
8 plus 8 plus 2 plus 2, यानी कि total 20.
Our warriors will be fighting.
Yes, वो fighting के लिए तो ज़्यादा ही होगा, because वो तो आखिरी fight होगी.
15 minutes का है, ठीक है?
नहीं, total 20 minutes का है, so 8 plus 8 ना? नहीं.
So the judges will be sitting in front of me. All are judges. So
अच्छा,
finally they
15
will
plus
take
15.
decision from the house that who is the winner.
He's the boss.
Then we will see.
15 plus 15.
Doctor, side हो जाओ. Dr. Jayant Panda.
अजित 15 मिनट का टाइमर लगाना.
Big name in
Yes.
the country. He's MD internal medicine, a professor of medicine in SCB Medical College, Cuttack, Odisha. And topic is digital diabetes management. So I request all those who are present in the hall, please listen and see the fight between the two friends. One friend is in the Pierre Bihari style, I suppose. Gamcha pahin ke aa gaya hai. Digital diabetes management too much complicated for an average Indian. So an average Indian, what he thinks that how you are going to manage the diabetes digitally, non-digitally. So there will be the better aspects. We will be just listening to them and finally we will have our comments. Thank you and over to Dr. Jayant Panda.
Thank you, sir.
Time starts now.
Thank you for that nice introduction to the topic and me. And most respected Professor H.S. Sharma and Dr. Modi, I see the doyens of the country from this region, eastern region, Bihar, are here. Professor A.N. Rai here, Dr. B.K. Singh here, Dr. D.P. Singh here, and all who are here are known friends, part of the family. It's a pleasure being with you all this evening, but I had again a tough time. Once from Patna to Gaya, virtually I had to run for my session, and today from Devagar to Bhagalpur, again with the cities, with the towns, with the markets, with the traffic, had to fight, and I could reach just 3 minutes before my session. I'm very lucky. So I'll give you a overall impression of the topic, what has been assigned to me, the digital diabetes management. But before that, conflict of interest, I have held Bapicon hospitality, Dr. Singh's hospitality. And I salute the team, Bapicon and East Zone Epicon, led by Professor B.B. Thakur and Professor N. Rai and Professor D.P. Singh and whole team, because grand arrangement, grand participation, and it's equivalent to a national API, I'll tell, because who's who or the faculties are here. Maybe it's in Bihar, it's in Bhagalpur, but whole country is invited to Bhagalpur. Please give a big hand for the Bapicon East Zone
Hello.
Epicon. I'm overwhelmed with the arrangements. Digital diabetes management. Before that, I want to take your opinion. You have children, you have grandchildren who are teaching you digital technology day in and day out. And how many of you today are without smartphones, without computers, without video calls, and without gadgets? You're managing with the pen and papers. You go back 30 years, 40 years, 50 years. How many letters you are receiving? And how many letters you are writing? And now it's all text, it's all mail, and we have gone digital. Whether you agree or you don't agree, we have gone digital. And the same digital technology has entered our medical practice arena, say it be diabetes, say it be gynae-ops, say it be robotic surgery, say it be the telemedicine. Everywhere we see the digital print. And after COVID, you see, whatever hitches were there, during COVID, you remember court gave a verdict that the advice in the telemedicine is accepted legally, which were not accepted. Telephonic advice was not accepted legally earlier, but that was cleared. And everything became digital savvy, technology savvy, and based on artificial intelligence. So I won't agree that digital diabetes management is too much complicated for an average Indian, and I'll be speaking against the motion. The AI technology in diabetes clinic shed, I need not tell. Much before now, you are doing your patient's SMBG. You see, I've taken a glucometer's picture. And what is a glucometer? You are doing a SMBG with this. This is a digital monitoring which has been incorporated in the practice for last 4 decades. And a insulin pen you are using, a continuous glucose monitoring you are using, all are AI based and all are digitally planned. I'm telling you this list and you will realize without your knowledge the digital technology has entered your practice. The flash continuous glucose monitor, the smart ECG, a iWatch, a smart watch can record your ECG. If your heart rate goes high, it gives a beep. Something wrong is happening here. The smart drugs, the apps, the smart weighing scales, smart shocks, artificial pancreas, smart watch, smart blood pressure monitor, and smart contact lenses. All are in place, being used by our patients and being used by all of us day in and day out. And the challenges in the diabetes management, whatever you face, you are unable to make it interesting. You are unable to remind your patient. Your patient goes and comes after 3 months, 6 months, a year without medication. And you fail to remind your patient, you fail to control the blood sugar, you fail to see a timely blood glucose report. But here what happens? The glucometer is connected, and once you do a test, a message goes to the consultant's mobile and also to the patient's mobile regarding the blood glucose level. That's a smart technology that I'll show you, and that clearly tells you your all barriers, all stigma, all inertia, clinical inertia is tackled by the technology at present. So digital diabetes management is a smart option for a average Indian, where a vegetable vendor uses a smartphone, a housewife does a video call. It never goes without saying that the technology has entered our daily life. You know, the role of technology: improve access to care and empowering patients. Till now, we were telling the patient, 2 unit बढ़ाना है, 2 unit कमाना है. Gone are the days. Now patients are Google savvy, they are tech savvy, they are able to know what is happening. Now will not get a patient who will come and tell you symptoms. They'll tell, I was taking this insulin in this dose, this much is delayed, and now I am facing this. Doctor, are you able to advise me something? So every patient talk like a partner, a team member, or a medical professional to us at present. That is because the understanding of the people regarding the technology and the science have gone up, and only a technology-based management has made it possible. And this patient empowerment we have to accept. Many doctors get irritated. Why are you telling that? मैं जो बोलता हूँ सुनिए, सुबह शाम को ये खाइए और मेरे को आके बताइए. Patient is not agreed to do that. If you tell that, you'll lose the patient. Patient will go to the doctors who are digitally savvy. So it's better you utilize the patient's resources, patient's caregivers' resources to change for digitally. That set of clinic with a prescription pad and a BP instrument will no longer hold good. You have to take a computer system, you have to take internet, you have to take a smartphone, you have to get an assistant who is IT savvy, and you have to manage a digital diabetes clinic. I'm telling you, if you are unable to do that, you will be thrown away. You have to stop your practice, and your business will be taken by your colleague who have time and interest for digital technology. Smart glucose monitoring devices, I was telling, all the clinical trials at present is by these devices, where the future of the smart glucose monitoring, I was telling, if you do a test, a message goes to the patient's mobile, a consultant's mobile, and one of the caregiver's mobile which you want. So any alarm for hypo or any alarm for hyper goes directly reminding the person regarding the timely blood glucose adjustment. The smart glucose monitoring devices helps the patient to keep the blood glucose in control, and it's a real-time blood glucose monitoring and data analysis. You know about the CGM, continuous glucose monitoring, which checks the reading, tell you time in range, tell you time above range, tell you time below range, and allots how much of time the patient is out of control. Gone are the days at the end of 3 months you do a A1C and be happy that A1C is 7. You see daily fluctuation. You just touch the meter and it tells you the present blood glucose. Those who have put a LibrePro themselves, they know how beneficial it is to control. The mobile app for diabetes management is very useful. If you are not used, download and use it today itself, which not only tell about the diet and the lifestyle, tell about the dose adjustment of the insulin. Not only the blood glucose goes to the app guides आपको क्या करना है, क्या नहीं करना है. And it works partially between the doctor and the patient, guiding the patient about the good control. Telemedicine has changed the concept of consultation. Many of us avoided the patient during COVID time, and telemedicine came into picture. It was there since long, but we have rediscovered telemedicine, and a diabetic consultation over tele becomes very effective because you know the patient, you know the control, you have to see the report and adjust the doses. That can be easily done without traveling hundreds of kilometers to the clinic, and even a consultation charge can be levied for that. That is the benefit, and all of you have seen the benefit of telemedicine during the pandemic time. Artificial intelligence has changed the world and so also in the medicine. Like other fields in diabetes, we want to introduce artificial intelligence to teach your patients' caregivers, teach yourself that how machines can be helpful. The machines can suggest you the action. If you put 10 X-rays to the machine, it can tell how the X-ray can be suspicious of the tuberculosis. Your knowledge is the final. Machines are machine, but a clue that to based on the intelligence always helps a consultant. Benefits of AI in diabetes are many, and the enhanced self-management, optimized treatment plan, and the improved access to care, I have already told you, and believe me, once you take, those who are using an iPhone, you know predictive texting. You have typed a word and the next word is suggested. How you are becoming happy. The phone studies your habit, and if you send a mail to someone, he suggests, do you want to send the mail to this? And Siri asks you what you want from me. So if you get such an assistant from the AI era, you will be happy or you will be sorrowful. The wearable device for the diabetes tracking, you can track your patients, and anybody who is cheating, who is taking food, who is taking high calorie, that can be very well be controlled. The digital diabetes education, you can control online platforms, courses and tools, and personalized diabetes management solutions, the tailored treatment plans and improved monitoring and management. You can be in touch with the patients who is very far in other countries or other states from here. So this practice can go far, and the integration of the data for the better diabetes management, benefits collecting and analyzing the data, all your patients' blood glucose and patients' behavior can be analyzed over the time. The improved patient outcome, increased access to care, and the cost saving all support the digital diabetes management. So finally, the affordability of digital diabetes management solution and cost considerations are all in favor. Privacy and the security concerns like data protection and patient confidentiality are through legally by court of law. So to conclude, if a housewife can do a video call, if a vegetable vendor can manage a smartphone, if a smartwatch can give you a ECG, predict your heart rate, why not serious problems like diabetes can be managed digitally, can be managed by artificial intelligence, can be managed by the advanced technology. And if we take that, believe me, your cost comes down, your control becomes better, and this is the time, starting from a small child to a grand old man, all are digital savvy. You'll see everybody with a tab or a smartphone in the airport or the railway station. And this use can be extended to the important fields of diabetes management, and I am sure all of you will adopt this and take it to your daily practice to give the benefit to the patients. Thank you for the time.
Thank you for ending in time. Now I ask the second person. Now you can take your seat here, sir. You can come here, sir. You will
Dr.
be listening
Amit
and
Kumar Das.
looking on to what your opponent has to say. You talked very good circumstances about the management digital watch. I'm sorry, I am also having a digital watch which tells me to get up. Your time for sitting is over. Now may I request Dr. Amit to be here, and what he has to say, whether I don't know on which point he is going to focus, but in the morning talks I was here when everybody was talking about the sympathy and empathy, how the artificial intelligence is going to be sympathetic to us or empathetic to the patient. Let us see what Amit says.
Well, you can see Dr. Amit Kumar Das already on the stage, but he's come with a different style. माथे पे क्या लगाया है वो उनको ही बताना होगा. Under stress, pressure? No, I don't think so.
Welcome, Dr. Amit. We know you are a great fighter and you will fight for India. India should go digital or not. Dr. Amit. Digital system has failed.
प्रणाम सर. मालिक प्रणाम. ये चल ही नहीं रहा है. ए आवाज दो यार.
सेटिंग है क्या?
ये डाटा खत्म हो गया क्या रे? ये बज का नहीं रहा है.
डॉक्टर जयंता ने पैसे खिलाए.
छोड़ दो, नहीं चल रहा है. डायबिटीज भी ऐसा ही मैनेज होगा. स्लाइडवा डाउनलोड करो. नहीं चली हो. Thank you very much. Can we have the slides, please? I hope my slides are visible now. For the usual technical glitch that we have in the conferences, my dear friend Dr. Jayant Panda says that digital is the fashion now. So let's move ahead. How do I move my slides? Yeah. So the topic is digital diabetes management is too much complicated for an average Indian. I'd rather say we are sitting in Bihar. It's too complicated for people like us who live in Bihar. Dr. Panda doesn't know what Biharis are. This is an average Bihari, and the whole talk will revolve around this person, and this is the disclosure I have. I have actual and potential conflict of interest in this topic because I am representing this man. And who is this? This is Binod. And he is guided by whom? He is guided by this fellow who says, देखो विनोद कैसे अंग्रेजी बोल बोल के घुमाया जा रहा है. Well, I must apologize and I must admit that I'm no match to Dr. Panda. He's a very, very big man. Not as big as this photo, but he's a big man. I don't say him. Sir. And a very small, minuscule person trying to, push the big man out of this context. I am sure I'll lose this match. But what my teachers taught is diabetes management should be available, should be affordable, should be acceptable, and should be achievable as well. The slides are moving at a faster rate. This is the technological glitch. And already introduced, digital health includes technologies, platforms, systems, which collect, store, or communicate health informations and assist life science and clinical operations. And then it helps and has the potential to allow consumer to engage in the health, behavioral change, and impact the analytics. So there are various modes of digital diabetes management. I'll try to detail some of the topics and tell you some stories which will help to understand why I'm opposing this. These are the health, digital diabetes management. You have the mobile health, you have the mobile health services, you have the e-health, and these are the advantages. It's a tailor management, it's a patient education and awareness, has instant feedback. You can share the data and you can use it for research purposes. You can maintain large amount of data, and there is a quality care for people who are unrepresented or less represented. But then let's see, where does India stand as far as internet is concerned? So India is the second largest digital population in the world. Sounds very attractive. So we have almost 700 people, 700 million active internet users above the age of 2 years who use internet. So big number. 700 million people. But if you calculate, more than 50% are still unrepresented. There's only 700. We have a population of more than 1400 million. So India is largely unrepresented, going by the numbers. And interestingly, what do the people in India do on the internet? 700 million people use कर रहे हैं. क्या देखते हैं, क्या करते हैं? भाई देखिए, आप लोग अपनी नजरें मत झुकाएं. हम क्या करते हैं? What do? We do shopping. We do gaming. And we watch movies and TV shows on the mobile. Rarely do we use these mobiles for our health purposes. And interestingly, 85% of young people use mobile, and they are online for more than 5 hours. And 5 hours you don't spend on health, do you? You spend on movies, social medias, OTT platforms. And 40% are using pornographs. So there's a lack of awareness about privacy and safety control measures on online platforms. You don't have any control. You have a button, you can press anything. Or you will be pressed into anything. Dr. Panda said telehealth is in vogue now. So let's see what happened after COVID. So in COVID, you had a big boost, but in 2021, the next year when the COVID was still increasing, the use of telehealth has gone down. And I must admit, all of us in this platform who are senior consultants might have used teleconsultation for your patients during the COVID. How many of you are actually using right now? Less than 10%, I'm sure. You all love to see patients in person. In India also, there's a slowly decline in the interest in the telehealth. People are investing less as for the business today. Challenges are multiple. So it cannot be a replacement. It can be an additive. It cannot be a replacement to the usual health services. Now, if it is too easy, will it be overused? Continuity of care. You use e-Sanjeevani apps in your state health services. Now, e-Sanjeevani, you see Dr. Navneet is seeing patient on one day. He asks for reports on one day. And the next day, Dr. Manish will see that patient. So there is a lack of continuity of telehealth services, and that doesn't convert into the most essential component of health services, which is relationship, which is confidence between the doctor and the patient. So that wanes away. Though we are easy, accessible, but the relationship fails to develop. I did a small survey before coming to this conference in a small village which was largely unrepresented, and I asked them कि क्या आप अपने परिवार का सदस्य शुगर का इलाज कराना चाहते हैं तो टेलीफोन या टेलीमेडिसिन से इलाज कराना पसंद करेंगे या डॉक्टर से मिलकर करेंगे? 89% सेट कि डॉक्टर साहब आपसे मिलकर ही करेंगे, टेलीमेडिसिन तो छोड़ दीजिए. So this is the state of affairs of telemedicine. Now, Dr. Panda said of CGMs, there are various types of CGMs. It's very nice. It gives you so many advantages. Research and evidences are very strong-fold. Across the globe, you have evidences which say that CGM is very good in predicting hypoglycemia, in predicting good control, predicting less hospitalization. Evidences are large, huge. And the recommendations are also there. So whom to use, when to use, by ADA, ACE. But my dear friend, does this Vinod understand that these telecommunications recommendation, CGM recommendation? No, he doesn't. So the center of attraction today is this Vinod, an average Indian, an average Bihari. The reports which are generated are too beautiful to put on your wall. It looks very nice, like a painting. Is it easy to understand for an average Indian? Let me tell you that 2017 we had a different guideline, 2029 we had a different guideline, 2023 we have a different guideline. This person would be largely perplexed by this time in range, by the targets, and by this, I don't know what is this, GMI. This is the glucose management indicator, and it is calculated by this complex formula of 3.3 into plus into this, that, and it gives you an average glucose in the last few hours. So it says that GMI is better indicator of HbA1c. So it gives you a better understanding of the glucose profile of that individual. You are better placed. Only few people in this crowd would understand. One of them would be my opponent today. Dr. Panda is sitting and trying to understand glucose management indicator. I know he has understood, and he'll tell you after this, after my talk, in my rebuttal, what is GMI. In 2020, I had a talk on the pitfalls of CGM, and I discussed in details the various pointers of the problems of CGMs, and there are so many issues, the acceptability issues, the challenges, and one story from Facebook I just heard. One night I woke to a strange noise. My iPad was ringing. The Guardian app was showing that I was in severe hypoglycemia with a glucose of 50 milligram. I woke up, I checked with my glucometer, and my glucometer showed a 74 milligram per deciliter. Libero showed a glucose of 63. Needless to say, I was asymptomatic, and I was pained by this entire process. So this is the alarm which this CGM, the nice device, will give you at 2 a.m. in the morning. Hypoglycemia, hypoglycemia, hypoglycemia. और आप उठ जाओगे, अरे मुझे तो कुछ भी नहीं हो. Because it follows. So the time lag, there's a time lag. So you will not be given the right alarm. Now the M Health story. So health apps, multiples, of which one is the Practo, and I'll tell you the story of Mr. Sanjay. Now, who is Dr. Sanjay, and what is the story from 50 to 15? So this is Dr. Sanjay. Do you recognize this person? He is Dr. Sanjay, and this is the story. Dr. Sanjay was a general pediatrician and was doing his private practice in his chamber, and he was seeing almost 50 patients per day. Now, he was recommended, some of his friends recommended to use a app, say Tracto app. And he started a Tracto app, and now that opened a Pandora box. Now he got a booking of 50, 1/5 didn't turn up. People asked to start his questions, how to use Tracto? Why am I getting this? No, reminders after reminders on Tracto. No, Tracto also shows advertisements. So are you endorsing these products? ये चीनी खाओ, ये आटा खाओ, ये गेहूं खाओ, ये millet खाओ. Are you recommending it? So he was actually pained, and his staffs were also pained. His patients, while searching for him in the Practo, had other options also, and they started searching for the other person. Now from 50, he is seeing 15 patients per day. पहले मैं बहुत मोटा था, फिर मैंने टीवी देखी और सोना स्लिम बेल्ट मंगवाया, अब मैं बेवकूफ भी हूं. So 15 to 50. This is M Health. The pedometer story. My wife is very particular about my health, and she uses an app called Pedometer on my wrist and asks me to run every day. And every morning what happens? I forget that. And what I do, I tie this app to my driver, ki chalo daudo, and I show my wife my pedometer profile. So this is called cheating the pedometer. And is it actually showing is it specific, or is it actually showing your pedometer profile is actually showing? No, as you run fast, the specificity of active monitors go down. So specificity issues are also there. Now you have a whole lot of applications and on the internet, and it requires some amount of literacy. Now this literacy is called digital literacy. Now digital literacy is always lags behind the usual literacy, and the speed with which internet things are moving are very, very fast than the digital literacy rate. So you would be left behind the speed with which internet is moving ahead. So digital literacy rate always lags behind. Can the patient distinguish between the accurate and inaccurate health information which they find online? I'll just tell you another story for this, Mr. Binod. This is the mental TikTok health. So TikTok is no more banned. In 2020, TikTok was there. And 2020, the mental health TikTok, you almost used 4 crore people viewing this site. And when people analyzed this mental health TikTok, 83% of the things which were shown were misleading. More than 45% pair were inaccurate advices. Potentially damaging advices were also there. So is it possible for these people from villages to understand the accurate and inaccurate differences? No, I don't think so. Then if you go online to search articles, you'll see all kinds of health sales. Mr. Party trying to cure your diabetes without medicine in 72 hours. And then you'll see all sorts of diabetes ठीक होगा advertisement. कि diabetes ठीक होगा आप type करिए और then you see so many advertisements. Is it practical or worth understanding that an average Indian will understand the truth behind or the untruth behind these advertisements? I don't think so. And then there's a data privacy issue. The iPhone said, I have only the privacy, health privacy. So health privacy data is also an issue. You can sell your data to a company which can use your data. Social medias, most of us use them, but you cannot ensure quality to the end user. It can damage your professional image. It's a breach on privacy. It's a violation of personal and professional boundaries. There are licensing and legal issues. So social media is not bereft without disadvantages. So be very careful in using social media for your professional advantages. So then there are challenges of data management services. And when you talk of digital diabetes prevention program, it sounds very attractive and we all vouch for Dr. V. Mohan. I'll take only 2 minutes more. And this is the digital diabetes prevention program which Dr. V. Mohan said that there is paucity of literacy or diabetes prevention program at the periphery, and he started a program at the Chunampet Rural Diabetes Prevention Project model, and he used a car or an ambulance which had all sorts of devices, and it tried to educate people, and they did a survey. This was in 2006. So what happened? In 2006 to 2010, when this Chunampet Rural Diabetes Prevention Project was done, the prevalence of diabetes in that area was 4.9%, pre-diabetes was 14.6%, and the mean body mass index, your obesity index, was 21 kilogram per meter square. After 10 years, another study was done in the same area, and look at the prevalence, 13.5%, almost 3 times. Pre-diabetes increased, the BMI also increased, 25. तो हम लोग actually क्या है कि हम लोग अपनी आदतें सुधारते नहीं हैं. How do you believe that this digital platform is going to prevent diabetes? So it's not going to do that. So my Dr. Panda, try to understand that digital diabetes prevention program is not the answer to your problem. Your problem is making people, an average Indian, understand the complexities of diabetes management. The challenges are many. The EMR. So here you send a message, a voice message, and you understand that you'll get a very sweet voice from Tumhari Sulu. Kaise ho aap? And then you'll get all sets of questions. So it's not going to have adversities, economic adversities, data packs. पैसे खर्च हो जाएंगे तो बहुत सारे लोग रेलवे प्लेटफॉर्म पे अपना मोबाइल डाटा यूज करते हैं, हॉस्पिटल में जाकर डाटा मोबाइल यूज करते हैं कि पैसे कम खर्च हो. तो डाटा इश्यूज आर आल्सो देयर. हमारा भाई साहब का डाटा ही नहीं चल रहा था कि वो मेरे वीडियोस को चला पाए. So he was trying to save the data. Lack of structured systems, lack of trained personnels. So this is in a nutshell that despite the advantages, there's an issue. The obstacles are data divide, data privacy issue, lack of awareness, limited infrastructure and funding, lack of policy, and I must admit the center of this is Mr. Binod. So to me, it's too complicated for an average Indian Bihari. Koi shak. Thank you very much.
Time for the rebuttal. And
may I now request Dr. Panda to have a rebuttal? I will give you 2 minutes
and I think Amit has given the answer in the last. He showed a picture of a man in the parliament. Oh, probably, fortunately, unfortunately, he is the man who is leading the digitalizations, right? You were opposing digitalization, and he showed a man who is pro-digitalized.
Over to Dr.
Modi.
Panda.
नहीं,
So
शक है कि मोदी को दिखाया आपने. Now come down to Dr. Panda.
my good friend Dr. Amit has taken you almost 50 years back. So first question, you saw his turban, but anybody put such a turban with tie, suit and boot? That you can think that putting a turban in hand, putting a towel in head doesn't take you back 50 years. The glitch he is telling, glitch is there everywhere. If your patient develops hypoglycemia, he'll stop treating diabetes, and hypoglycemia is definitely something we have not intended. You have put a LED TV. Glitch is not something we have intended, but that happens. That's a part of the story. Non-health issues, if we are digitally active, why not extrapolate that in the health issues? If something is so close to our heart and it has entered our life day in and day out, why not put it for a very vital concern, that is health? Tele, I conduct tele for my diabetes patients, and people of Odisha who are 500, 600 kilometers away, in hundreds, are connected twice weekly by telemedicine to SCV Medical College, and they are so happy. They need not travel. Only thing, they need not travel. I am not telling any coma patients or sick patient can be taken by telemedicine. They have to attend their local hospital. But your follow-up patients, 99% can be very well managed by telemedicine. CGM, I am telling regarding the story that my good friend has shown you. The instrument has alarmed at around 60 to 70 to tell you that by early morning there may be a dead in bed syndrome. If in the middle of the night you are 63, if it goes further, so there is no meaning in alarming you at 54 or 44. He has alarmed you at 70 so that you correct your blood glucose, and by early morning you stay alive, because you know what happens in nocturnal hypoglycemia. And we know the rural-urban differences. Now, how many people you are seeing in airports, how many people you are seeing in the railway stations and bus stands? You know, the Delhi airport, there are more than 2,000 flights take off, and Mumbai it's 900, and Bangalore it's 1,200. And if you go to a airport, you'll feel like a previous railway station. People are getting smarter. It may happen another 20, 30 years. There'll be no concept like village. There'll be no concept like rural. There'll be no concept like backward, because everybody will be educated and everybody will be wanting to avail their best. And the dish TV and the motorcycle is a must if you go to the nearest slum. People are in the slum encroaching the government land, but every home you'll see a dish TV and a motorcycle inside. Why? They want to evolve. From motorcycle they'll go to car, from car to they'll go to bungalow, and they'll evolve. And it may happen that digital will sweep out all conventional and traditional methods, because intelligence is smartness. You use iPhone, you use computer, you use latest technology in your clinic. More intelligent you are becoming, more evolved you are becoming, you are getting more smart and using the best in your practice. And I should not listen, my friend, quoting the quacks and the diabetes healers who are 100% non-scientific. We are talking something ahead of the generation. We are not talking the false promise to our patients. And regarding the failure of Dr. Mohan's study, that is because of non-following the lifestyle. That is not because of the digital methods. And that is very common. We know how many of our patients walk 30 minutes a day. It's very difficult to convince them. And if you see a prescription or a message digitally or verbally, what will work for lifestyle, perhaps you can better remind your patient to walk by telling for a regular lifestyle, by smart means than the conventional means. So the same Binod will change to Mr. Binod, Dr. Binod, Professor Binod, and then further. And he'll ask you, why not best of the technology for this man at this end? Why it is for the people in the cities and the metros? So, ladies and gentlemen, the future belongs to digital era. You may accept, you may not accept. In your life, the artificial intelligence has entered every field, and in our medicine, in our hospital, in our practice, it's going to enter. If you are not being able to accept in this generation, you'll see the next generation working only with digital means, with artificial intelligence and technology based interventions. If we keep that, we'll survive or will be rejected from our field. Thank you for your time.
Dr. Amit sir's rebuttal.
Now the final words from Dr. Amit. And then Ravi will have some comments.
Thank you, sir. I must admit that Dr. Panda exceeded defeat by quoting his last word that you may not accept me, but in future digital is the way forward. So the question today is it too complicated for an average Indian today? So the context is not future, the context is present. And the context is not behind, the context is not past. Sir, we are sitting in an AC chamber in a medical college, the best and the best of the society. Just walk outside this campus and you'll see rickshaw pullers and thela pullers walking under the shade, living under the shade with this turban ahead. So this turban is not mine. It has been borrowed from Mr. Binod. Mr. Binod, I don't find any problem in calling him Mr. Binod because he's wearing a dhoti and a ganji. He is still Mr. Binod. So the context is today. The problem with digital technology is it's too complicated. It's too inaccessible. And it's too difficult for an average IQ person to understand the complexity. I can challenge and I can vouch that for a person sitting in a village, he is not going to talk to a doctor. He'll come to a line or to a medical college and see his patients. We see 200 patients in an OPD. From where they're coming? We have a e-Sanjeevani app working in all civil hospitals in Bihar. Despite that, the numbers are not falling. It tells you the exact true story, what's happening across the state of Bihar. If telemedicine would have been successful, the numbers in e-Sanjeevani would have risen high rather than it would have gone down. As of now, in 2023, it's too complicated, but I must admit that the future lies in telemedicine, teletechnology, applications, but it needs to be modified. It needs to be made friendly for an IQ person, very low IQ person. For a person who would be, it should be comfortable. It should not have the glitches of all the graphs and the complexities of glucose management indicator. And I forgot Dr. Panda didn't tell the GMIs. Okay, so that's all I have for today. For me, I still believe that managing diabetes on a digital platform for an average Bihari is still a complex thing to do. Thank you very much.
Thank you. Both of you have done justice in the current era and in the future perspective. Now, देखो समझौता भी हो गया. जजमेंट के पहले समझौता इसको बोलते हैं आउट ऑफ कोर्ट सेटलमेंट. तो ये आउट ऑफ कोर्ट सेटलमेंट हो जब हो ही गया तो हम लोग दो जज यहाँ क्या कर रहे हैं पता नहीं, कोई फायदा नहीं है. But I will have a few comments, and the comment is that when my respected speakers are standing, I should also stand with my chela on my left side. The thing is this, that in the current perspective era, we need to be digitalized. This digitalization should not be that complicated as Dr. Kulkarni always says. Right? If you follow one of his talks, he is talking almost like Chandrayaan. So we don't have to go to Chandrayaan, everybody can't reach over there. The percentage difference is there, 6 to 7% rural population and 11 to 14, 16% in the urban. This is the different setups. But the overall percentage, the people living in the rural areas are definitely more. So with the advancement of the knowledge, with the advancement of the technology in between, we have to infuse it. So मध्यम मार्ग है, जो बुद्ध का मार्ग है, जिस क्षेत्र से हमारे प्रोफेसर एन राय सर आते हैं, वो मार्ग बेस्ट है कि यार जो समझते हैं उनको डिजिटल पे ले आओ, जो ज़्यादा तकलीफ में है, जहाँ ज़्यादा हाइपोग्लाइसेमिक एपिसोड्स हो रहे हैं, जहाँ डायबिटिक कीटोसिस की चांसेस ज़्यादा हैं, दूर दराज क्षेत्रों में उनको फ़ायदा दो, जैसे आपने कोविड में दिया था, उनको एडवांटेजेस बताओ, छोटे मोबाइल से ही बता सकते हो कि मेरे को कॉल करो, प्रॉब्लम बताओ, मैं आपको बताता हूँ, टेक ए ग्लूकोमीटर, टेक ए मोबाइल, एंड आई थिंक मोस्ट ऑफ द थिंग्स कैन बी मैनेज. बट फॉर एन एवरेज Vinod, I think the Vinod will be converted into Professor Vinod one day, and the pagdi now should be jara niche kar le guru. Thank you so much. The final comments from Ravi.
Congratulations, Dr. Jayant and Dr. Amit. You both have really did just to the subject, and I must conclude that both of you are winners, and I know Dr. Amit, he is the man who has started a digital clinic at Mazapapur. Am I right, Dr. Amit? Yeah, okay. What I want to say that we should prohibit or we should ignore or we should discourage over digitalization in a very quickly manner. I must say knowledge should be penetrated socially. So slowly, when we will improve our awareness and knowledge, then we can accept to be digitalized, because digital life is very close to heart. Thank you, sir.
Thank you so much. Just wanted to let everybody know the general body meeting is going to be happening right over here.
Before the judgment has already come, just I would like to have comments on this debate, because for many days I asked Dr. Jayant Panda to have a debate. So he chosen the topic. Yeah, he chosen the topic, and so yes, and the essence was blending science with art of medicine. This is the theme of this conference, and so he chosen the very right questions, the very right topic. The artificial intelligence is the science today. And what we talk, the conventional medicine, where the love is there, human values are there, that you have blended. So this is the blending science with art of medicine. So we have succeeded in that debate.
तो अब मुझे पता चला कि ये मैच कहाँ से खेला जा रहा था.
Ajit, LED wall बंद कर दे. Just to let everybody know that the GBM meeting is going to be happening right over here. Right now, the scientific comes to an end. It concludes. At the same time, we've got the gala dinner as well, and the cultural event, which is going to be happening by 7:30 just outside. So everybody is requested to please be there. I am also going to go change and come back at 7:30. So requesting all to please be here for the GBM as well. Be ready. 1 घंटे में GBM meeting इनका हो जाएगा और then we'll start. So I hand over the mic to.
We should come back at 7 o'clock, assemble there in the open hall. That's open hall, yeah.
So we now handing over to Dr. B.K. Singh for the sessions, and the secretary, you can come over here.
And I'll see you at 7:30.
नवनीत, अब आप लोगों का हम लोग अब नीचे चले.
आपके लिए कुछ लाया.
Good evening.